doesn't need any introduction. He's started this BAPIO program, and I'll let you.
Thank you, Gajanan. I don't need introduction, do I? I do, actually. And my introduction is my pride, this organization, which was started 25 years ago. And the fruits and the work we have done, you can see today. Good morning, ladies and gentlemen, and the guest of this August gathering, John MacDonald, the chairman of the University Hospitals of Leicester. John, it's great to have you with us. Guys, you know, the talent amongst what is called LED, locally employed doctors, and the chair of this conference, Shubhangi, said there is a crisis of identity of this group of doctors. You can see what has happened here today. It's magical for me. This organization, this conference has been organized by LEDs, for LEDs, and is being carried on and is being carried on by the LED doctors. Shubhangi came to this country only a year ago, and you heard her speaking. Do you think she is talented? Yes? What a talent. And this is representative of all the LED doctors. And you can see in this one, there are some nice pictures. And it's not just beautiful doctors, but they are called LED doctors, which is a shame for NHS. Why they are not in training? Why they are not called registrars? Why they are not called consultants? This is a problem. And what BAPIO is going to do is this. The Charter for LED. BAPIO has been doing a lot of constructive work over the years. And you would have seen that we have got the documents like Bridging the Gap. We have got special work done for doctors who have been bullied and harassed, which is a big problem. So the conference today is going to utilize all the resources that BAPIO has. You will see that the Faculty of Leadership and Professor Geeta Menon is here. We have got BAPIO Research Institute and Professor Indranil Chakravarti is here. We have got BAPIO Training Institute and Professor Parag Singhal will be here. I don't think he's here yet. We have got the nursing organization and Mr. Kumar, the chairman of BINA, the British Indian Nurses Association, will be here. We are using all our specially done work over the years being utilized for the LED doctors. We also have Medical Defense Shield. And Dr. Satish Matthew is here and Dr. Grover will be here. Now, Medical Defense Shield was established because our doctors were not getting proper attention and support by existing established organizations. So we started Medical Defense Shield about 11 years ago, which is supporting doctors. Finally, I must say, and Mr. Gajanan here has already said, that BAPIO is for diversity and inclusion and equality. We work with all different organizations. I'm glad that here we got representation from MANSAC, the Nigerian doctors. Thank you, Dr. Obo, for coming. We have got Pakistani doctors, we have got Bangladeshi, Nepalese, all different nationalities, and we welcome. So although there is Indian name in BAPIO, it stands for everybody. We believe in equality and we can't not support equality. With that note, where is the thing here? Normally all BAPIO conferences are opened with lighting the lamp. And I was just saying to John the significance of lighting the lamp. It is bringing in knowledge in the darkness of ignorance. And this is a normal Indian thing that we do all the time, that we ensure that we know that there is knowledge, but we need to bring in more knowledge. Now, normally we light the lamp properly, but Marriott has problem with fire hazard, so we got the technology here. I hope it works. Oh, there we go. Although two. This signifies the inauguration of LED conference, LED National Conference. I now invite our chief guest, John MacDonald. I was just having a chat with him. Of course, you know he's the chairman of this wonderful institute called Leicester Hospitals, University Hospitals, one of the best trust in the country, which is very ably chaired by dynamic John MacDonald. While I was chatting with him, I realized that his ancestors came from the beautiful Isle of Skye. And if you visit Isle of Skye, as you enter there, you will see a bust of John MacDonald there. John, it's a great pleasure to have you with us. I must say that from my point of view as president of BAPIO, it's a pity that we haven't had very close connection with this wonderful hospital trust. But it's never too late. We are going to, this is the beginning today. We are going to have very close links. We will be working with the trust on equality, diversity, and inclusion, but also all our specialty branches, whether it is training academy, whether it is research institute, whether it's faculty of leadership, whether it's nursing institute. We will be working together to assist the trust and to assist the staff of this wonderful institution. With that note, John, I welcome you to say a few words. Thank you very much.
Good morning, and thank you very much for inviting me. I'm really honored and excited about being here. But before I do so, I just want to sort of disillusion you. Normally, speakers like this are people who are experts, who've got a national reputation. I don't have either the expertise or a national reputation. I'm here to listen and to learn and to understand, and I'm really looking forward today. I think we've got to be clear that equality of opportunity doesn't exist across the NHS. The first step in this is to acknowledge that. Just a few examples from Leicester. The University of Leicester recently did a survey of some of their trainees, and the conclusion, as said to me by Professor Robinson, was that there was one course but two experiences. And I think that sums up very much that we need to think very carefully. And we're a really important part at UHL of delivering the training for doctors, etc. And I think what we've really heard today is that those things are felt even more clearly by yourselves, locally employed doctors. Some of those disadvantages and some of that inequality seem strongest in this group. Now, we see that in career paths. I've talked to people who have almost given up of thinking that they're going to get to the next stage of their career because they've applied so many times. And that's not right. If you look at our senior leadership structure, while we do have people from all communities, the number of people from ethnic communities and others, as you go up the leadership structure, reduces. That's not right, particularly when we're living in a city where over half the population are non-white. We also need to think about the consultant awards. Again, we've done some work, and this has been done nationally, and it shows that as people go up, and it's not just about consultants, actually the pay and rewards are not equitable. So it doesn't really matter which aspect you look at. We have to think carefully about doing things differently. That's not to say there aren't people who don't flourish. Professor Kunti, who leads our diabetes service, is a national leader in this and has been recognized as such. So people can get to that, but it's just much harder for them. Does this matter? Well, I think it matters for a number of reasons. First of all, there's got to be a moral obligation to treat people fairly. But less altruistically, there's research which clearly shows that a more diverse organization is a better organization. It's a more effective organization. There's research that's come out recently that shows that people from certain communities and women actually get worse care than white men in a number of areas. So this can only be addressed by having a workforce which really does reflect and which has a major say in how care is provided. But we've also got to give people confidence that if they do come forward, they'll be given an equal chance. They'll be given the opportunities, because for many people, they're asking the question, if I put my head above the parapet, will I actually have those opportunities? And we have to give people the hope and the confidence that that will be the case. So what are we doing? I'm just a few things. I think the first thing is to recognize and to commit. And as a board, we have committed to that. We have a vision that, particularly given the population who live here, we want to be seen as one of the leading organizations in this country in terms of giving people equality of opportunity. We're reviewing our leadership development and supporting people at a much earlier stage so that people who haven't had the opportunities to get into those positions will be given opportunities to have leadership training, leadership development, leadership opportunities at a much earlier stage. Because if you look and you move up through the leadership, as I said, it gets increasingly less diverse. And that has to start much earlier. I think we also have to look at our policies and procedures, how we recruit people, how we make decisions. One of the things, and this will be news to Claire, the Director of HR in the room, I think we should be doing is we should be putting in inequalities impact assessment in every single decision we make, actually to make sure that we're making decisions taking those into account, just as we need to do with an environmental impact assessment and the whole green. That's not something that's widely done, but I think that if we're going to take the right decisions, we need to be doing things like that. We've got to develop the leadership right the way across, because it's not just about what the board says, it's right the way down through all parts of the organisation. And we've also got to give people permission to call out things which are wrong. There's a non-executive director on our board, Balu Patel. When I talk to him about Leicester, it's like getting a history lesson in Leicester, it's fascinating. But I've said to him, you must call me out if I say something that you think's wrong. And so far, I think he's called me out 3 times in the last year. So, you know, people like me will get this wrong despite my commitments. And we need people to say, that's not right. And that needs to be said and accepted and thought about carefully. So those are some of the things we're doing. There are a lot of other detail which I'm not going to go into because I've only got a few minutes. But just to say that I said at the beginning, I was here today to listen, to learn, and to understand. There's one other thing I want to do. I want to steal your ideas with pride. So I'm looking for lots of ideas from you all today, because my commitment is that we will lead a trust, that we will make a trust to be one of the places which is at the forefront of addressing equality and diversity for yourselves and indeed for people across the organisation. Because in 2 to 3 years' time, I want all of you to be knocking on our door saying, I want to come and work at UHL. Thank you very much.
Thank you, sir. I would now request our Conference Secretary, Dr. Parveen Dodamani, to please hand over our token of gratitude to John MacDonald.
Thank you, everyone. Now we we'll begin the first session for National LED Conference on Health Education England's strategy provide equal opportunities for LEDs. Yeah. Good morning to all the dignitaries and delegates present here today. I'm Dr. Lakshman Somashekar, a LED doctor from University Hospital of Leicester. Welcome you to the first session. I would like to extend a cordial welcome to the chairs of the session, Dr. Anshu Dalaria, Consultant Pediatrician at Leicester Hospital, East and North Hertfordshire NHS Trust, and Dr. Sneha Bisht, Junior Clinical Fellow at Northwick Park Hospital. I shall now hand over the session to the chairs.
Thank you, Dr. Lakshmish. Warm welcome to everyone. Let me just start by introducing our panel members for the first session. We've got Dr. Chris Agbo, Consultant Renal and Acute Medicine. He's a President of Medical Association of Nigerians across Great Britain. Then we have Dr. Harsha Gowda, Consultant Neonatologist and Tutor for Junior Specialist Doctors at University Hospitals of Birmingham. We have Dr. Parveen Dodamani, Internal Medicine Trainee at University Hospitals of Leicester, and Dr. Anindya Bhomik, Junior Clinical Fellow, Neurosurgery, St. George's Hospital, London. I would like to hand over to Dr. Delaria now.
Good morning, Leicester. It's such a pleasure to introduce our first speaker of the day, Professor Geeta Menon. She's a postgraduate dean for South London, but personally, a very warm and welcoming person, always has a smile, and it's great to have her presence this morning for the lecture note. Thank you very much. Can I just add, we won't have Q's and A's after Professor Menon's talk. We'll straight go to the panel discussion. And then I've been asked to make sure that we are on time with the session. So it's a great start, and we'll keep up to the time. Thank you.
Yeah, but it won't unless the slideshow. It's on slideshow. It's coming on slideshow over here.
It's on the slideshow.
That one.
Slideshow on the screen.
But this is a slideshow. No, so it's not showing the screen. You want to see the next one. Yeah. Because
Yeah.
What happened? Oh dear. It's come on the screen. Okay, it doesn't matter. I'll just...
Well, it flicked through. It should be going. It should be going, guys.
I hope it goes.
Is your
to the
clicker
next
working?
one. No, it's not
working.
working. It's not working. It's the clicker's not working, you see. So.
I thought for a sec.
Should we just close that one as well?
Yeah, let's just reopen it.
I think the slideshow is not going to stop.
Which one is it?
This one, final LED top. It should work now. Have you closed the previous one? Yeah, it should come up right now.
Yeah, perfect. Thank you.
There you go, guys.
Sorry about that. Hello, everybody.
There you go, working.
Good morning to all of you, and thank you very much to the organizers for inviting me today. I thought I'd start with why is it I'm passionate about working for the locally employed doctors and making sure that they have a good experience. That's because I started my journey in this country as a kind of a locally employed doctor, you could say, because in those days you could get an SHO job just employed by your trust. So it's kind of what you're experiencing at the moment. I came to England the first time all on my own because my husband and son could only join me a month later. It was quite horrific because I came in the autumn. I remember I landed here in September, end of September, so the days were getting shorter. And I used to be a consultant vitreoretinal surgeon back in India before I came here. And here I started off my job as a senior house officer. I must say that, I led a really sheltered life in India. I had a chauffeur, I had a cook, I never had to open a bank account, never even knew how to do it. And suddenly I was then landed in this country where I had to not only open a bank account, I had to find a house before my husband and son came here. And the memory that stands out for me is that finishing work at 7 in the evening and then rushing to the payphone to make that call to talk to my son and waiting for those pound coins to finish because it used to be a payphone at that time, and then getting really upset that I didn't have enough pound coins, didn't hear his voice enough. So I think that is why I'm really passionate that every one of you in this room should have a much better experience, and if each and every one of you tries to make sure that the people following you also have a better experience, we can make that level of change that we are trying to do this over here in this first conference. So we do know that international medical graduates actually are the second largest group of doctors employed by the NHS, actually constituting 30 to 40% of the junior doctor workforce. And why is that? This is because of the demographic change that has been happening in the NHS with part-time working, job sharing, the fact that, 2014 and 2016, UK saw that there was a 9% reduction in the EU doctors relocating to the UK because they now had to actually take an English language proficiency test that they didn't have to before. So that actually brought those numbers down. And you still have doctors in training who want to actually come out because they want to take a step back before they join training again. So all of this has led to a real increase in the international medical graduates. And if you look at this room here today, most of the locally employed doctors are international medical graduates. The locally employed doctors actually face multiple challenges, adapting to that new culture, language barriers, unfamiliar training systems, the medico-legal framework, work duties, and skills. So these challenges actually then affect performance, career development, and as well as, most importantly, the well-being, and then leading to patient safety. So LED doctors find themselves in that unprepared space where they're exposed to independent, unsupervised work. Remember landing here, and my first day in clinic, I was told I'm looking after the emergency eye clinic, so I'm an ophthalmic surgeon by background, and I was having a clinic of 22 patients, plus there was this phone constantly ringing with GPs trying to contact me or the optometrist trying to contact me, and I had no clue what I was trying to do in that space. I was lucky that I had a very nice nurse with me who basically said, okay, Geeta, this is what you need to do here. This is how we actually get this medication. Sometimes minimal prior experience and training on how to work in this environment, no formal assessment of the competency level or knowledge of the local systems that they come with, and no standardization of an orientation program for locally employed doctors. What then? Oops, what happened? And what has happened over the years is it's always gone into that too difficult box. because locally employed doctors are not one category. There are different categories of locally employed doctors. There are people who actually are trainees who come out of training programs for a year, the F3 year. Then you have doctors who have done core medical training or core training and then come into the country. Then you have doctors that come in who have done a postgraduate training in their home country and then come here to join the NHS. So, because they don't fit very nicely into one box, there's a multitude of people in there. People have put it in that too difficult box, not ready. But I think it's high time we open that box now. The GMC did try to actually distinguish or try to get these distinct groups when they did a big piece of work saying, what do we know about specialty and associate specialists and locally employed doctors? And they decided to put them into groups based on their career choices. So they put them as periodic SAS and LEDs, career SAS LEDs, and recent SAS LEDs. Now, what do they mean by that? So the periodic SAS LEDs were people who were young UK graduates mainly in the early stages of their career who either started their training program and then have taken a break or joined the training program after a break. And it's a really short term, so it's only 2 to 3 years that they are actually in that space of what is an LED doctor or a fellow, etc. Then you have the career. This is the second group of doctors. They're typically slightly older, mostly international medical graduates, do not enter the training program sometimes during that study period. So which is, you're actually need to, most of the training programs have this clause in them that if you've done 18 months or more in the area, then you can't join ST1. And at ST3, you have 36 months gap, etc. So they can't enter the training program. And then you have the recent or the third group of doctors, again, mostly overseas, young overseas doctors who are licensed for 3 years or less. So they could still enter the training program, or they could decide that they want to actually take a step back and just do the SAS LED role because that's what fits their work-life balance. So this was, either way, whichever category they fit into, they actually need to have a good induction program. Now, this was something that was really lacking. There were parts of the country that did it really well, parts of the country that had no such induction program. So the IMG induction program was then spearheaded by Mala Rao. Unfortunately, she's not in the room today, just now. She has gone out, I think. So Mala Rao actually brought in all the different groups of people that were working in this space to develop what was called an International Medical Graduate Induction Program. So she gathered feedback from all the IMGs about the experiences of starting work. What was it that people needed to actually start work in the NHS? And this was very varied. They highlighted the no assistance of working within the UK, setting up a bank account, like I said, no support in understanding policies or organizational structures, etc. So this program is this document is now a guidance document that sets minimum standards for a trust induction program. So each and every one of you can now go to your trust and say, this is the program that they need to actually deliver on. So to set out what the induction should include, this should be accompanied not just by a one-day induction program of the trust induction. I'm not talking about that Statman training bit. I'm talking about how can they actually do the mentoring, supervision, buddying, etc. And this document actually explains, the induction is vital and it's necessary for these IMGs that are new to the NHS. And also provides links to further learning related to the induction. There's also on language, communication, professional practice, etc. The most important bit of this document is the pastoral elements of the IMG induction. So here they're looking at the 5 key elements of pastoral induction, which is making new doctors feel welcome on arrival, assisting them on basic matters and practical matters, placing them within that social professional peer group, pairing them up with a buddy, somebody who's already started before them, getting feedback from them to improve the induction and ensuring they all have clinical supervisor and a mentor. So then going back to the basics, these are the basics that everyone needs. And I go back to Maslow's triangle. So Abraham Maslow was a psychologist. And what he said was that for people to be motivated to get to where they need to be, they need to actually get their 5 basic skills, which is physiological, safety, belonging, esteem, and self-actualization. But he said something really important. He said that if they did not actually start with the lowest end of that hierarchy, you'll never get to the top. So if you don't have your basic skills and your physiological and the safety and the belonging addressed, you can never get to self-actualization. So that is why it's really important to get the basics right. So I'm going to give you a couple of examples of what people have done. So Epsom and St. Helier Hospital, their medicine department had chronic poor GMC surveys. So they there are 2 district general hospitals that were combined with a combined medical bed space. Majority of their locally employed doctor posts remained unfilled because of the culture, the way they were being treated, etc. And there were rota gaps. And so year on year, it was like a vicious circle. You had bad surveys, still bad surveys. And there was an increased reliance on locums. Again, not enough to actually do that. So they developed...
We have 5 minutes remaining.
Yeah. So they then went into what's called the recruitment or the intervention. 2 grades of IMGs, less experienced doctors that had their UK licensing, and the group B, which was extensive home graduates. And what they did was they gave them supernumerary placements, receiving close supervision, mentoring, pastoral, etc. So if you see, look at this infographic, it shows you that week 1, they had their buddy, mentor, clinical supervisor. Week 2, they were supernumerary on the on-call rota. Then by week 6, they were assessed to see if they actually were eligible to go on the on-call rota before they were put on the rota, or if unsuccessful, then they were given another 2 weeks of more supernumerary and to become eligible. King's Hospital has also got an overseas doctors development program, and here they actually look at the needs of the IMGs and then decide what is the training they need to receive before they start. And this is some of the things that they have actually done in the space of the teaching and learning activities. So to conclude, actually, innovative strategies to improve recruitment and retention of locally employed doctors have been taking place, but very much in a sparse manner. Structured programs for IMGs that are naive to the NHS, leading to clearly signposted, smooth, safe, supported transition is important. And this group of doctors actually do feel very unsupported and underappreciated. So we must do all what we can to provide a basis for their successful career. I also wanted to add that previously, we used to have HEE looking after the future workforce, which is the trainees, and NHS England looking after the current workforce into which your locally employed doctors grouped into. However, there's now a transition or a merger that's happening between Health Education England and NHS England. So this is a prime opportunity where we're actually going to be having unification of the current and the future workforce, and so merging service with training. So how can we actually get this right? This is the correct point at time when we can do it. So we now developed a steering group that, with the right stakeholders, to develop the strategy to support locally employed doctors at different stages. And some of them, like I said, may want to not move on from and want to just end up being an SAS doctor, which is great because you at least have national contracts and you got something to work with. And if you're a locally employed doctor who wants to move into the training program, how can you be supported to do that? Trust should make effective support and development of LED doctors an important aspect of their people strategy. Only then can you actually hold them to account. So you need to actually make sure that this happens, because it's not just the benefit of the LEDs that this is for, it is for the benefit of the doctors and their UK-trained colleagues as well. As Gandhi says, strength doesn't come from physical capacity, it comes from that indomitable will. So we need to actually take that forward. Thank you.
Thank you very much, Professor Menon. It was all echoing when you started off with your story, because many doctors here would have been in the same situation. So thank you very much, Prof. Menon, for enlightening us with the challenges that LED doctors have got. Can I now request the panel members to please join the dais, please? Thank you very much.
CJ.
Where is it? This one.
Prof. Menon, can we ask you to come on stage as well, if you don't mind, just be part of the panel member. Thank you. So we are now opening the floor for questions for the panel. So the topic is Health Education England Strategy to provide equal opportunities. So if you have any questions from what the speaker has just had a talk about, or if you want to ask any questions to our panel members based on the topic, please feel free. We'll be having members who will be coming up with the mic, so do raise your hands so that we can help have a healthy discussion. Start off with our president of BAPIO, Dr. Ramesh Mehta.
Geeta, thank you very much for fantastic explanation. We are really pleased that you are Health Education England. The problem we have had with HEE, although they are very keen to collaborate, is a lot of policies, a lot of good talk, but no implementation. How are you going to ensure that what you said just now is implemented? Thank you.
Thanks, Ramesh Bhai. So actually, that's why I said, we need to have the right stakeholders in the room. So HE on its own wouldn't be able to do it. And like I said, locally employed doctors currently sit within NHS England because they are the current workforce. So it's getting all the right people in the room so that we can leverage some action. And you know me, I have to get things done. I don't actually leave things half-baked. So yes, it is going to happen now that I've taken it on.
Now, Geeta, you have been extremely helpful towards international medical graduates and LEDs. This question is not directed to you specifically, but it's to Health Education England. You know actually that when you helped us with a discriminatory advertisement put out by the Health Education England, I have to explain this when when Health Education England puts out advertisements for training grades, sometimes they are openly discriminatory. And Geeta did help us. And what do you say actually? That still happens, Geeta. What do you think about it, and how do you think we can make it better?
So I think that now, because more than before, after Black Lives Matter has actually raised, the fact that we need to make sure that all recruitment processes actually follow the equality impact assessment. So that is something that they are now strongly following in the ways that they actually, work in trying to make sure that that diversity is not affected and people are not discriminated against. I don't know whether...
Thank you very much. I think we look at it from different perspectives. Health Education England and the fact that we're here talking about locally employed doctors has already brought a level of inequality. And what we're looking at is actually how we can provide an equitable training program for our locally employed doctors. But what we're doing is trying to create a space where we say we have diversity, equality, opportunity, and all that. But if we employ someone from outside the country to work in a trust, it's already an unequal opportunity because someone else is already working in that trust that's probably trained here. So we start with that premise. What we are looking at is actually addressing that Health Education England is having an equitable employment opportunity for our doctors so that if someone is coming from outside the country, you don't treat the person the same way you treat someone that trained here because that's the only way we can actually make progress. If we are sitting here talking about equal opportunity, diversity, we're going to sit here 10 years' time saying the same thing. What we need to look at is actually being fair, being impartial. If I'm doing a training program, I can't do the same thing for someone that did his medical training here and started as an SHO, and someone that's coming from India or Nigeria or Pakistan as an SHO. You are putting both of them at the same level. That is looking at it as equal opportunity. But is that equal? No. But what we're looking at is actually bringing up a strategy that's equitable. So if you know that this person is coming from overseas and he has these deficiencies, we need to fill up that deficiency before we put them at the same level. But what is happening, I've been here for 17 years and I came in as locally employed doctor, as they term it now. But the opportunity had never been the same. The treatment is still not the same. So what we are looking at is not just equal opportunity. We are looking at how to bring a strategy that specifically caters for this group of doctors so that when they sit, they'll be able to actually achieve about the same. There's no point saying, okay, I'm bringing induction program for all the junior doctors employed in this trust. And you are telling them the same thing, and some people don't even have a clue what you are talking about. Some already can go with it because they know what you're saying. That's not equal opportunity. So we're talking about equitable opportunity. We want equity in our distribution of services training program for our IMGs. So those are the things that we actually need to redefine, not just equal opportunity. We have to talk about what we are doing. Is it equitable? Are we talking about this additional support that we need so that this person that's coming with this deficiency meets up with the peers? So those are the kind of things that we expect the Health Education England to be looking into alongside with the NHS England. Thank you.
I was going to ask, we have a couple of locally employed doctors here. What have your experience been from, have you had any support from Health Education England at all?
Thank you very much. It's an honor to speak in such a distinguished panel. So from my experience as working as a locally employed doctor in the past, nearly about 2 years, I've been, I think, grateful about the support that I've got from the trust, but there are some discrimination points that you see. What happens, mainly because the trust-grade doctors are employed by the trust, not the deanery. And the expectations that you have in support-wise of teaching or training that you always don't get from the trust. I was grateful that my trust had specific trust-grade doctors teaching sessions, which many trusts don't have, which is only available for Foundation Year 2 doctors or IMT1 or CST co-trained surgical trainee doctors. And there is kind of an expectation when you're working in the wards with them. They ask for the time off for the teaching. The registrars usually go for the teaching time off because that's mandatory for their portfolio, and we don't get that time off. And that hampers our teaching quite a lot. And then when we go to fill up our teaching time, we don't have that time of teaching there. So that's one of the issues, I think, because it's trust regulated and not incorporated with the deanery itself. These are some of the issues that's there. And some of the experience that I've got from the feedback from some of our colleagues as well, like these drawbacks actually cause them to think about what they want to train in. Maybe their basic interest was in one specialty, and once they feel that they can't fill this up in the portfolio, that detracts them from the field of a choice, which was primarily for them because of the support. So I think if we can ensure a centrally arranged support, maybe in the deanery which has the trust itself, if they can incorporate something like maybe for the trust grade doctors, we will have an annual curriculum of that many teaching hours, that many presentations, or that kind of seminars that they want to attend. Maybe that can help. Thank you very much.
Hi, thanks for that. I work in Birmingham Heartlands, part of University Hospitals of Birmingham. To answer to some of your issues, in UHP, what we've done is we started a program called the JST program, that is Junior Specialist Doctors. We started around 5-6 years back. So all the locally employed doctors come under this umbrella. I think over a period of time, it's a big number. We're totally around 550 doctors of the JSTs among all the 4 hospitals in Birmingham. It's a one trust. So what we started around 4 years back is we started a separate teaching programs for JSTs. That's 1 full day every month, and they have to be released. The department has to release all the JSTs for this teaching program. We started on Friday, so we don't want to clash with the deanery or the foundation teaching programs. And recently, after COVID, we started recording this teaching as well. In case for JST, for some reason, can't attend the teaching, it is recorded. And we also made sure that department give a day leave as well to attend the teaching. So we made some significant changes in the teaching program for the JSTs. And also, it was a big push from the trust as well. And also, as a tutor, we have to make a lot of changes, make sure that, JSTs get a good amount of study budget, study leave to attend all these teaching programs. And also other point you've told is about annual review. We do all the annual reviews for all the local employed doctors end of the year, so to see that how they're progressing in their career, and also give some career guidance. This is separate than appraisal. This is not the appraisal which is required for GMC. This is just annual review of their training, how they're going, and also to see the progress. And the next thing, what we introduced recently in our trustees, we started the CSER program. I know some of the trustees already doing the CSER program, but we started centrally doing this from the trust point of view. So we identified around 8 departments. The departments are willing to support the CSER program. So the department will chalk out all the curriculum, what they're required to do. But the trust point of view, what we started supporting is management training, leadership training, and leadership courses program, and help them to attend all the divisional board meetings, so that they can get a good management experience as well. So these are some of the changes we're doing at UHB. But what has happened now is JST numbers are so big, we started doing some internal rotation among all the 4 hospitals in Birmingham. So they're getting a good training experience as well with teaching and the training. They are I'm hoping that in the next few years, they will be getting the CCT and they can become consultants as well. That's what our long-term dream. Thank you.
That is fantastic, Dr. Gowda. With all the implementation points that you've given and best practices that you've highlighted, I think many people will take it back to their deaneries and to their trusts, and then they can implement that further as well. There are other questions from the audience that I'd like to take. Professor Rao, yes.
Thank you so much, Anshu. Well, first of all, thank you, Geeta, for a super talk, and especially for the shout-out to the International Medical Graduate Induction Program, to which so many senior leaders from BAPIO and elsewhere have contributed. And so thank you very much for that. One of the things that I began to encounter quite frequently during its development was people would say, what about the private sector? And we can't resolve the issue of the private sector this morning or indeed in one day. But the private sector is playing a pretty significant role in providing healthcare now, particularly those bits that are being outsourced, care that's being outsourced to the private sector, and the recruitment of international medical graduates to the private sector. And I gather it's become extremely rapid from Nigeria, Chris, less so from India at this point in time, but that'll change because these are block recruitments going on from the Department of Health and NHS England. I'd be interested to know whether there are any plans by NHSC, HEE, Geeta, to bring the private sector educational opportunities and so on into the fold, because we do contract with them. So quality there should matter. And if you've got anything to say from the particular MANSAG point of view, Chris, about how this needs to be resolved. Thank you.
Thanks, Mala. Actually, it's really interesting that you brought the independent sector. One of the things that we actually came across was when we were developing the imaging and the endoscopy academies. And that's when we realized that there was the independent sector that we could actually use as a bridge to make sure that all the consistency across the piece happens. Like you said, there are a lot more international medical graduates now going into the independent sector. So it's the small piece of work we've started in HEEs with the academies, but I think we need to have a lot more. Like I said, once the transition of HEE into NHS England happens by April 1st, 2023, then we'll all be one organization. So it is not as if we are working on two sides of the platform, and NHS England is very much in that independent sector space as well. So I think that would help us a bit more.
Thank you very much. For the private sectors, it's quite a different setting. I did have some meeting with some of the medical officers that work in these private sectors, and their terms and condition of services different from NHS, and those are some of the things we have to look into, because when I was having a meeting with some of the group that came from Nigeria that are working in those private hospitals, I think their work conditions are quite different, and these are some of the things that Education England should look into, how we can actually monitor what is going on there. That's one. And for us as an association, how do we support this group of people that are there? Some of them don't actually know what they are meant to do the next 6 months. So I think it's important for us as an association to look out for these ones. They come in, they are different, they are usually lonely because they come in, they don't have any, they just tell them that you live in the hospital for 2 weeks, and so it's just very different kind of setting. And it's, for me, having meeting with those ones just give us a different aspect to, there's a large number of doctors in that category which we need to look out for and see how we can actually, support them in terms of their career to make sure that they're learning what they're meant to learn, and at the same time, making sure that they're not just there to be used for service provision. I'm just going to come back to what one of the LED doctors said. I think as trusts, some of the trusts have done few things about trust-grade doctors, locally employed doctors, and that. But one of the things I want to also tell each and every one of you, and for those ones that are young, you have a great opportunity. When we came here years back, it was very difficult for you to actually get a training post. So if you're coming in, don't just assume that you're coming in as a locally employed doctor. You should have your career goals. Aim to get to a training post. That should be your end point, and the opportunity is far more better than what it was 15, 20 years ago. So I think it would be unfair for us not to actually open that discussion. If you are employed in any trust as a locally employed doctor, you should aspire to get into a training post, regardless of what specialty you want to. I think the NHS and the society as it is now has a greater opportunity than what it was 15, 20 years ago. So most trusts have clinical supervisors attached to these doctors, others don't. But it's also our responsibility to make sure that, which is what Mala is doing now, to have a unified induction program so that when they employ these doctors, they have specific agenda for these doctors. They don't just employ them to, you come in, we do have that in our trust. You see some people coming in from Nigeria, Pakistan, India, and the next week they are going into on-call, and they don't know their left from their right. So for our trust, we've said that when they come in, they stay 1 month, and they get assigned under a consultant to supervise, and that will be a supernumerary post. They'll be paid for that. And until that consultant says that I think this person is confident enough to take up on-call duties, then they can be signed off. But some trusts actually bring them in within a week. They do this very sketchy induction, and the person is thrown into the service, and you find out that those are things that we actually struggle a lot, because those members end up having issues with GMC, the regulatory bodies. So it's important that we have a unifying body that can actually cater for this? Thank you.
No, thank you very much. I'm just going to take two more questions, one from Prof. Chakravarti and then Prof. Singhal, if that's okay. I know there's a press on time, and the rest of the discussion can happen just in coffee, if you don't mind. So two more questions, please, for the panel.
Thank you very much. I'll be very brief. I'll mention two things. One is, there are two words here, which I think that we need to be careful about. One is deficiency. Chris, excellent work that you've described. But I think that if we approach this as a deficiency in the particular group of people who are coming, then we're continuing to perpetuate the problem that has always existed, which is that there's something less in them. And the second bit is about discrimination, and they are very linked. So the minute you do that, the second thing comes in, that they are different and they are treated in a different way. Although the work that you are describing in Birmingham, for instance, is great, but it's still going to perpetuate that dichotomy of two types of doctors, one who are trained properly and the one who are trained in the alternative way. And I think there is a time for us to rethink this again in a radical way, to actually break down those particular things. So yes, we are doing some excellent work trying to support that, but we are still perpetuating the problem. I would suggest that we replace deficiency and discrimination by diversity. And I think diversity and being intelligent about diversity, recognizing the strengths that people bring from 200 odd countries that people come here from, and taking that as a strength rather than as a deficiency would get us to a much more equal platform. Thank you.
Yeah. That's really excellent comments, Professor Chakravarti. Over to Professor Singhal.
Yeah, just one thing, Indranil. I think that's really important, and which is why Chris's point that every locally employed doctor, if they wish to do that, should be trying to get a training post. Because, that's where that's the goal that they should be trying to achieve. Yeah. And for that, they will need to have the support, whether it's in country like Parag's work, or whether they come here and get that support.
I've been alerted that I have to stop. I'm really sorry. Prof. Singhal, do you just quickly want to comment something, and then, and then we'll finish after that.
So my point links with what Indranil just said. I struggle with the term locally employed doctors. All the doctors who have yet to achieve the status of independently working should be treated as trainees, and the term should be replaced by locally employed trainees. You have to give them status of training.
Thank you so much. Thank you very much. And before we finish, can I felicitate Prof. Menon for her presence and the rest of the panel. Thank you very much.
Thank you so much, everyone. Thank you. We've been an amazing interactive session. Let's keep the energy flowing in the sessions to follow. And let's take a short coffee break now. Let's come back at 11 o'clock. Thank you so much. Thank you.
Just to let everyone know, our posters are being presented in the foyer where the coffee is being served. So I would invite everyone to have a look at all the lovely posters that have been put up by delegates and poster presenters. Thank you very much.
I also request everyone to kindly fill the pallet scoreboard provided in the bag before the leadership workshop begins at 11:30. Thank you.
Can we bring the next presentation?
1 minute.
Okay.
Let them go. Just don't want to drain the batteries.
That's enough. Wait a minute.
So this will be right back to how it was in a sec after the break.
Yeah, we keep this one minimized always.
Yeah, for sure.
And the other ones we can, the finally just close that one.
Cool.
Go to
I'll
your
get rid
mail.
of this guy as well.
Yeah. Send it to your mail, inbox.
Have you sent another one to me? Yeah.
Yeah. I think refresh it. No, if you refresh it, I think it will come. Yes. Sorry, sorry, I missed it. Should be coming. Let's send you.
Telling me lies.
No, I didn't send you because I send you and myself both a copy.
That's okay.
Wait.
Yeah, not coming through on my phone either.
Let me see. It's not come to me too as well. All right.
Where have you sent it?
Oh, all right, over here. Can you do one thing, please? Can you open the downloads for me, please? Yes.
Can I open what, sorry?
How many do you have? Yeah, it's it.
Which one is it?
Let me see,
Is there any of these?
no.
Cool.
Unless it's been given a random name. I named it with today's date.
No, your presentation is already here in the desktop on the keynote sessions.
Ah, cool. Just put these over here so I know where I'm at.
If you go inside, it's the keynote session 2.
This you'll have this will be replicated on here, so you'll have your notes on here if you've got anything. So we're just swapping screens over some issues this morning.
Brilliant.
If you want to go
and
through
is there a clicker?
There is a clicker.
Marvellous, because
One of you guys got the clicker still?
Yeah.
Perfect, thank you.
Just a small one. So Mr. Irfan, President, he will be introducing you and requesting you to go on with your session. But he just wants a bit more about your bio, but we couldn't find it.
Oh, do you not have it?
Just 1 or 2 lines other than...
So I have been working in the NHS for 25 years. I work at the SARCs, Sexual Assault Referral Centres.
Sorry? Yes.
RC, sorry. And joined the GMC 11 years ago. And
so you're a SARC member or?
I support survivors of abuse at SARCs, and then, but my job now is predominantly at the GMC.
Your clinical.
And there I'm head of our outreach service.
Okay, perfect.
Yeah.
Okay, all right. Thank you.
Okay.
Atif. How are you? Assalamu alaikum.
Atif, really good to see you. Ramesh. No, we have made good time. So you came on your own? I came mentioned because I was all different organizations. And we have always said that although Indian name is taking part in the name BAPIO, we are equality, diversity. We work with all and we collaborate.
BAPIO has extremely generous and kind, giving a very generous donation.
Yeah, left one's on, right one's on.
Exactly.
I think things which unite us are bigger than this.
Exactly.
And people who try to take minorities think up.
What's the march? So this will be the Egyptian.
Something with it as well. So that's what I keep thinking. You have been given that opportunity.
Right, 4th of March. I will be absolutely delighted because I'm very keen.
You know, you started all the things.
No, thank you.
So we too are all.
So Egyptian.
You did Manchester. When you announced it by you.
That is Southeast Asia Regional Corporation. Yeah. No, I think I'm going to say just check over again and technically how
Flexible. Treat them as adults. You know, you don't have to problem. As long as they finish their work for the day.
Okay, it's in now we should be just so you know our annual conference is in Cardiff this year in November. So I'm sure you got the invite.
Yeah, because we're doing it at the same time with the Bima as well, the one Islam doing the same day. So it's not good, you don't have to coordinate. It's one thing. And you are very
And then the Bima is doing the same day in London, while you are doing in Cardiff. So we thought about it. So I would rather like it to bring it to summers. Problem, you know what the problem is? Summers. I don't know about Egyptian, but Indian and Pakistani, they run back.
No, you can get in June before the school finishes. I go to one in March.
Yeah, that's good.
So,
and Easter holidays are good.
So because I would like all of you to do the same day.
Yeah.
So in March when we go to I go to the few months. So if you can organize it, and we do every 2-3 months meeting.
Yes.
Then you can go for it. I'm not for 1 month. Go
every meeting. That's a good option.
Yes, so those are the questions
Just drop me a text and I'll put it in my diary. And 12th of November you must. 12th of November you must. It's not from here, it's Newark. It's about 20 minutes from here. Between here and Nottingham. And it's a beautiful place. You will enjoy it.
They're actually list the organizations like HE does.
So I do
in the same way. We want GMC to
So I take it as and then we know that.
This will be one of the topics for our panel discussion.
No, we have to do a few more things which we have to do.
Everyone, if you do want to have a meeting, then you can all of us go for it. You cannot go for
I think it is based on people holidays and all that.
So you do for Ramadan.
Yeah, inshallah.
Ramadan is in the March.
Is it finishing 22nd?
Start 22nd.
That's what I'm saying. It's going to finish in April because this was April and May this year.
We're doing before that.
Oh, it's good because people will not go for Eid. You know, because a lot of people go to Eid within Pakistan.
If you do your May, June as well.
Yeah.
No one go home because it's good for
So I think because this place which you have taken out, you will love it. Beautiful. Oh, you should. There is a bazaar, there is a CND, there is a very big ENT going on. Massive ENT. I will tell you what is on the ENT. It's still being formulated. This moment is how to create international fees, education platform, you know the master class.
Yeah.
So he's going to talk about master class. ENT training in UK. These are the like of ENT training. So this is purely, we have got 10 different sections going on. Yeah, they're entirely different. And there is one girl, Asad Qayyumi, is Peterborough, Peterborough. You know him, yeah? Yeah, Asad. And Nishad Qureshi is with him. Asad Nishad Qureshi. Yeah, so both are good. And then he's going to come, the wheel is going to come and talk about cocktail implants. And then primary unknown consequence differentiation. And then rhinoplasty. That's Ahmad. So he's going to talk about. So ENT is about 2 hour session, which is going to be separate. And then you will have poster presentation. And if you have anybody junior, like
या फिर यहाँ पे बैठ जाओ
you know, like there are 2 students who are going to come and say, how can I enter plastic surgery? Plastic surgery is doing that. So how do I enter the orthopedics? So, you know, you all see the people are sitting. Oh, yeah. So it's a big session. And then at 5 o'clock, GMC and plenary session. 12th.
Okay. You have to register because I know.
Yes. But if you drop me an email, I will register you. But I will send you an email. I will send you. ENT, prostate, medicine, which has got 3 specialties, surgery, which has got 3 specialties, ophthalmology,
The first thing I told you, I did not know GST.
You have to introduce it. Why is this here? First. Oh, that's this the chocolate cookies, no? Yeah, I think letter slide be there. No, we need the main slide. Yeah, main slide is there. It's always there. So I just need to change it. Yeah, just change it, and this one goes left and right. How do I start, man? Huh? How do I start? No, you need to wait for this thing. Not working. Let's just get the main screen. Can we get the main screen off here? I'll introduce the chairs and I'll start. Who's coming? Is the microphone on? It's got so this. CJ will do it from there. They're sorting this. It's not working. Ananda, it's not working. Parveen, the mic is not working. Are we setting up the mic? Sorry. Can you also say that? Okay. Okay. Before we move on to the next session, could I request everyone to fill out the leadership ballots that would have been given to you? That'd be great. Thank you. So, good morning, one and all. My name is Praveen. I'm one of the e-learning module leads in BAPIO SS LED Forum. I'm the joint secretary for this particular conference, and it is my pleasure to crack on ahead with the next keynote session. I'm a clinical teaching fellow in Chelmsford Broomfield Hospital. So I've been with BAPIO SS LED since the COVID times. They've helped me with everything, so I'm really grateful for that. So I'm going to introduce the chairs for this particular session. It's Mr. Irfan Akhtar. He is the president of APNE. He's a consultant general and endocrine surgeon in Nottingham, and also he is the clinical training program director for the clinical fellows at Sherwood Forest Hospital. And we have our next chairperson is Dr. Faryal Sahi. She is a trust grade CT1 in medicine at University Hospital Leicester. It is my pleasure to welcome one and all again, and I'm going to hand it over to Mr. Irfan now.
Thank you very much for this introduction. I must congratulate BAPIO for taking lead once again into a very, very useful topic, which I think is dear to so many of us, and I think it's brilliant to have that many people to have a chat about that. Without further ado, I would like to call Ms. Tista Chakravarti-Gannon. She heads the outreach operations at the General Medical Council, and she is going to talk about a very important topic of ensuring locally employed doctors are supported to provide patient care. Thank you.
Morning, everyone. Are these my slides? Whilst we're waiting for my slides, great pleasure to be back with you, my BAPIO family. I have to say that I have spent so much time with you this year, haven't I? So I'm delighted that you're not sick of me yet. But I think Ramesh just tells me where to go when I go there. But I am particularly pleased to be here today at this inaugural LED conference, because this is a group, you are a group that I think have not had the recognition and respect needed for far too long. And to know that you have BAPIO's very considerable weight behind you, I think is a very, very good thing. So brilliant to be here. So what I want to do today, I'm going to talk through a few key areas, explore some of the challenges that we are aware of at the GMC, explore some of the resources available in terms of ensuring that support for locally employed doctors. And really, I want to call for action as well. I've been speaking with colleagues for a little while now, and we really feel that there is a momentum building. There was a time where we'd talk and talk and talk, but this is the moment to turn the dial. So that's what I really want to focus on throughout what I cover today. But before I do that, just by way of brief introduction for those that I've not met before, and this is also quite important in terms of the support available to you. So I've been in and around healthcare for 25 years now. I work, and still do, but only about a day now, I work in the SARCs, the Sexual Assault Referral Centres, with survivors of abuse. And it was doing that work that got me interested in how, when we don't support our professionals, our clients, as we call them, or patients more broadly, fall through the gaps. So that support for professionals, that importance of the partners in the system working together is absolutely critical. So when the GMC, just over 10 years ago, asked me and another colleague to set up a support service for doctors on the ground, I jumped at the chance. I thought it was a really progressive thing for a regulator to do. It's not something that any of my MDT had seen before in the team. Given my interest, I wanted to really build that. I remember one of my first events when we were fact-finding, so meeting doctors on the ground to understand what support was needed. It was a few weeks in, and I was introduced onto the conference podium to the theme of the Imperial March, Darth Vader's theme tune, for those that don't know. And they'd actually embedded it into the PowerPoint as I was walking onto the stage. And that moment crystallized for me just what fear we beheld in. And of course, we're thought of predominantly in fitness to practice terms because it's about livelihoods. But as I learned more about the GMC, because I didn't know that much about us then, and as I learned about all our statutory functions, as shown there, it became really clear to me that standards, that's the fulcrum of what we do. And I would argue, actually, much more important for patient safety, in many regards, than fitness to practice, because the really serious fitness to practice stuff applies to a minority of our register. And therefore, logically, but most importantly, to support colleagues to deliver challenging standards in an increasingly challenging time. Pre-pandemic, well, that's where we need to be. And leads me the first resource, if you will, and that is the outreach service. So this is a service that I now head up at the GMC along with a few other colleagues, and the bullets there tell you what we do. Wherever you are in the country, you have outreach advisors available to you. There are ones who meet with employers, and there are ones who meet with doctors. We provide teaching, things like that, and I think that bullet there, that final one, is particularly important because we're there to listen and hear what's happening on the ground as well. So, examples, when I used to do the teaching a bit more regularly myself, when I set the service up, examples that come to mind when one of my F1s told me that they were covering over the weekend and had 47 outliers in T&O and no support, and it had been raised before. That's something that we can then act on. There can be broader things as well that we can then act on. So in O&G, there's been a load of issues with discrimination. What can we do? Well, then we can step in. So please remember, as one of your first sources of support, the outreach team. Okay, all details are on our website. And that support for me, I think, is particularly important for local doctors, and our focus in outreach, we need a good portion of that focus to be to support locally employed doctors. Because what we're trying to do is epitomise upstream regulation. Essentially, the idea, there's a load of academic theory behind it, but I'll keep it very concise. Essentially, the idea that you provide support early before colleagues and patients are harmed. And I think this is particularly important for locally employed doctors because, well, why? Let's start by looking at recognition and looking at some data. So last year, 62% of GMC registrants coming in to the register, I should say, last year, were international medical graduates, okay, or internationally qualified. 70% of locally employed doctors are internationally qualified. Now, those data, that second bullet, that's from 2020, so I expect that's actually higher now, okay? And if registration continues at this trajectory, then by 2030, and this is, for this one I've aggregated, I'm afraid, locally employed and SAS colleagues, but by 2030 you will be the biggest part of the medical workforce. Okay. You bring your skills, your dedication, your compassion to patients here. Yet, until very recently, where are the programmes, the charters, the support for retention? And I think that point is particularly important. I want to draw our attention because employed doctors are the ones most likely to relinquish their licence to practice. Without the support, without the right environment, leave. All of that, and I'm delighted, therefore, that we are having this conversation. Some of the initiatives, that come about. I'm glad that we are finally getting there because the time to turn that dial is well overdue. So that's the imperative, if you will. That's a burning bridge, and I want to move now to look at some of the challenges. This word cloud here, I've drawn this, or pulled it together, from our survey of locally employed and SAS doctors from a couple of years ago. But what I've focused on in this particular word cloud is the locally employed doctor experience, because the data was disaggregated. Okay. There are some positives here. So 67% have said that they had positive, supportive environments. That's great. But, you know, the flip side to that is a third of our locally employed doctors do not, or reported not, have a supportive environment. We've already heard from colleagues about lack of access to training to CPD, and that's one of the big highlights, unfortunately, or lowlights, I should say, in the report. No SPAs, limited CPD opportunities, not getting that time release. And the really big one on top of that, again a third, but nearly a quarter of our locally employed colleagues have reported bullying and harassment. There is real differential experience, as this survey showed us, as it demonstrated. So for me, that is one of the key challenges that I drew from the survey. I'll come to another one a little bit later, but in terms of that first key challenge is that experience of incivility that so many colleagues face. And some of you will be aware of the work of Civility Saves Lives, literally. And I use the word literally with impunity. There is a strong evidence base around this. If you are subject to that incivility, this is what can happen. If you witness it, this is what can happen. And of course, as well as harm to colleagues, there is harm to patients as well. Okay. So this is the big thing that we need to tackle. And where does the GMC fit? Now, of course, we work in a continuum of professionalism. That's the...
Chakraborty, we're left with 2 minutes.
2 minutes, yeah. We work in this continuum, and the GMC's role here is to set the standards, but the employers have a responsibility to ensure that these are delivered. Now, in terms of standards, I don't think we do go far enough just yet. So the new GMP, I want it to be much more robust in those standards. And what I want us to focus on, rather than the fitness to practice, because by that time it's too late, it needs to be earlier work, is holding ourselves and our partners to account. And if these two reports, we started that journey a couple of years ago, if these two reports were implemented, these are some of the findings from them, then a whole swathe of those problems that we've seen, those challenges we've discussed, they would be addressed with one fell swoop. And my team can help do that if we hear about the problems. So there's a final key challenge that I'll cover very briefly. This list, what do you think it represents? Statman training, most people say? This was actually the gamut of my friend's induction when she arrived from Sudan. That was it, nothing else. You know, where's the Maslowy stuff? Where's the support? But I won't delve into this, but there's more lived experience here, and in fact some of this was from the work that we did with Marla. Absolutely appalling examples. Okay. There are interventions in place. Welcome to UK Practice is one of your other sources of support. We know that it works. Please access it. But we need more, as Geetha said, the Maslowy stuff.
Sorry, left with 1 minute.
And we have that induction in place. Okay. As Geetha's spoken to it, I won't cover it any further. And there are other resources on our website. But to wrap up, we've looked at the key challenges. We've seen what resources and levers are available. This is my final call to action. We've talked about recognition, but what we also need to talk about is respect. all too often I hear locally employed doctors described in deficit terms, and Indranil was talking to this earlier: non-trainee, non-consultant, non-SAS. Let's define you by who you are. Diverse colleagues who need to be seen, heard and served. So in this room, those of us with power, let's collaborate to make it happen. Thank you.
Now I'll request my panel members to please come on the stage for some discussion. We have panel members as Professor Mala Rao, OBE, Senior Clinical Fellow at Imperial College London, Medical Advisor to NHS England's Workforce, Race Equality Strategy and Vice Chair of Water Aid UK. Next we've got Professor Sujesh Bansal, Consultant Anaesthetist at Chester University and NHS Foundation Trust. Dr. Vik Raj, Foundation Year 1 Trainee, University Hospitals of Leicester. Dr. Jerry Varghese, Internal Medical Trainee, University Hospitals of Birmingham.
Thank you very much. I know you have a short time, but very elaborate talk. Before I open it to the floor, any comments from the panelists, and then we can start asking questions on the presentation.
Hi. Thanks, Tista. I completely agree with you that despite of like more than 50% of the new registrants being international medical graduate and majority of them going into locally employed doctor post, we're still lacking the support which they require, as well as the cultural change. We really need a cultural change in not only in the organizations which they are being employed, but in Health Education England and other regulators as well. Thanks. That's all. Being in focus.
Anything else? If I may, please. You want to say?
I just also wanted to thank Tista for an excellent, I think a wonderful summary of what the current challenges are. And I like the fact that your call to action asks for a redefining of who this group are. They're not this, they're not that, but actually what do they bring? And redefining that group so that it brings back that value and then a proper understanding to us all as to who this group are and who are the sorts of people who might be interested in applying for those posts in the future. And I think that's where we need to begin.
Well, I think I'm an FY1, and being the junior most person in this panel, it's quite reassuring.
Equally important.
It's quite reassuring that this sort of dialogue is actually happening. I studied in Ireland, and the switch was quite steep and different for me as well, because the system is different. And I realized that it's not about the knowledge, but it's about applying that knowledge in this system. And when I came here, the GMC had courses and all, helping us bridge that. And I think that's a wonderful start. And we've come a long way, I'd say, from trying to integrate doctors from abroad into the NHS. And it's important for us doctors as well, from the bottom level up, to have that sort of communication and have that going, because people at the top need to know what we need so that they could do something, if that makes sense.
So thank you very much, Tista, and thank you for putting it so elaborately with the numbers. And I couldn't agree more. I always knew about it, but being the program director for the last 2 years has opened my eyes. And I'm running a program which is bigger than the foundation program of the Trust for doctors. And I must say that majority are coming to expand their careers, to excel in their careers. And it's painful to see that if you do end up in the program, you're 7 or 8 years, it's about 15 years. And I think if you get that. So I think that is something which GMC look very seriously at. We are 1 in 10 is still empty. So this is how we have You've got such big force with that. So I will open it to the floor. Any questions, please?
It's a pleasure to be here. About some of the big things that hits the junior, well, I shouldn't say junior doctors anymore. HEE is saying we should refer to them as postgraduate doctors and not junior doctors. So there needs to be a culture shift there. But then when it comes to the portfolio, they're not used to the portfolio, but they have to engage with that portfolio, and if not, they're going to be struck down because all their assessments, the ARCPs, everything relies on that. So what sort of extra support do LEDs have in terms of how is HEE? It's great that he and NHS England is going to merge, but what sort of support is going to be available for LEDs in terms of engaging with the portfolio and not being made to feel like they are second-class citizens? Thanks.
I could take that.
Thanks a lot. I think it's a very, very important question about, of course, many international medical graduates are not aware of the requirements like e-portfolio and especially the specialty portfolio as well. So that's why it is very, very important for us to make sure that the education supervisors and the infrastructure we already have in the trust and the HEE are sensitized about the needs of the locally employed doctors and the international medical graduates. So like in the guidance, IMG induction guidance, which we have produced, does include a IMG checklist as well, in which it is very, very clearly mentioned about the e-portfolio that when the LED meets their education supervisor for the first time, that discussion happens about the portfolio. And then of course, not everything can be done on the first meeting, but it is about then the responsibility of the education supervisor to kind of provide them support. And I personally, when I meet my locally employed doctor, I can't, or I won't have time to provide them every support. It's about them directing them to engaging them with the right infrastructure, so making sure that they network with the trainees or the other peers, and that basically strengthen them and make them more confident about using the available resources. Main thing is not to create additional infrastructure, is to integrate them into the infrastructure which is already there.
I will just expand a bit onto that with some local experience. So when junior doctors come, well, postgraduate doctors come, there are a lot of challenges for them, and one of them is financial too. So many portfolios from the Royal College are from the Horace, there is money attached to that one. So what we have done for our trust is that their first year's study leave expense goes into that. So everybody is given a portfolio straight away. So they are aware of it, and then they start working on it. And that's part of that. The other thing which we have done, which gives them a little flavor of working in NHS, is that their ARCPs, which they are all subjected to, replaces the appraisal process as such. So that helps us too much in two ways. A, that they get their appraisals sorted out, but more importantly, they get a feel of what the trainees are going through. And there is no difference between the way they are assessed, are supported, are promoted, anyway other than the local trainees. Thank you.
Good morning. Just to introduce myself, I'm Mr. Sankar, I'm a consultant plastic surgeon. I'm also Leicester Asian Doctors Society's chairman. I would like to thank Ramesh Bhai and the team for organizing a wonderful event. The reason I came for this, I've seen three parts to, I belong to three different groups. I was an overseas doctor to start with. I was a trainee for a period of time until I get into the registrar job. Then one of my senior consultants, I'm talking about late 90s, told me that I'm an overseas doctor, therefore he would never let me write the FRCS plastic exam. So that made me jump ship. Thank God I came to Leicester. Leicester had a wonderful system. The consultant who was here, who was my peer, and he said to me, "You are a consultant material, you should be aspiring for it." First, you need somebody like that to motivate you. Then we talk about what HE can do, what the postgraduate can do. It's more about what, as a doctor, as a LED or SAS doctor or a non-consultant, what we can do to make it. I think that's what's driven me. So I looked at the portfolio of all the trainees, what they do. I would try and duplicate that. Yes, I may not have time to do it. I may not be able to do everything, but I will try and duplicate it. In my career, what I tend to do is at least 2 presentations, 1 paper every year. I go for 1 management meeting. All those things will help you to career progress. Now, if we include that in the portfolio that we are going to create for LED doctors, that's what we need to be looking at. And for that, we need a good mentoring. Every organization needs a good mentoring. Program directors are great, education supervisors are fantastic, but the mentor who could be able to go and give a slap at the back of the wrist saying what you're doing is wrong. The one other problem we have, unfortunately, culturally, if I tell somebody what you're doing is wrong, immediately he or she can turn around and say, I'm bullying them. That's a culture we created. So mentor can avoid that, because as a program director, I've seen a number of times I can't go and tell people what they should be doing because of fear of the repercussion. To avoid that, you have to have a mentor. I think every one of you should have a mentor in your own specialty and latch onto that mentor and bug them. You have to keep bothering them. You have to be a chronic, persistent irritation. Therefore, they will make it happen for you. I think that's very important. Rather than we talk about how the organization can do it, each one of us take responsibility for it.
You want to answer that? Yeah?
No, Ananta Darby.
Ananta, yeah, Ananta is
I have 2 questions. One is for Tista, and the second one for the rest of the team, please. Tista, when I came to this country, they said the GMC does everything by the book. Correct? 100%. So why does the GMC propagate the title LED? It is an incorrect title because I am an LED, every consultant is an LED. We are all locally employed. And what they feel is that this title is added to the hierarchy, and actually it stands for locally exploited doctor and not locally employed doctor. So why does the GMC propagate an incorrect title? That's my question to you. My question to Will Neswaran and Jerry, what kind of an induction did you get when you came into your jobs? And then Mala and Sujesh could tell us what an ideal induction would be, because they've done a lot of work on this. Thank you.
So, Amit, I don't quite know how you expect me to answer that question. What should we be calling colleagues?
If you ask them, not even one of them has a similar title to the next one.
Yeah.
How can that be right?
This is it, and this is my point about not using that deficit model of the non-this, the non-that, and looking at the diversity. But yes, we argue, don't we, over titles for job roles in the NHS and have done for decades, and I think we still say SHO and all kinds of things. So I think it will be a while, but I'm very, very open to ideas. I'll pass the mic in a moment, but I also want to proselytise about the induction, working with this indefatigable team, especially Marla. Just picking up on the mentorship point as well earlier. Again, if everywhere implements this induction, this is the ideal induction because it serves the Maslowy stuff, it serves the mentorship, it covers all of that. So please hold your trust to account, use us to help hold your trust to account because we need to deliver that induction.
I think Ananta is next and then yourself.
That's it. We have a good induction.
Hello. The thing is that when I came to this country initially, we need to know the system, how it works. I think that's what everyone is apprehensive about. It's not probably the medical knowledge, it's about how the system works. So, and we were told to know that you need to go through the induction. So induction, when I came in just after COVID, unfortunately a lot of the induction happened in front of a laptop. So, and also it's quite appreciable that GMC is acknowledging that there is a significant amount of IMGs coming into their registry. They're trying to create programs and workshops, and just as Professor Dr. Bansal mentioned, there is a lot of checklist. But as a junior doctor, what I've felt is that despite having all these checklists and workshops, there is a very little effort to see how many people are signing up for this. I also saw in one of your statistics, you can see there is a lot of people who are being complained or registered, they are bullied and all. How many doctors over here know there is a lot of websites, and in your hospital, in your trust, there are options where we can escalate these matters to, and how many of them are using it? I'm pretty sure 80% of the doctors, including me, we know certain things exist, but the workload is sheer high that we work from 8 to 4. We just want to complete at 4 and we have to go home. No one even bothers or cares to take an effort to find where exactly how I have to escalate this, where is the wellness program, and how can I register this. So I think there should be an effort from the GMC, also from trust individually, to make sure that the doctors are complying. Not for namesake, there is workshops that people are actually attending it so that they can get feedbacks from it and they can improve based on this. That would be my input, I would say. Thank you.
If I'm going to be very candid about this, I might get myself in hot soup because my chief registrar is right there. But to be very honest, I started off with my medical placement, and I thought that induction was quite solid and it was quite organized. But coming in as a FY1, I don't think that induction was well put together. It was pretty rushed. It was quite last-minute information, getting emails saying that I've got to get stuff done one day before. And I personally don't think it might be a problem as an organization, but something local and how the HR and the trust kind of like run programs. But the good part is, feedback was collected. So the question now, is that going to be translated when the next cohort comes in, more time being given, if that makes sense? And I think 3 things which were very, very vital, which I learned during my induction, was that the culture here is about speaking up. Coming from an Asian background, I think sometimes we're a bit reluctant to speak up or question authority or people in an authoritative figure. Second, knowing what your role is and playing by that. So making sure that you know what you can do and cannot do. And lastly, just asking for help if you don't know. I think these 3 things have been very, very vital for me coming in. Yep.
Thank you. Is there a mic for Ananta out there? Yeah, please.
Hello. Firstly, thanks for a fantastic talk, Tista. It's been a wonderful session so far. I just wanted to, pick up on a point around how we actually bring about the culture change and the positive behaviors that people are talking about. And some wonderful suggestions have come through. But frequently we've seen that when something very significant needs to change culture-wise, it's also important to introduce an element of accountability and transparent monitoring or evaluation. Now, I say this with considerable trepidation because in the NHS, we already have a vast amount of, structure put around regulation, monitoring, performance, etc. So I say this with caution. However, because the experiences of LEDs, who are a heterogeneous group of, diverse group of doctors, are not captured by the usual or very unlikely to be captured, say, by the GMC survey, staff survey, REST survey, CQC inspections, all the usual mechanisms we have of picking up concerns, of acting on something and, publicly published information. Because that's not likely to capture the experiences of LED doctors, I think it perhaps is incumbent upon us who are trying to bring about change to put in some kind of a transparent monitoring and accountability on the part of trust managers, boards, etc., to see how they are specifically looking at the needs of LED doctors. It might mean some bespoke surveys, some kind of follow-up action based on the information collected, some kind of transparency and openness around this. And also very valid points being made about the difficulties in speaking up. So rather than putting the onus on the doctors themselves who are affected to change the system, because there's an additional emotional burden on them as well, apart from everything else that they have to face. I think the onus should be on the trainers, on the boards, and on the organizations. But again, working together with HEE and GMC rather than, trusts on their own. But I think something like that might be necessary to take us to that next step. Thank you.
Yes, yourself. Up here first.
Can I ask one question? I think Professor Bansal has been doing good work in the Northwest, MFT. I would like to hear from him what he thinks.
Maybe me. No. No. Anyway, I'll ask questions. I'm Satish Matthew. I'm a retired consultant medium. I retired 2 years back, so some of my knowledge may be outdated. Now, so when I was working, there was nothing like this portfolio business, nothing like this ARCP business for I call them LEDs. And you were actually talking elaborately about e-portfolios and ERCPs. Is it available now for these people? Is it a requisite for them at present? That's question number one. The next one is to TISTA. I know that TISTA actually probably is not the job of General Medical Council to provide support to these doctors. So let us say actually in your job, an FY1 trainee came to you and contacted you and said actually I am being discriminated against by my actually consultant, and she gave evidence to you. And in that regard, do you have a mechanism by which the GMC can provide them with support? If not, who should be providing with support?
I can take the mic. Thank you, Satish. So, Satish, thank you for the question. We felt quite overwhelmingly that the more we talk to the IMGs coming here, the overwhelming majority would like to excel. They would like to excel in their specialities and take up a consultant post. It's only few, for various reasons, would fall back onto non-consultant career posts. So there was an attempt that they get a taste of what trainees are going through so that it becomes easier for them to make better applications and build up their portfolios and then apply in the time. So there's a lot of learning in there. So when I started my induction program, I soon realized that, thinking that's very good, but the feedback started coming in. And the best way I found the feedback was joining in the WhatsApp group of, you would rather like to stay away from that, being senior, but once I joined them, they were talking about things which I never thought about. So that was very good. The other thing which really helped was we talked about proctorship, we talked about mentorship and pastoral support, but buddy support was an excellent idea. So you buddy with somebody who's been here before, and you join them in the same specialty, and that was wonderful. So it's a constant learning thing, and you keep improving on what you have, but it has to be in line with the training program.
Shafis, thank you for your question, and yes, we do have mechanisms to support. It depends on the particular scenario, but if someone was to raise something to my team in that way, then we can either intervene directly, like the example that I gave. We have a confidential helpline, so we have our own resources, but importantly, I think, is we are connected to a lot of people. So we will know people in the organisation, we'll know people outside of the organisation, and depending on the level of the concern, we can connect people to provide that support as well as do things directly ourselves. Okay. There were some questions around induction as well, and I'm keen not to lose that. So Mala Sujesh, I think you had...
Yeah, well, thank you, Tista. One of the issues about induction is that we've heard some bits of it. We've heard people mention excellent clinical inductions, a little bit of pastoral care,
you were talking about, getting people into the system and giving them an e-portfolio and then monitoring it as time goes by. We've heard mentoring and budding. I really would urge you all to look at the induction program, the published induction program, not because I think Sujesh and I wrote an amazing, piece and you should all be looking at it, but because it's systematic in that it has taken what you said in focus group discussions as the basis for constructing the program. So it's your voice in that program. And what we haven't heard is, for example, the importance of language and communication. There's a lot about pastoral care, and absolutely that's got to be the basis, setting up bank accounts. I was staggered to hear that there are IMGs worrying about where their next meal was coming from because they didn't even have a bank account 2 months after starting work. Now, this sort of thing has to stop. And there's plenty in there, but there is much more, such as IT systems that many of us find completely bewildering. Because, one focus group discussion IMG said, I quickly came to realize that if I didn't talk to a patient, it probably wouldn't matter. But if I didn't record it on the IT, good God, that might get me sacked. So our reliance on IT systems, language and communication in particular as it relates to medical communication. So there are aspects of induction which trusts must take the responsibility to look into and provide for their IMG. So I would urge you all to look at those, and the senior doctors in particular, challenging your trust to provide the resources for those things in addition to mentoring, budding, and so on and so forth.
Thank you. Excuse me. I just want to come back to the really important point on accountability that was made. Sorry?
We are running short of time. Can we please ask Dr. Bansal to make completing remarks, please? Yeah.
So very quickly, I think that it's really important that this gets on chief execs and chairs' agendas. And there was one really frightening statistic in your presentation, that in 8 years' time, more than half the doctors will be from this group. And yet we're not giving them the support and the training and the development. And that's a strategic issue which every single chair and chief executive needs to understand. And there's an offer here that if you want to work with a trust to help get on the various networks of chairs and chief executives around the country, then I'm sure that Claire, who's our People's Director, and Richard Mitchell, who will be meeting tonight, would be very happy to work with you to try and put this on various agendas, because I think that statistic frightened me to death, if I'm honest.
I think what John's just said is so crucially important, and I wonder whether BAPIO, Mount Sinai, they couldn't all get together and work with you on this, because there are questions running through my head, such as, even this discussion, although we've said it should, they shouldn't be defined as non this and non that, it still is veering to becoming the consultant as the end point. That's success. So the business of stopping at a grade somewhere between being a postgraduate doctor and a consultant is somehow seen as demeaning, and yet 70% of our doctors might be there. Have we ever asked, do people want to be there? Maybe they do. Maybe they do wish to be there, many of them. Can we create a cadre that's actually attractive? Distinguish what consultants do, distinguish what this group does, what postgraduate doctors do, and make it an attractive post. And make it flexible, that people can, 25 years after they've had a very fulfilling time as this, whatever we're going to call it in the future, then can seamlessly, shift into a consultant post if that's where they want to go, or even come back from a consultant post into this post at some stage. That defining needs to happen.
and this post needs to become attractive and something people aspire to as an end point. So I really want us to go away with that message from this. And so a challenge, I suppose, to you, Ramesh Bhai, and Chris and all of you, is to work with people like John and the system leaders to redefine what this group is. Thank you.
Thank you so much, Dr. Professor Malarao.
I'm just going to quickly jump in and kind of like add on to what Prof said. I think for my juniors, it's very important that we also interact and know what is out there, because there's no point there are policies, but we don't leverage that and know what we can use. So it's just something for us to think about. Thank you.
Thanks, Vicky. Could I request Professor Bansal to give a closing remarks on the session, please?
Thanks a lot. I think there's been quite a good discussion in this session, and what really is everybody's enthusiastic and there's a lot of good work happening around. But what Anand said is about making sure there is some kind of accountability, and if the organizations work together, involve GMC, HEE, I think that's the one which is going to bring a consistent change. Because if you look at the induction for the trainees as well, over the last 20 years at the trainee feedback, many organizations get red boxes for even the trainee induction. So you can't expect them to deliver a very successful LED induction unless until we make the organizations accountable for the induction. So I think it's about making sure it has been a good start, but engaging with the national organizations to make sure that the trusts are accountable.
Thank you so much, Professor Bansal. We thank the speaker and the entire panel team for a wonderful presentation and a thought-provoking discussion. Thank you, one and all. Now I'd like to request Mr. Akhtar to hand out a token of appreciation to Ms. Chakravarti. Thank you. Could I have the attention of the delegates and dignitaries, please? We've got a couple of important announcements to make with regards to the workshops and the oral and poster presentations. So the first announcement would be with regards to the morning workshops. So we've got 3 workshops, and I believe in the morning when you had registered, they would have noted down a couple of alphabets on your brochure. So if I could request all the delegates to take out your brochure, and you could find out that you might have the alphabets ranging from M1, M2, and M3. So those who have been allocated to M1, you'll be going to medical leadership workshop, and that would be at Tanner's ground floor. And a special mention that the moderators of those particular session would be guiding you to that particular room outside in the banquet area. So the next one is M2. It is the medical research. It's going to happen in this main hall. So I'd request all of them who's registered for that particular workshop to kindly be seated here. And the third one is M3, which is the medical education, which would be at Ashby Room 2, Level 1. So these are the workshops for the morning, and we've got the announcement for the oral and poster presentation given by Meena.
Hello all. I have an announcement to make regarding poster presentation. So poster presentation is going to take place during lunch break. I would request all the delegates to stay near your poster. So poster 1 to 12 will be judged from 12:50 to 1:10. Please stay near your poster as judges will score your poster. Poster number 13 to 24 will be judged from 1:10 to 1:30. And poster number 25 to 34 will be judged from 1:30 to 1:50. Please stay near your posters, and the rest of the team, please feel free to look around for posters as our delegates work really hard to present these posters. Thank you very much.
To add on that, so once you've done your workshops, you've got the lunch at the banquet area in the entrance at around 12:40. So feel free to come down to the banquet area. So now I'd request all the delegates and invited dignitaries to move on to your workshops. If in any doubt, please come to the dais. We will guide you through. Thank you.
Where is the thingy?
So tell them.
Where is? Yeah, very good.
What's the first? Would you need anything presented on here for the workshop?
Yeah, yeah. You can't get the screens corrected, right?
No, speak to Tom.
Huh?
Did Tom speak to you?
No.
Yeah, there's some reason that's like basically gone down, and we didn't have enough time to kind of work out why. So
Are you putting the PPT of Mr. Iyengar? Yeah.
You're good, yeah?
Sorry. Yeah.
Yeah, cool.
Yeah, just put them in the background. So you will just close the slideshow from there, and Mr. Iyengar's one is here. Morning workshop too. No, it's not workshop. Why did he? That's poster presentation. Okay, this is the one. This is Mr. Iyengar's one. BAPIO talk. I'm opening it, but not putting slideshow on it. No, don't. Yeah. I will close the. Which is this one? No, I'll do that. Don't worry.
Thanks.
Yeah. So I just need to go on that one and then put it on there. Yeah. Just exit this one and then put it on that one.
You know that, right?
Yeah, I know.
Delegates.
Yeah, I've told him. I'll get
Delegates for the leadership and education. Kindly
Assemble.
make note of the placards that's being held by the moderators, and they will guide them.
Yeah. Once more again, I would just like to draw the attention of all the delegates. Delegates attending the workshops in Tanner Room and Ashby Room, that is M1 and M3, are requested to take a look at the placards being held by the moderators or our volunteers to guide them to the workshop areas. Thank you very much.
You have the slides?
Yeah, everything is there.
Can you bring up the slides?
No, slides are already there.
Right, okay. Perfect. You're all happy, right?
Yeah, where is Ashish?
Yeah, other sessions. Are they here?
May I request Dr. Ashish and Dr. Preeti to come on stage to chair the session, please? Thank you.
I'll sit here. Who's helping us? They'll introduce us. More here. Come on. Come. After you.
Hello everyone, I'm Ashish Mishra.
I'm Preetu Anand. We are trustee doctors from Leicester Royal Infirmary.
And now can we please welcome on stage our next speaker, Professor Indranil Chakravarti, MBE, Director of Medical Education, St. George's University of London.
And next, Professor Iyengar, Honorary Professor, Apollo Hospital, Education and Research Foundation. Onto the stage, please.
Thank you.
So, good morning everyone. It's nearly afternoon, isn't it now? Yeah. Let me put a timer.
It's on. It's on. It's on. It's on.
Correct? Right. So, thanks to BAPIO and Gajanan, I should say, for inviting me here. Good to see you all here. I hope you had a good morning session. So my talk today is slightly different in that we don't look at academic publications and research in a more effective way like we do other bits. So let me show you my journey, and if you guys can take something out of it and streamline your future career, I would be more than happy. I would like one of you guys 5 years down the line standing here where I'm standing or where Indranil is sitting to give a talk similar to mine, and that would make me very happy. So the first picture here is a picture from the mountain top, but look at the paths around it. So if you can see the paths, you are seeing multiple paths there. So what I'm going to reflect on this talk as we go ahead is to show you that there is not only one path for success. You can have multiple paths, but in the end, it should effectively help you reach where you want. Be happy with your life, be successful in your life, achieve what you want. So it may be clinical, it may be paraclinical, but I'm going to show you my journey. A short introduction about myself. So, as all of us, I come from a place born in Chennai, but I studied all my post-graduation in Nagpur. Some of you may know. Currently, I work at a place called Southport. It's on the northwest coast of England. But the real reason I am here is for this side of the picture. So over the last 2 years, it's not showing up very well. Over the last 2 years, I have published nearly 150 articles in journals, 125 in PubMed, and because of that, my citation till yesterday is more than about 2,000. So why I'm emphasizing that? Whatever I have done or wherever I have reached till now has been all because of that. And over the next few slides, I will show you why I consider that to be important to me, what did I do, and how I did. So if you can take some tips and tricks out of it and streamline your journey, let's see if it helps you in the future career. So where's next? So these are my disclosures. I am on the editorial board and an associate editor of all 4 of these journals. So it gives me a unique perspective, not only author, because I submit there, but I judge nearly half a dozen articles submitted over a period of a month. So I channel them, I get peer reviews to review them and get a decision. Apart from that, I'm a peer reviewer. So I judge the abstracts here. So this gives me the clinical skill or the skills which I need to judge the abstracts. So this is a way I have learned myself. Before I go any further, I'm going to highlight one poem, which I find it very fitting. So this is a poem by a poet called Robert Frost. He published this back nearly a century ago in 1920. So he says, one day he was walking in the woods and he saw 2 paths, and that reflects us. So if you see there are 2 paths, one on the right and one on the left. So if you consider your path on the right to be as a clinician, like you, all, me, so that's the traditional path we take. But if you take a parallel path and walk on the left side and see where it leads to, it may be also important, it may be also educational, helpful in your career, and that can make all the difference. I'll reflect back this at the end of the talk. We'll see how it reflects or connects with me. So when we talk about academic publications and research scholarship, these are the traditional queries. Why should I do that? What should I publish? Or how should I go about it? So in the next few slides, we will see how we can work on that. So the core principles, this is a critical slide. I have made it myself. I think the 4 key pillars of all of your academic endeavors is, number 1, it should enhance or support patient care. That is crucial for anything. Any small amount of help while you publish or undertake research that helps to improve patient care is number 1. Number two, all your academic endeavors should help you in your gaining knowledge, skills, professional capabilities, and help you with understanding patient care. Third thing is, it should help with your appraisal and revalidation, which are all important for us. Most importantly and crucially, in the end, it should give you recognition. It should give an impact. It should support yourself, what you wanted to do in the first place. I have highlighted or connected these four things to the four main bodies that look after us in UK. It fulfills the four domains of GMC good medical practice. It fulfills the HEE professional standards. It supports the appraisal revalidation process. And also, if you want to become a supervisor, you need this evidence. So let's look at why. So I have highlighted these points, and all of these apply to me. And whatever I have achieved have been because of that. So we will look into each of this. Some people may have different reasons, but these are the reasons which apply, all of them to me. So if you look at the first pillar, number one, patient care. So when we do academic publications or research, you learn evidence-based medicine. Evidence-based medicine is the key to patient care. It leads to improved patient care. So what is the best way to understand or learn evidence-based medicine is to publish articles. So when you publish articles, you start reading about the subject, generate knowledge, put that into practice, and that will improve your patient care. Second, most important is it will increase the confidence in which you treat patients. So if you need a new clinical diagnostic test, you want to learn about it, you do research in it, work in it, it increases your confidence. The second pillar is knowledge, skill, and competencies. Most important is this is the hierarchy of research evidence which we use when we treat patients. All our clinical guidelines, NICE guidelines, orthopedics is BOST guidelines, depend on hierarchy of evidence. So every small bit of research endeavor, academic publication, forms a little bit of evidence so that they make the general evidence, and that's how you treat patients in the NHS. So the more and more you start understanding about research hierarchy, you understand how to critically appraise literature. You try to understand which evidence should I use to treat which patients. And this is all because of academic publications and research scholarship. Third, this is where are the points which will support your career as we go along. First important is you need academic publications and research endeavors for supporting your appointments. All of us here require that. And it's not only in India, it's also the same here. As you all know, National Medical Commission has rephrased its guidelines not only for appointments of doctor, but for promotions as well. And if you see the requirements, you need to have articles, you need to have them indexed. It doesn't have to be PubMed index, but you need to have a logical index in which they are published. Unless you get this now, I know friends in India who have done this. They don't get promoted, so they are looking for this. So if you get these articles in place, you get promotion. It also forms the basis of all of us. It's not for trainees, not for SAs, it's not for consultants. For all doctors in this country, academic publications and research forms a key component of GMC good medical practice framework. So we all should be doing this. Next, as you all know, you all want to apply for training post. My specialty is orthopedics. In my specialty, you can clearly say for your self-assessment scoring system, PubMed articles on the top right here, you score points. So you need to have that. And the best way to do that is over a period of time, collect it so that you score high. You need to have your QIP there. You need to have a complete cycle there. So publication and research forms an important element for your appointment. Most importantly, for all of you guys here, it is a part of your portfolio. There is no excuse for it. When you fill your CV or make your portfolio, what is a portfolio? It's a collection of all the skills you have. 1 page, 2 page should be that. One of the objectives or in the table of content should be research publications, academic endeavors. You should have that. So this needs to be a part of your medical graduates or postgraduates. This is important. Therefore, when you want to progress and apply for post further, it is important because we all need to complete appraisal every year. We need to get revalidated every 5 years. So you need to do that for all. This is the supportive evidence. This is a key slide. Take it up. As you all know, some of you would like to go through the Caesar route. This is also an evidence for that. And therefore, I would suggest that you look into that. For me, it has provided evidence for a number of things. For myself, I am at multiple committees. I am the only person from the trust or maybe from the Northwest who is on the JCI board for trauma and orthopedic surgery. So they just don't give appointment just like that. They need evidence. So when you have your publication record, when you have your H index, you score highly on those. I'm a member of the Faculty of Surgical Trainers. I became that 3 years back. There is a sheet of evidence that you need to supply, and that's where my publication gave the evidence. I've applied to become a fellow now. I will know later. Academic position, key. I became a professor April 2022. And why did I become? It was not just because of someone else saying that. My mentor, my EIC, nominated but the foundation wanted a string of evidence. I supplied it, and they happily accepted my application. I am an honorary senior clinical lecturer, both at undergraduate and postgraduate level. I needed evidence for that. I'm flying on Monday because I am a part of a nation which supports postgraduate training there. Most importantly, the reason I feel happier is I have mentored all my colleagues in my trust. I have at least, I remember 6 who have co-authored along with me on my articles, and they get the specialty points. Also, seniors, they don't have time, but I wanted to support them. They have name on in my articles, and that helps them in their appraisal and revalidation. Remember, they are also educational support. Most important slide to understand, why am I doing this? And that's H index. H index, if you consider publications as currency, H index is an equation that you get with productivity. So how much is the currency you want? But divided by citation, that is how much is the currency value, and you get a number. The higher the H index, it is helpful in applying for post, any excellence in awards. It is the higher the H index, the important it is. Therefore, it's not only the number of publication, it should be impactful. So the citation go up and your H index goes up. I'll show you some examples. So that's where I was back in 2016. H index was 2. I'm now 25. This is maybe in the top 5% of about 5 million authors all around the world. And therefore, whenever I apply, my H index is high. So they compare the H index across university. So as a ballpark figure, if you want to become an associate professor, you need to have an H index between 15 to 20. Anything between 20 to 40 is good for a professor. Anything more than 40, 60 is a genius. So I'm not there yet. But as I said, editorship. I'm an editor, associate editor in all 4 of these. Importance is, I started low. I became a board member because my H index was only 5. As I progressed higher, I have become an associate editor. Why do I do that? It helps me understand literature better. It's a responsibility, and I can progress towards higher achievement as I go along. Also, remember, the fourth point I mentioned is impact, recognition. How do you feel yourself? In the last 2 years, I with my Dr. Bochu is one of the greatest friends I have. He and me have got 3 clinico-radiological signs named after us. This was the first. What does it show? It shows the structures on the medial side of the knee. And we have made an algorithm how to assess that and named it after both of us.
Sorry to disturb, just one last.
Finish. So nearly there. Therefore, the second is similar like that. This is an angle. So what do I publish? Scientific articles are of 3 types. It can be investigative, review, or assessment. But currently, I would suggest if you want to invest in research articles, probably do in technology. And this is what I have done in 5. Now I will take 5 more minutes. Is the last one. Is that okay? 1 minute. So how do I do it? I'll run to that. Most important is get organized. Planning is the key. Get your basic competencies of all the certification. Learn about study design. Sign up for NIHR. Do your GCP. Get your ORCID number. Multiple resources available. These are from my journals. Learn about bibliometric. Learn about the art of manuscript. Learn about the art of writing articles. Have templates. Have structure. And then, if you don't want to know the anatomy, you can also get help from various publishing models and become using collaborative research and help from forums such as BAPIO, BIHR, or try to publish in BAPIO's journals. Help yourself in the personal development. And if I come to the last slide, I hope by the end of it, I couldn't tell you more, is at the end of it, I took a path on the other side, and I feel that has made all the difference. I feel, or I can encourage all of you, take a part, apart from your clinical work, a path in academic publication, and I'm sure success will be there. Thanks.
Thank you.
Thank you, Karthik. That was, I don't know how I would describe that. I was thinking as I was watching a very successful academic orthopedic surgeon speak, I was thinking of the bullet train. And I'm thinking, I can't stop this bullet train. He's got so much of achievement. But then I thought about sort of leaving the orbit and rockets and stuff. So what I don't want to do here is, obviously what you've achieved is pretty incredible. And for lesser mortals like us, I think it's very hard to get to where you have been to. So I think it's definitely inspiring, but I don't want us to be scared of the fact that, that you have to do so much to get there. I think the fundamental thing would be here is to firstly understand why we're doing it. And I think you touched on the point that the reason we're doing it is because we want to improve things for our patients. So I think that obviously is going to be the fundamental point. The only other thing I would say is be curious. I mean, one of the things that I did not learn when I was in medical school is to ask questions about why we are doing what we are doing. I just learned to follow whatever was in the textbook or whatever was in the guideline, and quite blindly. And only when you start thinking about why is it that we are making this decision, then you start to delve into the research behind it. And one of the fundamental things is that irrespective of whether you want an academic career, whether you want a sort of a starship career like Karthik has, or you want, if you want to be just a clinician who wants to do good for your patients, you have to understand why you're doing what you do. And to understand that, you have to go back to the basics. You have to see every decision that you take on a daily ward round or your daily clinics, you have to know that that has come from somewhere. And that particular decision you take has come from research. And unless you have an understanding, a basic understanding of research, you will never be able to question that or to know why something is good and something is less good and why decisions are taken. So I think it's a fundamental requirement for everybody to have that. So one of the things that we ought to be doing is understanding research. And you can do it in various ways. You can do it by understanding the principles of research, and you can do this with short courses. Every university, every organization will offer that. and just have a basic understanding of that. Then I'm sure many of you will have journal clubs in your organizations, in your firms. And the purpose of journal clubs is to critically analyze articles. So you look at the article and say, why is it that they have drawn that conclusion? And I bet you that 50% of the published articles you will see, you will find it hard to understand how the evidence has led to that conclusion. And that is how research is. It's not an exact science. And people are drawing interpretations, and some of those interpretations may not be applicable to the patients that you're treating. So don't be blind to that. But understand that. I mean, those are your first steps, and then start to delve into taking on a project by yourself. So ask a question. Why is it that this is happening to my patients? And in the last 2 years, we have seen new diseases come along. COVID did not exist. And how COVID affects every system of our body did not exist. So that has suddenly opened up the opportunity for all of you to actually ask questions where there are no answers. And yet there are millions of patients out there who are going through this particular condition. I mean, that sort of change in the whole, firmament of medicine has not happened, since HIV was there. So the last 20 years, we've had nothing. Not 20, 30, 40 years, we've had nothing like that. So this is a great opportunity for you to ask questions, delve into research. So what we want to hear from you now is, what are your key questions about why do you need to do research? What are your experiences of trying to do a project yourself? What are the challenges that you have faced or you may be facing in trying to get something published? And let's talk about how to achieve that, and let's take the guidance that we have in order to understand that. So let's have some interactions and some questions from people. And I think many of the answers will be here. So, open to you guys. Tell us, what is it that you've taken on? And let's talk about practical stuff.
Hello, hi. I'm Afan. I'm one of the registrars working in Manchester Royal Infirmary. So basically, for people like us who have been trained abroad, especially in India, we've not been, brought forth to research as much as this country provides. So I really thank both of you, the lecturers, to speak to us about this topic. So just to bring out a few things which I think maybe we lost a little bit of time when Mr. Iyengar was presenting, but I think there is something with every trust that can provide every employer for research. There's funding that is provided for everyone. So one of the questions is, when we want to do research, the one thing that comes first is, obviously we need to gather in data and do all of this research and statistics and everything, but we also need to know where to submit these, and money comes involved, and we need to pay for publications in a better journal with a higher index. So if you could shed some light on that, and because not every one of us are, I think trainees as such who come in that particular code are given fundings for many things. So we could shed some light on that for us to learn more on that topic, please.
Yeah, sure. Thanks, Afan. First thing, we go about trying to publish in a wrong way. Tell you why. We say and write a draft and then looking for which journal to submit. That's the wrong way. First, decide your topic, shortlist 3 journals, 5 journals, that's it. And read 5 articles from that journal first. Don't put it on the computer, print those 5. Then you structure and template your article, and first journal, submit. Rejected, second journal. You should not be having 1 month lacunae between submitting between the first and second. You don't have time, mentally affects you. Third journal. First journal will say, oh, you can revise or major revision. Take those points, submit, gets accepted. First journal, rejected, gives you major points. Work on that, submit to the second. Second journal will give you some. So keep going, keep comes. You will find a home. If your methodology is good, data is good. Second, what was the second part, I think? 3 publication models you know. Subscription model is what we do. There is no money to be paid for that. Third, newer development is open access. Authors need to pay for that. So don't get caught into that. Know that a lot of libraries, institutes fund authors to submit there. But the best I found is the hybrid, journals which take both. So if you have funding from your institute, go for open access. You don't have to worry too much about it. But if you don't have funding, hybrid journals or subscription journals. Okay, 3 journal models.
Thank you. I'll probably take one step back before that. In order to get published, you have to have first designed, asked a question, designed a trial, run it, collected the data, analyzed it, and then you get to that stage. It takes 3 years minimum from where you ask the question to where you need to get. Now, not everybody has 3 years unless you are in a funded academic position. I don't know if Sunil is here, but one of the ways to get into something where you can get a funded academic position is to apply for something like an academic foundation program or a run-through program or a clinical lecturer program. They're very competitive, but you can apply for those and you can get onto that. So that's one way, and that in that way you will have time into your job plan. You get 3 months or 6 months in a 2-year program in order to undertake that. That is only to allow you to understand research and take a very, very superficial approach to it. The other way of doing it is in your gaps between your different phases, so finishing foundation, going on to core, or between core and going on to higher, and that sort of stages, or even after that, you should take time out, and that is the time out to do a program. So you do a 2-year, 3-year funded research program, and that's how you do a full academic research stuff. And those, you will have to connect to people who are research active in your organizations. There will be many of them. And then you need to approach them and say, look, I'm interested in this. And they will have some money available or some funding that they're working on. So every academically active person is working on something, and they will always need research fellows. So that's one way to connect to that, and you can get into that sort of stage. But what if you are in a busy clinical job and you do need to get, into this sort of area? And it's pretty tough because there is no time in your job plan to do anything like this. And that is where what Karthik was mentioning, you get onto that sort of initial stage. So you ask a question which you can answer by looking at data, for instance. And there's a lot of data. NHS Digital, your trust will have a lot of data. You can look at that data, ask the right question, get an academic guide within your organization, and you can crunch that data to produce something that will be worthy of publication. So that's one initial step. It doesn't cost a lot of money. It's you can do it in your weekends and, by ignoring your family life and your quality of life. That sadly is the case. But once you get that first thing done, you can get started. The other area, which is a bit more tough and you need guidance, is to look at systematic reviews. So again, asking a question, looking at data, understanding how to undertake a systematic review. There are lots of Cochrane bodies which are around, which you can, like for St. George's has the Cochrane Airways group. So that's a very good place to go and look at understanding systematic reviews and undertake a systematic review. For that, you don't have to generate new data, but you do have to look at the data. So again, something like that you can do without a lot of funding. And obviously there is time involved, and you have to really like it. So if you are curious about this and you really want to get into it, that's a good way of getting into that. And then after that, you will find softer funding available. So by soft funding, we mean, pharmaceutical industry or HEE or NHS England wants an answer to a question. And that will have something like 50 grand, which will give you 1 year's salary or part of 1 year's salary, and you can actually get on to doing that. So there are ways of doing that. And then once you think that this is for me and you really like it, because you cannot do something just for the sake of doing it. You have to like the idea. You have to enjoy looking at evidence. I mean, the reason we look at, I look at hundreds of articles all the time. But the reason I look at it is because I wake up in the morning wanting to do it. So you've got to want to do it. And unless you dabble into it, you'll never know whether this is for you. And if it is for you, yes, you will come and you'll keep going at it. So those are the sort of initial steps for getting funding. And every organization has a research committee which will have funding. And if you get in touch with them, they will have not only the tools, they will have access to courses, they'll have access to support you. Your library will have access to giving you how to analyze evidence, how to conduct a review. If you get into that sort of source and then try it out, and you might find that this is something that really rocks your boat and you can go for it. And then rest of the funding stuff will come. What Karthik is describing is the end of that spectrum, where you've actually done amazing stuff and you're looking at publishing in Nature. You publish one in Nature, that's it, you've done it. You can now rest for the rest of your life. Anyway, let's hear from you guys.
Next question.
Hi, welcome everyone. I would just like to share my experience because I'm currently working as an internal medicine trainee in Northwest London. So I'm very junior in terms of stepping into academic research, but thanks a lot, Dr. Karthik and Dr. Indranil Chakravorty first for giving us a very much broad spectrum of understanding how we can do a research and how we can get funded. Basically, I want to share my experience, how I got funded. I did a part-time MSc with National Heart and Lung Institution with my training. I started when I was a trust grade F2, and I completed it this year. So the first thing, when I was working as a trust grade F2 in cardiology, basically my research interest is in cardiology, I always looked into the patients who were coming through the ED door. There are loads of chest pain patients. It's a very common presentation in ED. And if we think of what I started doing, I started with an audit, developed it in a CAPE, presented it as an abstract in an AHA conference, and basically I wrote a paper on that. So how we did it, there were loads of patients coming with low and intermediate risk chest pain. Like if you think about TIMI score, Gray score, they were like very low risk. So, but the acute medicine beds are very precious. The CCU beds in hospitals are very precious. So we had a very high pressure, especially in Northwick Park Hospital, which is actually a very busy DGH in Northwest London. So we tried to triage the patient. We collected some data over 6 months' time. We wanted to have a look, who are the patients whom we are admitting, and what are the criteria, what are the basic demographics they are getting treated for. So we found out that there are loads of patients with a very low Gray score or TIMI score. Basically, they are getting admitted, which is actually not needed. So
let me pause you there for just 1 second.
Yeah.
So what you're describing here is having an open mind, asking a clinical question, looking at how an answer to that question might help your hospital or create a service or create a protocol that might lead to an improvement, either by reducing length of stay or improving quality of life. So that's a fundamental thing that you're describing. Now, you mentioned going to an audit, and you mentioned doing a quip on that. Now, audits and quips have different standards of evidence and all that. Then, what I want you to focus on is not the clinical part of that question, but to focus on how you took that question from a quip to a research project, because there's a fundamental difference between the two, isn't it?
Yeah. So basically what we did, we checked if there is any change in 30-day readmission or any outcome in the cardiovascular mortality morbidity. And we went in the, basically, as I was doing a MSc, so I had access to all the journals as via Imperial Library. So I wanted to have a look, like what has been done and what novel thing we can do and how we can present this paper. So we had a run through, we had a systematic review, what is the current guideline according to the most recent systematic review, what they offer for the treatment of patients with low and intermediate risk chest pain. And we developed that basically any patients with a low GRACE and TIMI score, they don't need to get admitted.
So, sorry, I don't want you to go into clinical detail on that, because I think the purpose of the workshop is to understand the process or understand the steps. And I think if you tell us how did you take that from there to research? As in, did you have to go and write a research design?
Yeah, so what we did...
Did you have to take ethics approval? Did you have to... So talk about that, because that's the next key step.
So then we designed a study, which was a retrospective study, which cross-sectional as well. We looked into a data of 6 months admission who are getting admitted with a low and intermediate risk chest pain. We developed a pathway. Any patient with low and intermediate risk chest pain can be brought into the ambulatory care via the LS, and we liaised with the Pan-London Heart Attack Association, the research group, Pan-London Heart Attack Research Group, and we found that this was promising. This was reducing the admission rate, and this also didn't have any negative impact on the 30-day cardiovascular.
So then did you do a prospective study after that?
Yeah, after that.
Yeah. So again, not going into the question, but actually the process would be good.
Yeah.
But thank you for sharing that. I mean, that's a very good description of how you take a clinical question that comes to mind as you're working on a day-to-day basis, and then take it through the steps of an audit, a QIP, a retrospective study, and then on to a prospective study where you're looking at a question. Just answer one thing about funding. Where did you get the funding for the prospective study?
Okay, so when I was doing my MSc, there is a Faculty of Medicine scholarship in Imperial under NHLI. Anyone is open to go for it. They do scrutinize what you will be publishing and what you want to work on. I was lucky that I got funded. Like 80% of my MSc was funded by NHLI.
Very good.
Yeah.
Thank you. I think let's get some more comments from people. So that's a very good description, and thank you for sharing that. Let's get some more. So that's an excellent way of going around doing this, and then to secure funding. Because initially you wouldn't have had funding for the work you did. Thank you for that.
Hi, I'm Harsha Gowda. Thanks, professors. Excellent talk, really interesting. Just to add on to that, just to going backwards, I think especially for the new doctors who come from India, I think the first publication is the most challenging one. As you get into the ladder, first, second, it becomes much, much easier. I don't have an H index like Professor Karthikeyan. Mine is much, much low. But I've not done any research job or anything. I'm not a professor. I'm just a consultant neonatologist. What is important is just publishing as a virgin article is not the only way. There's a lot of ways of publication. As you said, I can talk from the pediatrics perspective. In some of the pediatric journals, there's something like evidence-based reviews, not a systematic review, like a simple evidence-based reviews, Archimedes sections, and also publishing your QI projects, publishing a good quality audit. It's all possible. Aiming for virgin article is quite difficult. You have to do a proper research. But doing other things, like audit, what I always tell to my trainees is when you do a good audit, make sure it's present in the local department, also present in the conference, and also publish it. You can publish a good audit as a QI project in some short reports in various journals. It is possible. So always aim for that. Then it becomes a bit more easy. Once you get the initial step, 2-3 publications, then you can start aiming for for big journals as a virgin articles, and that's what I've seen. You can progress.
Thank you very much. That's an excellent point. I've got a 1-minute warning here, which happened about a minute back. Thank you really for that. I just want to say one thing finally as a plug, is that BAPIO has excellent two journals, The Physician and the Sushruta. Sushruta is about health policy and opinions, and The Physician is for everything clinical. Now, this year, they've been in circulation from 2012, and about 2 years back, we made them as part of electronically available journals, so you can pick them up, and Karthik kindly mentioned them. At present, BAPIO is funding the entire process of publishing in the articles, so there are no article processing charges. This year, the journals are going into PubMed because you have to give a certain amount of evidence for PubMed. And I'm hopeful that within the next 6 months or so, we will get onto PubMed indexing. And once we get that, we're currently indexed on Science Open, so it's an open access journal. But we will get onto PubMed. And once we get onto PubMed, all retrospectively published articles within the journal all become indexed. So you have an opportunity from now for a year to get your articles in to The Physician and to Sushruta, depending on what the topics are. They're all peer-reviewed, they're openly accessible, and you don't have to pay a penny for getting that in, and then you'll get them indexed. So by all means, send us, and we will take anything like quality improvement projects and stuff. Obviously, it has to be quality checked, and we will get them peer-reviewed, and we will ask you to do lots and lots of things to get to our sort of template and standards. But it's a very first good starting point. And once you get there, I can guarantee you, within a year, it'll be PubMed index. So it's a plug, it's available, BAPIO is funding it. So come, and if you want to join us in terms of editorial board, you're welcome to let us know. We would be happy to consider you as part of an editorial board. I'm always looking for peer reviewers. So if you want to peer review, which is a very good way of getting your hands on to articles. These are pre-published articles that you can peer review, and you get credit for that. So, welcome to really apply for editorial membership and to peer review and to submit your articles. But thank you very much for listening to us. You've seen where you can get to, where you're in the, what did you say? 1 in 5 million authors in that stage. I'm in the other side of the 5 million. But we can all get there. But I think the important thing is be curious, ask questions, delve into it. It's not that difficult. Thank you.
Thank you, Professor Chakravarti and Professor Iyengar. So it was really informative. So now we have lunch at Market Kitchen Hall, and we please request you to be back to hall by 1:35. So we'll have a next session on keynote speaker. Thank you.
Clary Tinney, Chief Pupil Officer, University Hospital of Leicester, and Dr. Latif Rahman, Chief Registrar, University Hospital of Leicester. I would like to invite my chair, Dr. Achyutan Sajayan, to introduce the keynote speaker for this session. Thank you.
Thank you, Teja. Welcome back after the lunch. And I don't think our first keynote speaker for the afternoon session does need any introduction. Professor Banfield is the current chair of the Council of BMA, and he's an academician and an obstetrician working in Wales. In fact, actually, he just came from the Labour ward straight away to this conference, so be kind to him when you ask questions. So without further ado, I want to keep the time keeping exactly like it was in the morning because it was excellent. So we'll stick to the time, and without further ado, I invite Professor Banfield to deliver the keynote address. Thank you.
I don't know whether I've got a mic. Is this mic working now?
Yes.
Yeah? Okay. Okay, look, I mean, thank you very much for inviting doctors and to SAS doctors and everyone who isn't my own grade. Right? BMA is absolutely for everyone. Unfortunately, you've been slotted in between me having to deliver some babies, right? Not my own daughters, she's due next week at our hospital, and my son going to university. So I've got a carload of boxes and pans and everything else. Now, I am going to move very quickly through quite a lot of material because I understand that at 20 minutes, the shepherd's hook comes and takes you off the stage. And of course, because I am from Wales, we are very used to sheep. So I'm going to be the chair of UK Council for 3 years. In that 3 years, I intend to deliver on the things that we have been talking about but haven't actually done. All right? And that's about shifting the BMA into being a trade union. Right? That's making sure that the BMA represents all members across all branches of practice. In the workplace. I want us to go back to people being worried about the BMA and worried about that people are in the BMA. As part of that, I want to deliver on us being inclusive and fair and an organisation that's led by its members, by the many, not the few. Right? So we are really, really taking the BMA away from being a middle-aged white man's gentleman's club into something that is fit for this century. We have already clocked that locally employed doctors are a lost group of doctors. All right? I've got some great LEDs in my own department, and I love them to bits, and they have told me exactly over the years what needs to happen, and we have been helpless to do something about it. Well, now is the time that we are going to do something about it. And we want to value diversity not only within the BMA, but within the workplace. It is what makes our work stronger. It's what makes our NHS stronger, that diversity. We shouldn't want to be the same. So it's all about walking the walk, right? In Wales, when I was chair of Welsh Council, we developed the NHS core principles. It was like drawing teeth trying to get the employers and the government to sit down and say, what do you mean? What do you actually mean you want for the workforce? So, for example, what I've got here is value all, right? Value all your staff. Had to drag them kicking and screaming to admit that they should value their staff. Who in this room feels valued in the workplace? Okay, I've got one or two hands, all right? It's not rocket science, is it? We need to deliver on valuing everyone. Oh, mate, you've disappeared, mate. Oh, there we go. Right, okay. So in Wales again, we've delivered for the SAS doctors, we've delivered the charter for SAS doctors. It's about time we delivered for the local employed doctors as well. And you'll have discussions about that, I know, as you go through. You don't need me to tell you who locally employed doctors are. Right? The BMA has done a toolkit for LNCs. It's worked out that there are probably over 20,000 local employed doctors around the NHS and outside of the NHS. Right? I really, until we went into this, had no idea how many people are employed outside of the NHS on terrible contracts and in appalling circumstances. It's just wrong, and it has to stop, because these contracts are not nationally negotiated, right? Some of the examples that we have, for example, some of the RMOs in the private sector, week on, a week off. If there's short of staff and you're week off, you've got to work that week as well. I mean, it's just incredibly dangerous, demoralising, and it's dehumanising as well. Many LEDs are from overseas, and that presents challenges in itself, and I'll talk about those later. It's broadly assumed that you're there to plug the gaps. I don't know a doctor that's there to just do anything, right? What kind of attitude is that, to think you're just there to plug the gaps on some form of rota? That's not a place to start on valuing your staff. And in general, there is a sense that LEDs are excluded from training, excluded from teaching, excluded from career progression. That isn't the way to treat your workforce. So the LED toolkit has been rolled out to local negotiating committees. It's identified a survey of about 6,000 LED members. And it showed that really the LEDs, a substantial minority of the workforce, about 10%, of the workforce are in local employed doctors without standard terms and conditions. Right? About 60% are from ethnic minorities. Some of them will be IMGs. The survey wasn't designed to pick up those exactly. So it's not just not having standard contracts, but it's been on temporary contracts, being made to feel that you have to reapply for your jobs every year or two. That's no way to treat skilled professionals, right? That has to stop. So you can't go on being this invisible minority, right? BAPIO is listening. Right? Otherwise, it wouldn't have this conference organised. Otherwise, it wouldn't be looking to help with an LED charter. The BMA is listening. The BMA has heard. All right? It expects to do a lot for you. You have a lot. You have a legal right to have a permanent contract after 4 years of continuous service. And so many LEDs are still not on permanent contracts. No, there's 100 from this survey that was done that still didn't have a permanent contract after a decade and are being strung along, made to feel insecure for their jobs each year. So where is the BMA in this? Right? It has been doing things to negotiate for local employed doctors, moved a number of people onto specialty contracts, moved them from the old 2002 to 2016 contract. For some people, that's not financially appropriate, and therefore the BMA has negotiated pay protection. Right? I'm going to give you a list of some of the things that people have done, because this is what you should expect as a minimum as you sit here now. The BMA can only expect to recruit and retain local employed doctors and SAS doctors if it starts delivering for you, right? If it makes you feel different. So an example of that, I had 2 orthopaedic local employed doctors worked propping up an orthopaedic service at a distant site for 10 years. When the pandemic came, there was a decision to move them into the acute hospital, into an environment that they were very unused to. End of the pandemic, they said, well, we can go back to our old jobs now because you've opened up the elective service again. And they were absolutely treated appallingly in not allowing them to return to their old jobs. We stepped in. It just needed someone to say this is unreasonable and unfair. Right? I've never seen 2 such dedicated doctors so distressed. Right? And this is what I had as an email the other day from them. Right? So thank you, but it was giving them back their lives and their dignity. Right? I don't want you to think that we do not understand how distressing some of the situations you find yourselves in are. DDRB awarded 4.5%. For many hospitals, there is no mechanism for getting it for the local employed doctors. That's where the BMA comes in. So the BMA does have a checklist that it's worth thinking about. It's on the website, and it gives you just a list of the things that you might want to think about. I'm not going to go through the detail here, but it's about the role, the pay, the future, hours, salary, what your rights are going to be. And the BMA, in different places, through its LNCs, has been getting the sort of things that local employed doctors should expect. So shifts from one contract to the next, access to higher points on that scale. Getting representation for local employed doctors, moving from temporary to permanent posts, and demanding really from HR departments, you know, why are you giving these temporary posts out? It's completely unnecessary. Give people job security, allow them to stay in the workplace, and bring local employed doctors into the expectation that they should have access to teaching and training. It is completely unreasonable to expect you to have annual appraisal and revalidation out every 5 years and then not provide you with an equal opportunity to further yourselves and your careers, and to do that within work time and within a funded budget. Right? It's just not acceptable to not do that. There's more to do at trust level. That's where our focus has been really with the LNCs, but we need
1 day per week to oversee the locally employed doctors' work and bring improvement. Our fourth recommendation is around induction. We know, and Dr. Malarao has talked this morning about IMGs receiving enhanced induction. We recommend this should be mandatory for all trusts to bring in enhanced induction for IMGs. The enhanced induction should include pastoral induction, talks on rota, good rostering gauge, talks on the NHS system, and they should also have opportunity to have mandatory clinical attachment or shadowing period, at least for the first few weeks before they take up their role or be on the on-call rota. We know that IMGs doesn't know much about how to raise concerns or how to access resources like well-being resources or access to guardian safety and all. So they should have induction modules where they can be signposted to different resources so they know how to approach or how to utilize the resources in a timely manner. The enhanced induction should also have training on communication. At St. George's, we developed 6 modules with 1 module on communication skills, and we're implementing that as enhanced induction for IMGs from this year. We also invited GMC to come and talk, come and do a session at St. George's locally this year, and I think all trusts should utilize the GMC workshop and make use of it. Even the UK graduates can have refresher courses on good medical practice and also access to career development through the enhanced induction. Very important slide. Well, we know that IMGs struggle to get access to supervisor and education and training. So we suggest that all IMGs should have a dedicated supervisor, a clinical and educational supervisor, and access to portfolio and appraisal system. And they should receive adequate training on how to use the portfolio on what ACAT is, jobs, and all those stuff, and also about how to get appropriate real-time feedbacks from the supervisor. And the supervisor can have a dedicated session per week to meet the locally employed doctors, and this should be implemented nationally, that all locally employed doctors should have a supervisor. We also suggest that locally employed doctors should have access to education as well. We know that the doctors in formal training have protected hours to go into training, but the locally employed doctors really struggle to get access to educational courses. So we recommend there should be at least 50 hours of documented training for each locally employed doctors for the annual appraisal, which includes at least 50% of internal and external accredited course access. And there should be appropriate supervision and help to support specialty examination appearance so that they can clear the examinations in a timely manner. We know that the concept of leadership is changing in the NHS. It's changing into a collaborative, inclusive, and compassionate leadership style. Locally employed doctors need to have access to different leadership courses so they can develop their leadership style and behavior. This can be offered locally so that locally employed doctors can have access to either a partial or fully funded NHS leadership program, and they can also be offered opportunities to develop their leadership skills. This can be either a formal role or an informal, like being in charge of a forum or in a leading champion. Teaching is more related to education and training. Once they have access to supervisor and education, the locally employed doctors should have the opportunity to attend training courses, get access to training courses, to attend training courses, to develop their teaching style and teaching skills, and also help to support and seek funding to get additional educational qualifications. They can also be offered resources and training to develop themselves into formal roles like educational supervisor, clinical supervisor, or even to supervise physicians, associates, and other medical associates. We also recommend there should be opportunity for access to expert career guidance as well as mentorship programs. So this will offer the locally employed doctors to explore the career options, to attend TASER sessions, and also to seek the support in career progression. The mentors can have appropriate training on awareness of the aspiration and the hurdles. We know that 41% of LEDs experience emotional exhaustion, 1/3 experience physical and psychological exhaustion, and 1 in 10 experience incivility. Locally employed doctors, they should be offered additional signposting and also access to resources to raise concerns and to seek support in a timely and in a precise manner. These are our 10 recommendations, which we talked in detail for the whole of today, but we need to bring this up nationally and implement in every trust so that all locally employed doctors will benefit from this. Thank you, and now we are open for discussion.
Thank you, Afzal. Thank you for running through the recommendations. One thing I'm sure you'll all be able to see that, we're not asking for the sky here. We're asking for something which should be the right of every doctor. So I'm going to open up initially to the panel members and get their comments on what do they think this is. And remember that this is the first edition of the charter, and I'm sure that we can together make it much better. So I don't know who wants to go first. Amit? Yeah. And then we'll come to the audience because I know there's a lot of experience here and I want to hear from you.
It's a golden hour where people like me, when you reach my expertise in age, you tend to nod off. So I'm going to start with a question. And my question to you all is, bright young faces, how many of you have heard of an associate specialist or a SAS doctor or a specialty doctor? Not bad, not bad. There's more than 25,000 of us in this country, and I'm an associate specialist and past chair of the BMA SAS committee, and I deliberately brought that up. I would like to congratulate BAPIO, and you know what? I'm congratulating myself as well, because I'm very much a part of BAPIO, although Phil, before he left, whispered in my ear, you're representing the BMA now. He did actually say that. And you know what? I started like all of you. Indranil was absolutely spot on when he said, came to this country very, very fresh, about 250 years ago, at least feels like that. No money, gave it all to the GMC and the visa or the Home Office, and then developed problems getting into training. In those days, there used to be a gentleman called Kenneth Carlman, and the Carlman reforms came into picture. There were not enough training posts. So the first forgotten tribe that was formed in the United Kingdom was the SAS doctor. Now it is the specialist, associate specialist, and the specialty doctor committee. And I became the chair in 2013, and the first thing I did was to sign the SAS charter nationally. 4 organizations. So Ramesh is absolutely spot on. He's always spot on. You need to get more stakeholders. And the BMA obviously consider it. I'm sure we will join. I'm sure we'll get other. The SAS charter was 4 stakeholders: NHS employers, Academy of Medical Royal Colleges, BMA, and I think the GMC came in for a bit. Health Education England was the 4th stakeholder. So I have a thing about titles. I hate the title LED, and I've made my comment about this before, so I'll not say the same thing. But a question to you again: why do you go to work? Hands up those who go to work for the money. Not bad, at least honest. Okay. Hands up those who go to work because their husband or wife or their partner kicked them out of the house. Oh, there's a couple of hands there. Brave, you're brave. You know, this question was asked in a very, very big meeting, and Indranil actually alluded to that. You know, commonest reason why we go to work? Recognition. Value us. Recognize us. And we last thing I'm going to say is there are many, many careers in this country in medicine. I have both my children doing medicine. I keep telling them, look at, explore everything. A GP is not the end of. Even a GP today wants to be something else. A consultant wants to be a leader, a medical director. It all changes. Consider your career options. The world is your oyster. Thank you.
Thank you, Amit. Ramesh.
Before I give it to Claire, because Claire has already said, she's going to do what things here, and hopefully we would have collaboration to show to the rest of the educators that how this charter can be implemented, because having documents and charters is easy thing to do, but implementing the recommendations is the most difficult thing to do. Now, because most of you guys are fairly new to the country, I just need to tell you how BAPIO has always stood up for fairness, equality and justice. So BAPIO, when it was formed in '96, there was a big problem with a lot of people coming in the country and taking the PLAB examination and finding no job. At that time, Tony Blair government had put in a lot of money to recruit specialty and consultant doctors and advertise all over the world that there is shortage of doctors. So doctors, newly graduate doctors felt that there is good opportunity of training in England. Now, fortunately or unfortunately, England or UK is seen as the base training ground for doctors. So everybody wants to come to UK. That's how all of you have come, and we came to get good training. So a lot of these doctors came and then they were unemployed and they were not looked after properly. But when the government saw that there are so many doctors unemployed and some of them were taking position of the local graduates, they said, oh, now we need to do something. And they had a meeting, a confidential meeting where I was invited as well, and one of the deans said we need to close the tap. So the tap is stop getting people from overseas. So we said, fine, how are you going to do that? And the Department of Health present in that meeting said that we will change the rules of training retrospectively, so those who are already in the training will be removed until every single local graduate finds a training course. And we said this is not fair. You can't do it retrospectively. But they did it through the parliament. So BAPIO stood up. We went to the judicial review. We lost the case in the first instance. We appealed. And we won the case, which was a big surprise for the Department of Health and the Home Office, that how a small organization like BAPIO can win a case against the government. So they appealed. And this case went to House of Lords at that time, now called Supreme Court. And ladies and gentlemen, you will be pleased to know that BAPIO won that case and that court the result of that decision was all those people who were removed from the training came back into the training, and now you will see that almost 15,000 consultants and GPs who would have left the country at that time are now serving the NHS in the best possible way. So this was a boon to the country which otherwise would not have been possible. So this is just an example. Coming back to this charter, and before I hand it over to Claire to say some even better things, this charter is very important because, as we have heard, locally employed doctors, although they are a neglected group of people, they are the ones who are the foot soldiers of the National Service. for God's sake, all the employers should be looking after you in such a way that you are happy to come back to work to provide the best patient care that you can. If you are not happy, you can't. So with that note, I am sure that we are going to ensure that this charter will be, well, we can't ensure, but we will do our best to ensure that this charter is implemented. And as I said, this is the first stage. We are going to include all the stakeholders and the VMN. And Amit, I know, is a BAPIO member, although he has been told to be VMN representative, which is fair.
Thank you. I'm not sure I can say better things, but I will try and say a few things. First of all, thank you to everybody who worked hard to develop the Charter. I think that's the first thing for me to recognise, because it's also, I think, should we have a round of applause for everybody? It's good work, and when you get a group of people trying to agree and finalise things like a charter, it's, the end product is usually very, very good, but there's a lot of hard work that often sits at the back of it to get people to kind of form the words that form it. I think what's really good about the charter is that it's being developed by the people for whom it will work for. And so it speaks to what is important for locally employed doctors, and that's what we should not lose sight of. I think it's that it contains absolutely the right things to do, and I would also say it is the start, because I think there is also more to do. Yes, we would want to push and support for this to be adopted nationally, and we can work with national organisations to do that. Equally, I come back to what I said previously about the responsibility of local employers. And actually, if as local employers we start to adopt the Charter, that's also actually better, because we are adopting it because we want to, and we want to work with you to do the right things, rather than being given a mandate to say we will do this. So for me, that is more meaningful. And certainly, having looked at the Charter, and Bijou said to me on the way in, there's a charter in there, you might want to look at it. We said, because you're talking about it later. But we're only unveiling it today, so I couldn't tell you about it yesterday. So thank you for that. But absolutely, University Hospitals Leicester, these are the things that we want to do. I was writing through the day a list of things for me to go back and check about locally employed doctors' terms and conditions back at UHL. And I'll still go back to my list to check that we are doing the right things, and if we're not, do you have my commitment that we will? But the Charter also gives us the good reference point to cross-reference that. So if I didn't capture everything on my list, I've now got it in the Charter, and we will work with you to implement this locally, and we will also work with you to push for this to be implemented nationally. Thank you.
I think I'll come back to two of you for your final comments. Can we have some comments from the audience, please? Anshu, do you have a mic? Oh no, it's here probably. Because I know there's a lot of people here who are doing a lot of good work, so I just want to hear from you, Anshu.
Thank you very much. Anshu Binaria, I'm the Trust Clinical Tutor for locally employed doctors in East and North Arts, and I've been appointed for the past 3 years. What I want to ask actually the audience here, who are more likely JCFs and senior clinical fellows, how many of you knew that the term locally employed doctors is meant for you? And I have a question about this word locally employed doctors, because until I tell them that actually, do you know that you're a locally employed doctor, they don't realize it. So I think I'm going to put the table around and ask, on the job description, how will people know that they're locally employed doctors? Because they go as trust doctors, or they go as junior clinical fellows and senior clinical fellows. So that's really a comment and really a question as well.
Thank you. Is there anybody in the panel want to take that?
Well, I can try. Actually, I'll take the problem a little bit further. And then what happens is if they don't know that they're locally employed, you never get data that they're locally employed. So the entire term is wrong. And the Charter actually addresses that. We've got to get a standard term, which is the best thing to do. And the Charter addresses that. You're absolutely right. They don't know that they're locally employed. They are locally employed because they're here, but so am I. So you. So, yeah, good point.
John.
I think it's very important to get major stakeholders involved, but we know doing that in the NHS can take years. And I want to dot every I across every T. Actually, there's very little here. I think most trusts do absolutely. There might be a bit of debate about, FedEx, because there's other sorts of facts of how that comes together, but that's my stuff. So my encouragement, because we've also got with us as an employer, the BMA, the GMC, many of the trainees all saying the same. So if we've got that on a healthy command, can't we just get on with it? Can't we just go straight to the employers, whilst we're also getting that wider support? Because we've all been there when stuff gets kicked to the last long grass and then emerges. We need to make sure that doesn't happen.
Thank you very much, John. I know we're down to the last couple of minutes. I've had the warning, so I need to hear from, now that you know you're locally employed doctors, can we have some comments about what you think? Does the Charter do enough for you? Do you want to see more in this? It's a bit of silence here, which might make the point. I don't know, Sharon, what do you think? Because you worked on the document.
I'm very happy actually to work on this Charter because whatever I have put down in the recommendations are all coming from personal experiences. And I think the key thing that we would all need to take home is that obviously, as we have discussed throughout the day, that we really need that self-development time, because that will also help us professionally as clinicians and also will help us for our career progression. So that is the longer goal and the aim that we need to see, that how are we developing as career-wise as well.
Thank you very much, Sharon. So can I give the last word to Gajanan? You may have to stand up so everybody can see. Come up here. Because this is...
What I would say is, after three great speakers, it's difficult. But now, after seeing so much silence, now you are in a shock that you're not considering yourself as an LED. But having heard this, now, from the stakeholders' point of view, there's big people involved and doing it. But from the ground level, you can go back to your trust. You can go back and ask, what are we doing? What you are doing? Can you look at the Charter and can you come up from the ground level, grassroots level, so that there's a two-way approach from you people and then be part of it. Thank you.
Thank you so much. So I think we need to come to, we need to come to the end for this session. Piju, one word from you.
Thank you very much. For me, sorry, can I something? Because my son recognized LED as a bulb. Then I reflected on that. When I reflected on that, LED bulb is cheap to maintain, value for money, it can be easily disposable. Can we value our doctors better than LED bulb? That is what the question I want to pose to all the leaders. Thank you.
Okay, I'm going to thank the members of the panel and for your promise and commitment to take this forward. And thanks to all of you. And I want to hear more from you later on. Thank you very much.
You're okay, sorry. Thank you.
Where is it? Where is it? Where is it?
It's gonna be last.
It is last.
Oh gosh, they haven't put it.
Do you have it with you right now? Do you have it with you right now?
No. Where are they? WhatsApp में है, लेकिन ये टाइम लगेगा ना.
मेल में दे दो, ये मेल में दे दो. मैं कॉफी ब्रेक के बीच में, नेक्स्ट सेशन के बीच में चला दूँगा और प्रेजेंटेशन. इस मेल में दे दो. इस मेल में दे दो.
किसमें भेजना है?
ये इस मेल में भेजो.
LED कॉन्फ्रेंस.
This one, Christian.
Okay, we start. You know, we need technical support for the posters.
Yeah.
ले लो उसका. Representation. Where is the presentation?
Wait. Yeah, there's a presentation.
Okay. And then it's going to directly come there?
Yeah, you have to open it.
You have to stay.
Okay, I will do that. Who is in the moderator?
We are.
Okay. Ladies and gentlemen, now we will start our oral presentations right now. May I invite on stage the chairs, Dr. Lakshmi Venugopal and Dr. Meena Laka. Thank you.
Welcome all. I'm Meena Lakha. And I'm Lakshmi. Thanks for joining us today in oral presentation session. I would like to request all the 7 delegates who have been selected for oral presentation to please come forward towards the dais and please take a seat.
I'll call out the names now. Dr. Abhinaya Srinivasan, Dr. Amy Craig, Dr. Maria Iqbal, Dr. Nang Hom, Dr. Nyan Tint, Dr. Pratima Gogineni, and Dr. Shashikumar Lakshmana.
We are pleased to inform that we have 4 esteemed judges who will judge and score these oral presentation. The judges panel include Professor Geeta Menon, Dr. Chitra Joseph, Professor Indranil Chakravarti, and Dr. Sunil Daga. Thank you, judges, for coming here.
So welcoming all to the oral presentation session. So presenters, please take note of these instructions carefully. You got 5 minutes for your presentation, followed by a 2-minute question and answer session by the judges. And we will alert you when it's 4 minutes time, and then you will have only 1 minute left. And please stick to the time limit. There will be negative marking for overrunning. You will be marked negative 10% of your marks for every extra second that you overrun. So please stick to the time. Right, so, and requesting all of you to try and keep your phones on either on silent mode, or if you could switch it off, that would be better. So let's begin our session.
May I please call upon our first presenter, Dr. Abhinaya Srinivasan, who is going to present on topic LED, a little extra for the doctor. Please, Abhinaya, if you can come on the stage. Over to you.
Is it okay to start? A very good afternoon, one and all, and I would like to thank this committee for giving me this opportunity to present in this conference. This is about a little extra for doctors. It's nice to have a little extra money for everyone, I agree, but this is not about that, but this is much more than that. Oh, yeah. It's changing. It's changing here, it's not changing there. Yeah, it's changing here, but not in the presentation.
Yeah, we stopped the clock. We have already stopped.
That's okay.
Don't worry. Don't worry about it.
Yeah. Cool. So we've been hearing challenges faced by LEDs since this morning, but on a positive note, I thought it would be a good chance to discuss the system change that we brought in the Eastern North Hertfordshire Trust to help the LEDs navigating through the challenges. So there were two major committees. There are two major committees in ENHT which helps in helping the LEDs to go through the challenges. The first one is a dedicated LED committee in the ENHT. There is a senior team which includes the DME, members from the HR team and the medical director, and a junior team which has trust representatives and individual department representatives to go in detail through what happens in the individual department. There's also a dedicated trust LED tutor who is amongst us in the audience. And this committee meets every 2 months, like once in 2 months, and the results of the meeting is being reflected to the regional HEE team as well. It discusses about study leave, study budgets, most of the time, which has been always the questions from the LEDs in the trust, and we've managed to sort out most of them. The International Doctors Forum, it's a monthly forum. It's more like a chit-chat group, like a peer group, more of an emotional support, answering questions which can arise in every member who travels from abroad. We also mentioned about the exceptional reporting for the LEDs in the trust. Two major documents within the trust. One of them is a dedicated charter, which we've been having for the last 2 years in the trust. We mentioned about the changes in 3 different headings, like a pre-transitional, transitional, and the post-transitional period to help making the transition smooth. The pre-transitional is until right before they join the trust, within the first week of getting settled in the trust. Transitional is the first 4 months of 4 weeks of shadowing, and the post-transitional period depends upon their professional development, where they want to get into. It might be a longer channel. The next one is the terms of reference document. It has a lot of roles and responsibilities explained. One of the major things is that we recommend a dedicated educational supervisor to individual LEDs in the trust, and we've had a little data about it saying that there are 20% of the trainee seats that are being not filled, and we recommended the educational supervisor who is supposed to be for that 20% trainees to overlook the LEDs who are joining in the trust. This is a major milestone which we managed to do in the last year. ACOLI, as we call it, it's the annual conference dedicated to the LEDs in the Eastern North Hertfordshire Trust. It was run at the regional level in the East of England deanery, although it was publicised at the national level. We ran it close to the induction time, like September, October, when there are lots of IMGs who join the trust around September. So we managed to, and we're looking forward for the second year of this conference. Last but not the least, the Mastermind initiative of a mentor program. We had a survey among the mentors asking for expression of interest for the mentors and the mentees. The special thing about this is that you can either be a mentor or a mentee or both. So I would say I myself, being a mentee, managed to become a mentor for my juniors in the trust. So this is currently under phase 2. So we match the mentors with their mentees according to their expression of interest, depending upon their professional development, career goals, aspirations. And then we give them a schedule to catch up with each other on a one-on-one basis, have a feedback session in the next 6 months to look back what has happened and then taking a way forward. I would take this opportunity to say that I myself being a member of many of these things, and I'm here at this moment. Like, this LED committee has helped me in a lot of ways to get through where I am at the moment, and I'm looking forward to a lot of things which happens in the future. Thank you.
Thank you, Mayor. The judges can have a Q&A session now, 2 minutes.
Okay, if it's 2 minutes, thank you very much for the presentation. And clearly, a lot of work has gone in And I can thank you also for allowing us to have a look at your charter when we did our, the national one. Now, the questions are two questions. One is, how do you know in the last 3 years the work that you've done is actually effective? So what are your outcome measures? And the second bit is, who is accountable if you're not achieving your goals?
Okay. In answer to the first question, it's a constant process which we are doing with a feedback session and everything. So I joined as an IMG, like I had my mentors who was in the trust when I joined and who has gotten into the training program, which as per their aspiration. And I joined myself as a junior doctor, did myself. So I had a mentor, and now I am mentoring to my juniors, as I said. So it's a constant progress. And like my role, I was a LED trust representative for the doctors, and I've given like my role to my juniors. So it's going on, and we are looking back as a feedback initiative to see. I've actually discussed with Dr. Delaria to see how many of us have gotten into a training program. So that's in the process, and I'm hoping it'll be there in the next 1 or 2 years. We'll be able to give you actual data to see how many LEDs have done what they wanted when they're leaving the trust or when they're going on to the next step. In terms of the second question, I would say as a teamwork, I would say depends on the individual as well. It'll be an individual responsibility, but as a team as well, to take responsibility of what they have achieved.
Thank you. Can I ask a lot of initiative that you and your team have implemented? How did you went about the resistance? Because obviously this is a big change for your institute. Were you involved in managing that change? And if you could reflect on some of the resistance.
I might need Dr. Delaria to answer that, because I joined in a place where I had options to enter the LNC committee as well. There were lots of changes, as I can appreciate, but they have taken into a step ahead, discussing with the DME and the medical directors involved in the trust. There has been lots of discussions going on, and after that they were able to manage that. Thank you.
Thank you, over there. Our next presenter is Dr. Amy Craig, and she is going to present on workplace sexism, doctors versus non-doctors.
Good afternoon, I'm Dr. Amy Craig, and I'm a junior clinical fellow working down in London at the moment. I'm very grateful to have been invited to speak to you all today about some work that my colleague and I, Dr. Warrens, have been doing, looking at workplace sexism amongst junior doctors. We're actually inspired to do this research by the BMA's recent report on sexism in medicine, which found that 91% of women had experienced sexism within the workplace in the last 2 years, with 42% of them not reporting these experiences. Of particular note to us was that it was the youngest age bracket, those in their early 20s, who were most likely to report these experiences and most likely to report experiencing them, but least likely to report these experiences. Because of this, and some of the examples you can see in the quotes behind me, we wanted to investigate this further to try and identify, is this a specific NHS problem within women starting out in the NHS, or is it a wider problem amongst women in their early years of their work? In order to do this, we adapted the BMA survey and sent it out to both doctors during WhatsApp groups and other hospital forums, and then amongst non-doctors during like sports teams and other local societies. This was to try and determine, is this an NHS problem or is it a wider problem? From the 100 responses that we got, we identified that over half of doctors said that they had experienced sexism at least weekly, compared to only 13% of non-doctors, with a p-value of less than 0.0001. When we tried to look more deeply into the examples of these experiences of sexism, as you can see from the examples behind the majority of them, doctors were saying that they were experiencing them more frequently than non-doctors were. When looking at these examples as well, doctors were experiencing from both senior colleagues, from their peers, and from patients as well. So it was being experienced across the board whilst they were at work. Furthermore, whilst doctors felt that it was individuals that were the greatest driving factor, non-doctors actually felt it was more to do with institutional and structural problems. And finally, whilst 68% of doctors experienced or witnessed sexism but didn't raise it, only 32% of doctors didn't raise it. From these findings, we tried to target our recommendations to three key groups. So the first group was junior doctors themselves and trying to improve their knowledge and their confidence in raising these issues. So we spoke to the foundation faculty meeting at our trust, as well as speaking to F1s directly. Interestingly, at the beginning of the F1 session, when asked if they knew how to report or raise these instances, 0% of the doctors present said that they knew how to do it. By the end of the session, 95% said that they did and that they had increased confidence in knowing how to do this. This is amongst a group who do have quite a good training program and often more structured support. So for instance, amongst the community here, the LED doctors, this is likely to be far less successful. We also wanted to promote the awareness of unconscious bias amongst our own peers and more senior colleagues as well. So we presented at our local Grand Round and also wrote in our newsletter as well. We directed our colleagues to look at the Harvard IAT, which is a test that helps identify potential forms of unconscious bias. It is evidence-based if it is followed up by a debriefing session, which we acknowledge is not always possible to do, but we would still recommend having a look at it. Probably the hardest one to address is the wider population, in particular patients, as this was quite commonly the main cause of some of the experiences. We are trying to organise focus groups in order to speak to patients to try and get some ideas about how we could tackle this. And we are also involved with an initiative called Project S, which is an excellent initiative that is gathering evidence across the NHS to try and get evidence and implement institutional change.
1 minute left.
Thank you very much for inviting me to speak to you today. We are still trying to gather evidence, and we recognise that a limitation of both our study and the BMA report was the lack of representation from LED doctors. And so if you have any experiences of your own or any ideas, we would be so grateful to hear from you. And by scanning this QR code, you could fill out our survey from yourselves, or you may contact us directly, and we would be very grateful to hear from you and work with you going forward. Thank you again.
Thanks, Amy. Over to you, judges. 2 minutes.
Thanks, Amy. Great presentation. I just wanted to find out, you said you then did the data between doctors and non-doctors, and you then worked out what the recommendations were for the doctors. What were you going to do with the non-doctors? Because, structural and racism is an issue. And so what was your plan for that?
So the main reason we compared doctors to non-doctors was actually to try and draw from some of the recommendations from the non-doctors of things that they had in place which had protected them. Because we found they were less likely to experience it, we were trying to work out why that was, and if we could draw from some of the processes they had in place, such as they had a lot of training sessions, they had women's initiatives and forums which really helped, and these helped guide our recommendations. Going forward, for non-doctors as well, we are going to publish the results, and everyone who was involved, we're in contact with them to let them know what we found. And there's also an excellent project called Everyday Sexism, which is a kind of a forum where you can publish instances and read other people's as well, and it's quite a nice place to vent, and it's open to both non-doctors and doctors as well. So we flagged people who did respond to this to that forum as well.
Just about your methodology, what's not clear to me is how do you know who said they are a doctor when actually doctors filling the survey? Did you do any validity check of your respondents?
We didn't. We just went off faith, I guess. You had to identify if you were a doctor or a non-doctor, and then specifically you had to say what grade of doctor you were, and if you weren't, what area you were in as a non-doctor. And this was classed within the official National Office of Statistics, which is grouped into kind of professional, artistic. They have set categories, and so by identifying within that what you were, that was kind of what we went off of. Thank you very much.
Thank you.
I would like to call now our next presenter. May I please call upon Maria Iqbal to please come forward. She's going to present on the topic burnout amongst LED IMG working in AMU General Medical Department in a Northwest hospital.
Hello, everyone. Thank you so much for inviting us over here. My name is Dr. Maria, and I'm working as a trust gate doctor in general surgery in Blackpool Teaching Hospital. As you all know, burnout is something that we discuss enough, and yet still we need to discuss more about it because we can't stress enough on it. Working in medicine as well for a time, I found that the pressure was so much that I have seen loads of doctors suffering from burnout. So we did a survey on the doctors working in the acute medicine and the general medicine department there. As we all know, GMC does the survey on the trainee doctors, and they found that 1/3 of them have been suffering from burnout. As well. And despite showing resilience in the face of diversity, a lot of support needs still to be garnered. Right. Well, that's it really. It's just that burnout is something I would say consultants and the reggers suffer a lot, but the juniors, they suffer a different kind of burnout among them. I know in a normal on-call that we do there, there's a lot of pressure on the junior doctors, especially the LDAs, and there are loads of expectations from them. However, I feel the help given to them is not enough to support them in all the criteria. So I think more help should be given to them. Thank you.
Thank you, Dr. Redbourne. Over to you, judges.
Thank you, Maria. Obviously, we support your findings and everything that you suggested about giving more support. I have two small questions. One is a process question. So if 80% of your doctors within 6 months of working are reporting burnout, the first thing that comes to mind is that the norm? And should we make that the norm and therefore look at the other 20% and find out why are they not burnt out? Or should you be looking at the definition of burning out and seeing whether we need to sort of reset that definition?
Right.
Or we are in dark straits if 80% are burning out in 6 months. What do you think?
So that's the thing. We also have a definition for what actually a burnout is. It's a combination of things. You got emotional exhaustion, you got feeling of cynicism and reduced personal accomplishment. The thing is, it's just not. I know that 80% thinks that they are burned out, but then again, what I think is we need to look into the reasons for those. If 80% are feeling like that way, there could be many reasons why they're feeling like that. Those 20% who have not been feeling like that, they might know maybe how to stand up for themselves, they might know where to go for the help, they might know what to do, but still 80% of them have been in NHS for only 6 months. I don't expect someone who's been working only 6 months to know everything regarding needing help. I mean, if I talk about myself personally, after 6 months, I didn't know much about getting help, but after I've been here for time now, I feel like I know better and better where to go for help. So if I say 80% have been burned out, I can say maybe I might be among 20% now because I know personally where to go for help. I know personally what to do. But those 80% actually don't know, so they go on and on with that, and they think, oh, maybe this is the norm. But that's what we need to change. We need to tell them this is not the norm. The norm shouldn't be that way.
Time's up.
No. Thank you.
Thank you, Dr. Maria Iqbal. Our next presenter is Dr. Nam Ning Hong. She will be presenting on Quality Improvement Project on documentation of clinical frailty scale for patients aged 65 and above at the time of acute medical admissions.
Good afternoon, everyone. My name is Nang, and I'm the Clinical Fellow FY2 from Southern Hospital. First of all, thank you very much for accepting my humble presentation today. Today I'm going to be talking about the clinical frailty scale with the aim of helping the new junior doctors who will be joining the NHS soon or who just recently joined the UK, where there is a huge geriatric population. So first of all, I would like to talk about frailty first. As an IMG who trained abroad, the word frail itself was so foreign and alien to me when I first started working here. So the simplified definition of frailty from UpToDate, which is also a very good website, is an age-related syndrome of physiological decline characterized by marked vulnerability to adverse health outcomes, which essentially means frail people are usually associated with increased mortality, fewer people returning home, and poor quality of life following an acute care episode. So interestingly, although it says age-related syndrome, it doesn't, like, being an elderly itself doesn't mean being frail as well. So how are we going to diagnose frailty? And the answer is there's no gold standard measure for diagnosis. So then clinical frailty scale was developed by Professor Rockwood to help healthcare professionals identify patients who are at risk of poor outcomes after a critical care episode, and also to help us guide making clinical decision when it comes to like treatment escalation plan, or and see whether the patient might or might not be benefit from some invasive interventions. And it should be used as a part of comprehensive holistic assessment, not in isolation. And when are we going to use to assess the clinical frailty scale of patients? So it can be assessed at first point of contact during the acute care, whether in the ED or at the time of clocking or post-op ward rounds, and it can be done by any trained professionals. And the reference for the scale is very easily accessible. We can Google the poster or use the NHS application, which is available for both Android and Apple products. So there are a few do's and don'ts when it comes to clinical frailty scale. It is only validated for those aged 65 and above, not for younger population or those with learning disabilities. And also, when we assess the clinical frailty scale, we must make sure that we check the baseline of the patient 2 weeks prior to the admission, not depending on the patient's condition today. And also, since we're going to use the clinical frailty scale as a part of clinical decision making, we must make sure that the score is accurate, not just randomly guessing it. So this is the poster for the clinical frailty scale. Very easy to understand and very simple, starting from 1 very fit to terminally ill, patient 9. Just need to be a bit careful when we decide whether the patient scores 6 or 7, because 7 means they're completely dependent for personal care, whereas in 6 means they can still manage their personal care but with a little bit of help. So in Southern Hospital, we did quality improvement projects on this topic, just with the objective of reminding the junior doctors on the importance of documenting clinical frailty score at the time of clocking. After 2 audit cycles, the target was successfully met, and we are trying to maintain it by sending out trust-wide emails, placing posters, briefings, and also updating the clinical clocking pro forma to include clinical frailty scale, and also encourage the junior doctors to include the score in the discharge letters for future reference. So my take-home message for today is when assessing the clinical frailty scale, it's all about the baseline, not about the patient's today's condition, and also we need to take proper history, like drill into the social history as much as we can. We need to get collateral history if accessible, and also clinical frailty scale is valid for those 65 only. And these are the references for this presentation and also our quip, and thank you very much for your time.
Thanks, then over to you, judges. Hi, nice presentation.
Yep.
How are you going to take it forward? Is any other demographic that age is contributing to this now?
Sorry?
How are you taking this results forward, as well as any other age or other parameters also contributing to the clinical library, other than sex, and gender, and everything?
So when we're looking at clinical frailty score, we just consider everyone, those above 65 years and above, both genders. Also, sorry, I got lost in the questions. If you could repeat the question for me again.
How are you going to take it forward?
Yes. Yes, like I mentioned earlier, we're trying to maintain the target by mentioning it during the handover briefings, and also sending out the trust-wide emails, placing the poster, and also now we have updated the clocking pro forma to include the clinical frailty scale, so that junior doctors are aware of the fact that it's very important to document that at the time of clocking.
Okay, can I ask, why did a doctor have to do this? Any member of staff who is clerking his patient Are the nurses doing it separately? Is your documentation electronic or just still paperwork?
Actually, clinical fertility skill can be assessed by all trained professionals, doctors, nurses, paramedics, but it needs to be reassessed properly. Essentially, we need to reassess it every 2 weeks if possible, but it's on the clocking pro forma, which is done manually at the moment.
Thank you.
Thank you very much.
May I please call upon our next delegate, Nian Ting, who is going to present on topic LED leadership, overcoming geographical and COVID challenges using Teams.
Am I pressing? Good afternoon. Thank you very much for giving the opportunity to present my small project. My colleagues have done, yes, it's too loud, very beautiful work that I'm really amazed. That I just like to share my the small piece of work I did for the trust. It was done around about 1.5 years ago when I was trust grade doctor in Lincoln County Hospital. It was under United Lincolnshire Hospital NHS Trust. So the first thing about Lincolnshire is there's a lot of trust, and in ULHT we have 3 hospitals. They are geographically quite dispersed. Until recently, we don't have no direct trains. After COVID, we started having direct trains to Lincoln. But Grantham, we have direct trains from London. And Boston, we have like 2 transit trains sometimes. So it is not easily accessible. So not a lot of locums come and work. So most of the workforce is depend on LEDs, locally employing doctors. That's one thing. And we have these major highways, which are a lot of time congested with containers. There's a lot of accidents with the containers, and so traveling, commuting is quite not quite, but a little bit challenging. And not every LED has a car. So if you have to commute between the towns with the bus, it took around about 3.5 hours. And you can watch the whole beautiful sceneries, the fields, the smell of tons of cows. Or even for me to get grocery shopping, Indian grocery shopping when I was in Boston, it took me like 3.5 hours. So, and yes, so LED represent a big portion of workforce there. And the problem when we started was there. When we have problems like rota or pay or something like that, we have to go and talk to line managers, and the line managers sort out these issues at individual levels. We don't have a group. And each department appoint LEDs themselves in a different hospitals. So even when we are appointed by the same department, let's say elderly care or cardiology, and then when we don't know each other from another hospitals, even though we are working in the same department. And then the COVID makes things more difficult. We only know each other by eyes because everybody is covering with the masks and only online. So we only see each other with the eyes. Well, even if we met each other in the city center, in the town, we don't recognize. And so another issue is like I was at the time I was in acute medicine. So a lot of LED come and works in acute medicine as part of their rotation, and I have a chance to talk to them whenever I am free. And not like I'm talking to them and not working, but every time I have a spare time, I like to listen how they are doing. And then each and every LED say the same issue that we discussed this morning very broadly. They come up with the same issue again and again. There are some things I can help, which I'm trying to help. But we start to feel like we must do something because there is not a single individual having the problem. It's like the whole, all of the LEDs are having the same problem, the same challenges we are facing.
1 minute left.
Oh, okay. So we make a group, called Teams group. The first thing we ask about the question is a very important question for all the LEDs. Is it cheap? Is that free? Because Teams is free. You can have everyone have a team access. So we create the teams, and then we have this a lot of activities in the Teams group, and we put out a survey. The highlight about this survey is almost one part doesn't have educational supervisor, and almost 100% of them, or 92% of them has faced problems that can be reported as exception, but there is no exceptional reporting system in ULHT for LEDs, and then there is not all of them had intimity covers. So they are working in a very dangerous situation. So we presented this to, oh, thank you. Should I continue? Or?
You have negative marking.
Oh, it's all right. because yes. I come here, so sorry for overriding, but a little bit. I come here to share experience that what we are facing rather than to win a trophy and go back. So we presented to, thank you very much. We presented this to our, what is this called, JDC, JDF, and LNC, and we discussed extensively. We collected, recruited representatives, and then from the LEDs, and then we make our voices heard in LNC. So LNC get involved and make sure every LED goes supervisors, every LED goes eportfolios, and so on. So there's a stage challenges that is ongoing, even though what we have done. Sometimes in one area is like clinical supervisions, although we demand, and then every meeting we ask, but some of the consultants are reluctant to do it, sincerely lack of willingness, and some complain of poor job plannings or fundings, and so on. And exceptional reporting, again, even not all of our LEDs doesn't aware of how to do it. And is there something like exceptional reporting? They don't even know. And again, intimity cover that our LEDs doesn't sometimes want to pay or doesn't aware of that we should be having intimity cover for our safety. So I would like to also thank from here Dr. Babu, who is DDME, who organized these LED team groups, and Dr. Katarina, who is my co-colleague in organizing this. Thank you very much.
Right, thank you. I don't think we have time for the Q&A session now. Sorry about that. I would like to welcome Dr. Pratima Gogineni over to the stage. Dr. Gogineni's topic is a rare presentation of painted large atrial portal shunt in adulthood.
Good afternoon, everyone. I'm Dr. Pratima, one of the trust grade CTs in HVB surgery at Leicester. I'm going to present a rare presentation of a patent large atrial portal shunt, which is vertical vein, which is presented in adulthood. And this is an infracardiac type, which makes it a very rare type. So a small introduction. So the total anomalous pulmonary venous connection is a congenital condition where the venous system, where the pulmonary veins usually connect to the left atrium, but in sometimes the direct connection to the left atrium, instead they drain into the right atrium, and it constitutes about 1 to 1.5% of total congenital heart diseases. Based on different associations, there are different types which we will discuss about in the coming slides. And so the most prominent of these is the vertical vein, which is found in supra and infracardiac varieties. I'll mainly discuss about infracardiac because this is infracardiac type. Here, the pulmonary veins connect through either to the portal vein or the inferior vena cava. And in this case is a second case of delayed closure of the vertical vein in the adulthood. So this is a case of 32-year-old female. She presented at the age of 27-year-old. Until then, it's okay. Sorry. So she was diagnosed with infracardiac total anomalous pulmonary venous connection at birth. She had a repair, but the vertical vein was not closed off. And her childhood was okay, but she had a severe episode of pneumonia in 2016. And at adulthood, she presented mainly with the shortness of breath, especially on the sleeping on the left side, and fatigue and breathlessness on exercise. And subsequently, she had cardiac MRI. After multiple visits, they found out that the vertical vein is still patent. And the MRI in 2013 diagnosed it, and her symptoms progressively got worse. Owing to the size of the vessel, the MDT team decided that they're going to go to the intra-abdominal approach, and that's when the case was discussed with our team, the HPB team, for the ligation of the vertical vein. The investigations which were done is the cardiac angiocongenital anomaly study, which confirmed that there was normal pulmonary artery pressure and no obstruction of pulmonary venous confluence, which are usually the complications seen in these cases. But she did not have any of these complications. And the CT scan, the triple phase CT scan showed the large vessel. In the first picture, we can see it's the white arrow. This is the vein connecting the right atrium to the portal vein, and the second image is the 3D reconstruction with CT scan. Here we can see that the blue arrows, which is showing the vein connecting the right atrium to the portal vein. So the treatment, as I said earlier, the endovascular approach was found to be unsafe. So they went for intra-abdominal approach, and the laparotomy and ligation surgery was done in 2021. And post-surgery, she was in ITU, and then she recovered well and was discharged in a week. And in 3 months' time, they did an echocardiography, which showed good systolic function in both the left and right ventricles, while right ventricle mildly dilated. We did have a follow-up after 1 year, that was a couple of months ago, and she's completely recovered well. She's back to the gym, and her exercise tolerance has gone back to before this episode. So the discussion is, as I said, there are 4 types of these. The type 1 is supracardiac type, and infracardiac. And so the long-term, sorry. I did. It's okay. So I'll quickly discuss about the vertical vein closed off. So we might have a question that why don't we close off the vertical vein at the earlier age? So the reason is there are multiple theories. The first one giving that the patent vertical vein will act as a temporary reservoir until the left atrium and the heart will grow up, which will decrease the load on the heart. And in obstructive cases and the non-obstructive cases, as a result, low cardiac output is a significant problem despite the surgical techniques. And it will, usually the post-surgically, hemodynamic instability. Okay, I don't want to negative mark, so I think I'm going to end there.
Thanks, Pratima.
Thank you. Thank you.
Obviously, it's a very complicated case, and we are quite a few experts here in the particular subject we're talking about. So the main question is, in terms of symptomatic presentation, she presented at 32, and this was identified very early in the stage. And you mentioned that there was some right ventricular dilatation. Yet, after a correction, there was full recovery. So what do you think is the right stage for correction or identification of this sort of anomaly? And what would happen if it was delayed, further delayed, where the right ventricle becomes more dilated? And would you get recovery of function after correction?
I think the main complication is the pulmonary artery hypertension, and the hemodynamically patient will go unstable. The longer we live, the recovery might be not so good as in her case. Here, even though she presented in 2013, they did not quite go to the surgery because the symptoms were okay and she was stable. It was only when she was not coping up even with the day-to-day activities, they did, owing to the advantages and disadvantages, they thought that the surgery is better. I think even now there is always a complication of pulmonary artery hypertension, but as we said, there are not many cases and there is no protocol or a type treatment that we do for everyone. It depends upon the individual case. And even I had a doubt that why they didn't go earlier, and I did have this discussion, but it was quite too much for my level. I didn't understand a few things.
Thank you very much.
Thank you.
Thank you, Pratima. May I now call upon Mr. Sashi Kumar, who is going to present on compliance with GMC guidelines on intimate examination and chaperone.
Good afternoon, everyone. Every year, the cost of clinical negligence is rising at an alarming rate. The cost of clinical negligence between 2020 and 2021 in England alone was £2.2 billion. And this is proven to be a substantial burden for the NHS. Well, I'm here to present a topic which not only reduces the burden, but also could save us from litigations in the future. Having said that, my name is Dr. Shashi Kumar, and my topic of presentation is compliance to GMC guidelines on intimate examination and chaperone. We'll be looking into the background, few terminologies, what the GMC says. We'll look into the project, how it was done, the inclusion criteria, and the results, and if there were any changes, what about. First of all, let's look into the terminology, intimate examination. I'm sure any one of us will think about intimate examination as examination of the private areas, including the rectum, breast, and the genitalia. But is that all? Well, you'll be surprised to know that GMC includes any examination where it is necessary to touch or even to be close to the patient. Yes, that's what they say, GMC says. And once we know that we're going to do an examination on a patient, what are we supposed to do? The first thing is explain why this examination is necessary. And next, you have to explain what the examination will involve and gain consent from the patient. And lastly, offer the patient a chaperone. Having said that, let's look into the term chaperone. Who is the chaperone? Well, chaperone is anyone, it can't be anyone, it can be only a health professional appointed by the trust. GMC says that, it clearly says that any of the patient relatives or any of the attendees for the patient can't be chaperone. It has to be a health professional appointed by the same trust. Well, what's the role of the chaperone? He is mainly there to reassure the patient as intimate examination could be stressful and discomforting for the patient. As well, they have to be sensitive and respect the patient's dignity and confidentiality. Other things are they have to be familiar with the whole procedure, and they'll have to stay for the entire procedure and be prepared to raise concerns if they're worried about doctor's behavior or actions. Well, once we define that, let's look into GMC guidelines. This is one of the most important slides as I've taken directly from the GMC guidelines 2013 March, our latest. What it says is when a doctor performs an intimate examination, he has to offer the patient a chaperone, irrespective of the fact that the doctor is of the same gender as the patient. The next important thing is you have to document the outcome. Well, what does it say? If the patient agrees for the chaperone, you have to document the chaperone's name and the profession. Well, what if the patient declines the chaperone? You have to document that chaperone is offered and the patient declined. Well, let's look into the project. The project was to just compare the clinical practices in a surgical assessment unit of chaperone provision and documentation of intimate examination against GMC guidance. If there was a divinity deficit, we would come up with a plan and reorder it following the intervention. Inclusion criteria was all the patients who came into surgical assessment unit between March to June 2022, who had an intimate examination and was recorded in the medical notes. What we looked for was the procedure explained and was the documentation of consent taken and whether there was any documentation of chaperone offered and the outcome. Well, nearly all documented the procedure and the finding itself, but surprisingly less than 20% documented that the procedure was explained to the patient and the consent was obtained. And less than 10% was documented that there was chaperones and what was the outcome. Well, this is not what GMC expect each individual of us to document.
1 minute left.
Our plan of action was we present the findings in CME presentations, we made out posters, we had small group sessions in the same trust. The main changes we brought about was changing the surgical clerking booklet to include the relevant information, with just the tick boxes where it could be easily done by a doctor without forgetting on a busy take. And reorder it following the intervention in some time to see whether it has brought about some change. Well, takeaway home message is always document what you have spoken to the patient and always offer a chaperone, irrespective of whether you're same gender as the patient. Thank you.
Thank you very much, Mr. Kumar. Over to you, judges.
Now, you really scared us.
Yes, I do know that. When first time I read this, even I was scared. I was like, wow.
So, yes, I'm so nervous now. And also, I'm also worried about whether you've got a chaperone for the question we're going to be asking.
I wish.
So, it's very interesting. Obviously, this is the GMC guidance.
Yes.
And, I'm sure if you ask everybody in the audience how many times we actually document that or the fact that it's been offered, it is quite rare. I know in private sector, there is a documented thing, but in the NHS, it would make life difficult. Now, when you fed this thing back, the fact that this is what is expected and your data clearly suggests that most people are not doing it, what was the reaction from your people who are listening to that? And did they how do you think that you will meet this GMC guidance in reality?
To be honest, the first time I presented, everybody was surprised. I had a bigger presentation which included few more cases, legal cases, which was dealt with. Doctors had to deal to because of the problems of improper documentation of consent and chaperone provision. The main change, like I mentioned, was the changes in the clerking booklet. This not only makes sure that it's documented, it also keeps reminding the doctors that it is something which is mandatory before examining the patient, before going close to the patient. So it creates a vicious cycle, and next time, even without a clerking booklet, they'll make sure they'll document that there's a chaperone and the consent was taken or the procedure was explained and everything.
Thank you. I think I'm really scared, but my question is, you obviously selected inpatient, but the big problem is outpatient, and also outreach clinic when individual consultants are going 60 miles away on their own, and hire a practice where it's not your organization. You can't take a chaperone with you, but we constantly have to do the clinic. So I know GMC guidance is one thing, but do you think the workplace guidance differs in that? I wonder what your workplace guidance was on chaperone, because we have a constant battle with our manager. We can't have additional resources just to chaperone.
Yes. I think just to...
You can answer the question then.
Yes, GMC says that if practical, we can offer a chaperone, but if not practical, we can mention that to the patient. As long as the patient is happy to continue without a chaperone, yes, we can proceed. But if a patient requests for a chaperone, we should not proceed, irrespective of the setting. Is that all? Thank you so much.
So that concludes our session. Thank you all for listening, and thank you all the delegates for your presentation. We will be announcing the winner towards the end of the conference.
Thank you, Meena. We're going to have a short coffee break now. So grab a cup of coffee, some snacks, and it will be followed up by parallel workshops, and you can proceed.
Hello. 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 Hi, respected delegates. I would just like to draw your attention. The coffee break is for 10 minutes only, not 20 minutes. So 10 minutes from now, I would request all of you guys to join your parallel workshop sessions. Parallel workshop session for the afternoon A1, which is on LEDs on facing disciplinary action against the NHS, would be here in the main suite, and the one for A2 is happening in the Tannis room. After that, everyone is requested to report back to the main hall in Grove Suite by 5 p.m., where we will have the oral presentation awards and poster presentation awards, as well as the end remarks. Hi, Uma. Yes. Huh?
Five year ending it, right?
Yeah. After end 5 minutes.
did you get more of the QR code?
No. I need to add something to that. Oh, no, there were so many last minute changes.
Is that the QR code there or not?
Which one was it? Oh, here, see, you've got the QR code. Is this the one, right?
Yeah.
I needed to add something on the form.
What's that?
I needed to add something on the form.
To the form itself?
Then I have to go to my one,
The
right?
EU thing, yeah.
Sorry.
Oh, you can do it on that, it's fine. Just maybe download the QR code before you log out of that.
Yeah. But the QR code will change, won't it? No. So it will stay the same, right? Yeah.
Put it on the...
Downloads.
No, I'll put it on the desktop for you, so it's easy.
Just right here. Thank you very much.
That's alright. Cool, do what you want to do.
Yeah,
I'm going to go outside for some sun for like a
I
minute.
know, I understand. I need to go out.
Let's go look at the sky.
I have the evening after this. I have one break. I'm coming after evening, hosting the evening one as well. So
Damn. Well, that's all sorted now. Screen sorted. That will stay there.
that will stay there. For
Yeah.
the,
This
thank you
will
very much.
this will go. These will go. But I think if you got a DJ on as well, let's bring in a PA. Cool. I'm gonna mute that.
I might. Yeah, I don't know what to say about the DJ. Yeah, just the microphone, I think.
It's on.
It's on, all right. Huh? In a bit. Yeah. Yeah. Just.
medicine consult.
There we go. Thank you. Hopefully we'll not try to get you to get to sleep. So this is a workshop, which means that it's very interactive, and which means that it would be very beneficial that we have a roving mic, so that people can ask questions and interact with us. And also, if people want to move forwards, it'll be very useful. So thank you, Uma, for the introductions. I'm Joydeep. I'm a consultant in Uma, and I also am a medical director for Medical Defence Shield. Dr. Matthew is popularly known as the agony aunt of BAPIO. He knows how people get into trouble and what we need to do to help them. He's the national vice president of BAPIO, and he's full of knowledge and wisdom. The main topic that we want to explore today, so I have no slides, you'll be glad to know, not a single slide to show you. The topic we want to explore is how to help and how to find out when doctors are getting into trouble for employment-related issues, for conduct-related issues, for patient complaints, coroner inquests, GMC stuff, how these things intermingle and what help and support you may require. And we will obviously tinge it with our experiences from Medical Defence Shield of having helped doctors formally for more than 12 years now. Medical Defence Shield was set up in 2010. We have thousands of members now, and thousands and thousands of cases that we've helped with. So we've got a load of experience. The way this will work is for me to introduce, which I've done, and for Dr. Matthew to give you an example of how doctors can get into trouble. And then we will explore as a workshop your questions and certain solutions and what we can do to not get into trouble. And if we do get into trouble, how do we get out of trouble? So that's the brief we have. We have half an hour, and it'll be really useful that we speak in reaction to what you want to learn from us. So over to you, Dr. Matthew.
Now, I'm not going to be speaking. I'm going to get you to do all the work. Is that okay? For that, actually, it would be helpful actually if you all came forward, so that actually, come to the front seats, please. So tell me actually, what is a trade union? Anyone from the audience, what do you mean by a trade union? Anyone from the audience? Does it mean that actually you don't know or you're shy to answer? Trade union normally deals with issues with employment. Issues with employment. What is a medical defense organization? Anyone from the audience? You are all relatively new to this country. Many of you are relatively new to this country. Probably that is why you do not know. In simple terms, medical defense organizations deal with issues related to patients. For example, let us say a patient makes a complaint against you, and you go to your medical defense organization, and they are the one who are going to guide and advise you, help you in dealing with that issue. Now, the other question that I'm going to ask you is actually, who in the audience is a member of a trade union? Please lift up your hands. There will be more people actually. So I can only see about 5, 6, 7 people. There has to be more. He is a member of it. Oh, she is not. She is retired. So are there only 7 people who are who is a member of a trade union? And we have got about 70 people in the audience. Now, what is the likelihood of you needing a support from a trade union during your career? Do you know? You think actually that you will not get into difficulty. No. I am telling you now, you will all get into some sort of difficulty at some point in your career, which requires help from a trade union. And let me now ask you, who is a member of a medical defense organization? Not even half. Not even half. Huh? See, Joydeep. Now, again, the question that I'm going to ask you is actually, during your long career that is in front of you, what is the likelihood of a patient complaining against you? We are human beings, aren't we? We make mistakes every day of our life. Even though we are doctors, we do make mistakes. And that is where you will need support from a medical defense organization. If you are not, join one today. Join a trade union today. Now, with that introduction, these are actually the scenarios that I am going to give you are real life scenarios. Now, you are actually a junior doctor in a medical ward. A 45-year-old male gets admitted with 7 days fever and cough. And as part of the investigation, you do a chest X-ray. And luckily for him, he gets better the next day and is discharged. 2 years later, he comes back with secondaries all over his body. And you look at his X-ray from the last admission and you see a coin lesion. Now, the patient complains against you, or your medical director makes a complaint against you. What do you do now? Now it's your job to tell me the answers.
Call it defensive mean, yes, but that is the right answer. But half of you don't have a defensive. Uma, there is someone with a hand up there. So the situation is that you clock this patient up for an hour in the night, prescribe some antibiotics. 2 days later, someone discharges them. You order a chest X-ray, may or may not have reviewed it. They come back 2 years later with a complaint that you missed my cancer and I'm going to die. So, Uma, this gentleman here had his hand up.
So, one of the chest X-rays, eventually, within the next 6 months, be reported by a cardiologist or an X-ray.
It should be, but yeah, go on.
For example, lesions that are not.
I can't hear you.
Lesions that are not visible to unexperienced eyes could be picked up by other fail-safe measures like radiology.
So, what is the GMC's stance on whose responsibility is to check investigations?
The requesting party.
Good. So the X-ray was reported 2 weeks later as, let us say, there is a suspicious lesion. We recommend that please repeat a chest X-ray after 6 weeks of therapy. But that was not checked.
Here.
Apologize to the patient and admit that this was something that should not have happened in the first place, and if this has happened, try to explain to yourself, be empathetic with the patient and try to give patient about the next line of management, available options, and try to settle down the dust with all of the synthetic and the synthetic way, but if still patient wants to go ahead, then you should explain him what we should go ahead. The first step is to admit and to apologize to the patient. This is what I would have done in first place, because I have done something and there is proof that I've done it. So it's better to be apologetic and be empathetic and try to explain your shoes, try to explain that this is something that would have made a change in all those things.
I think being open and honest is the right option. However, this is a patient whose cancer was missed and they were to die. So they say, it's all very good for you to apologize to me, doctor, but I'm going to now report you to the police because you're going to give actually, this is attempted murder. I'm going to die because of your mistake. And as it happens, this was 2 years ago, now you've moved trust and gone to another place now.
Then he has all the right to escalate this thing.
So it's your fault, then, is it?
In the beginning of the career, we are not that much expert, we should pick up each and everything, so that's why we are still in the learning phase. So that's why I re-explain and try to put myself in there and discuss with one of my colleagues, especially the registrars and the consultants, and try to.
You're asking for help, which is the right thing to do. You're being open and honest, which is the right thing to do. But it does not solve the problem because of the other reasons. Because the patient has come to harm and they are upset. And of course, if it was your brother or your sister whose X-ray had been missed, and 2 years ago the cancer would have been picked up, they would have a chance of 10 years survival. Now it's grade 4 tumor and end of life, etc., etc. They want compensation, they want to report you to GMC, they are not happy with the apology. Lots of problems to solve there. But hold that thought, very important. Any other points anyone else wants to make? So we've heard two very good comments. Okay. Do you want me to?
Yes. No. I think, is this a medical defense problem or an employment-related issue? Is it an employment-related issue or a medical defense issue? Now, interesting. Now, let us say actually the trust takes it up. The trust takes it up and actually starts disciplinary action against you. Is that then an employment issue or a medical defense issue? So there is a fine line between this sometimes, isn't it? I'll tell you actually why I say this at the end. Joydeep, shall I go to another scenario?
Should we? Yeah, I think we can discuss a couple more scenarios.
Yes.
And then we can come up with somewhere in the end. But you can see it's becoming quite delicious, isn't it? There's a patient complaint. There might be a GMC referral. The medical director might say, actually, it was your responsibility and your conduct has fallen below standards. So we want to take a disciplinary action against you. We want to review all the cases that you've seen, what all mistakes you've made. Suddenly it becomes quite interesting. And the police might come knocking at your door and can I see my man? Next scenario.
Next scenario. Now, you are now in ST4. And you know, every year your salary goes up incrementally. And for some reason, Claire is here. She will tell me that doesn't happen in her trust. You are now ST4 and you are still on the salary of ST1. And you write letters after letters to the trust and they either respond or the response is very lukewarm. And this is actually a real scenario I'm telling you. What do you do now? Because you kept on writing to the trust and the response is not very good.
That's where BMA comes in handy. Escalated to BMA if you are one of the members. So these are some things like rota-related issues, pay-related issues, your personal things against the trust or something that you are facing difficulty. BMA plays a very crucial role in these aspects so that even in most of the circumstances that people think about paying 25 to 40 pounds or whatsoever, the scale is according to that and they don't take up BMA. So BMA is like very good platform in sorting out these kind of issues.
So this is what I was saying actually. You think that this will not happen to you. This will happen to you at some stage in your career, and you will need professional support. You need a trade union to support you. Joydeep.
Yeah, absolutely. So what you need is an employment advisor. And BMA has employment advisors. There are other organizations as well which have employment advisors as well. But if someone is not responding to you, then you need to go to your employment advisor and say, why is this not happening? Now, one of the things which is related, which probably affects most of you more than anyone else. Now, if you train in the UK, you go through your F1, F2, F3, you've got a very clear track record, you know exactly how many years you spend, you get to the right salary scale. A lot of you, and a lot of members of MDS, come to us because they've had 3 years of experience in India, 4 years working in Pakistan or Egypt or Nigeria, and they've worked for 6, 7, 8, 9 years. They come here, they start off as a SHO or clinical fellow. Though we know that you can't call anyone SHOs anymore, but this is life. And then they say, well, actually I did 3 years of MD and I've done 2 years of senior residency. I'm working at SHO level and I'm getting paid for year 2 doctor, and what do you do about this? And then you go back to your trust and you say, well, actually you should recognize my previous experience. What do you do? It can be quite an interesting argument to have. And no one wants to pay you more money. You're doing the job. Why should you pay you more money? Yes, eventually you'll earn more. A lot of problems, particularly with international doctors. So MDS, I would definitely say we have employment advisors. We know exactly what problems you face, what processes are required, what is it important to recognize previous experience so you get on the right salary scale. Contractual issues, special needs, how do you go for compassionate leave, for example. You have to go outside of India, outside of UK to India or to Pakistan or wherever else. And usually it's marriages or funerals or something like that. And how to work with the trusts to ensure that they understand how the systems work in those countries. Because here, for example, if someone has lost their grandparents, you would get a day off, then you come back to work, and there will be a date for the funeral where you go there. But sometimes people here don't realize that actually in the subcontinent where you're from, the funeral arrangements are very different. And you need times off in a very different manner. And how do we negotiate that? How do we sort of work on that? So all these things come before as well. So it's important that, when we are having those discussions with your employers, we understand where you're coming from. And we understand what to tell them. And most employers are reasonable. Most, not all. That's scenario 2. And we'll come back to scenario 1 later.
If you are happy to answer this question, actually, the scenario that Joydeep was telling about is actually a doctor who comes to this country who had about 10 years experience in, let's say, India or Nigeria, and he was working at the level of a consultant. And obviously, his first job in this country will be at ST1 level or ST2 levels. And what sort of salary scale would a trust put him in?
So off the top of my head, sorry. Off the top of my head, I don't know the exact scale that they put him in, but that it would be in. It wouldn't be at an equivalent consultant kind of rate, is what I would probably say that they would do.
If I remember correctly, there's not a strict rule, but there has been guidance issued by the Department of Health to consider seniority in other countries. If you ask me to find it, actually, it's a document from years back, so I wouldn't be able to find it. There was a document.
So I think that this is one of the issues that we've got, isn't it? And that's what we've been talking about today, is that there are documents and there are guidance. There are different things that are probably happening in practice. And the other thing that I would also say is that I think that rather than things happening with a level of consistency, that it often depends on what that doctor has come to do and what the need is, and that will probably often be a determinant of the salary that is paid. I'm not saying that's the right thing, and I'm not saying that that should happen. I'm just being very honest about, I think, of what a lot does actually happen in practice. So rather than it being, these are the guidance, this is what should happen, this is what should happen in all sets of circumstances, and it does. I think the guidance is there, but what actually happens in practice depends upon the specific set of circumstances. Is that an honest answer?
It is a very honest answer, and actually that's the answer I wanted to hear, is for the sake of everyone, when you're getting into these type of negotiations, there is no clear guidance. And unless you're a skilled negotiator, and you know what you've done in the past to convince people, you will not get the results you want. So, because majority of MDS's members are international graduates who have faced these problems, you become slightly more experienced, let's say, with negotiating these very interesting scenarios. So it's quite interesting. So that's scenario 2. And if I can think about Kumar.
And it also depends on the specialities where you need it actually. If you think, if you say that if you go to a specialty where there is huge demand, then the manager will sit with you and be happy to negotiate. It all depends on which specialty you are looking for. Am I right?
Well, obviously it's always to do with demand and supply. But even within that, I think there are ways, because if you don't ask or you can't be persuaded, then you will get the bottom salary. Easiest way is not to pay you any more than what you need to.
The simplest thing to do is to have a much more transparent and equitable set of pay arrangements, because then that actually takes away the need for individual negotiations and for other colleagues within the NHS. That is indeed the case. So it's very clear, that's the job, that's the appropriate pay scale, and you're appointed within that pay scale based on your skills and experience. And there is some room for some negotiation, but it's negotiation with what I would call within reason, whereas what we're talking about is individualised contracts, and we need to get away from that and have a much more visible and equitable set of arrangements.
Absolutely, that is the ideal situation, which hopefully we will eventually achieve, and that's one of the reasons why we're having this conference today, to highlight that problem. But till that time it happens, you're still all here, and we do need to help you negotiate all of this. So hopefully eventually, raising this concern, we will come up to a standardized way of how we treat doctors who are not in usual training, who come through different training pathways, and how their experience is recognized. And I think that's one of the prime key areas we want to learn from this conference. But that doesn't solve the problem of the here and now. Yes?
In the meantime, get some support.
Get the right support, absolutely. Speak to people. Now, I'll give you one more scenario. We have time, and we're quite happy to run over unless you get sticky. So one more scenario was very interesting, and I was just standing outside and reading a poster. And I don't know whose poster that is, but it was about someone's Halo device. Anyone wants to claim that poster? A Halo device complication? No? Okay, so they're not here to present it. So let me present it to you briefly. So this is a 22-year-old chap who's had a road traffic accident. They've broken their C-spine, and the neurosurgeon decided that they want to put a Halo device to support his neck and head. So Halo device, for the uninitiated, is basically you put a brace on the shoulders and a halo around the head, and you create an external scaffold sort of thing to make sure that your neck remains straight. Part of that scaffolding is that there are screws which goes into your skull so that it keeps it very stable. Okay, so not going into details, but for everyone to know what a Halo device might look like. So those screws have to be tightened occasionally. And this gentleman is discharged home, and his mum is given the tasks of tightening the screws. And he comes back a few days later saying, there's some fluid coming out from here, and it's a little bit warm. And a okay, let's just have a look and let's do a CT scan. And they find that one of the screws has actually gone into the brain. And if you don't believe this, there's a lovely poster outside with a nice picture and a CT scan and an MRI and everything, and please read it. So it's all good. So, and there was one a young lady doctor who was just standing there who wants to be a neurosurgeon, and good luck to her. And I said, okay, now this is a situation here that you are a junior doctor. Your consultant has decided to build a device, and someone has put this up, and they've gone home and the screw has gone into their brain. Yeah? Good. So, what happens here? What do we do? Anyone wants to put a hand up? Not you, because your hand is always up. Someone else, please volunteer and tell us, in this situation, what is your next step? Yep, come on. I think we'll leave the mic on that table because everyone else is. Oh, there's one hand up there. Good, thank you.
Was the appropriate training for the mother?
Sorry?
Was there appropriate training done deeply for the mother how to and when to tighten the screws, and was it documented?
Good question to ask.
Was she able, or the carer were they able to retain this information? And did they, for example, practice on a dummy or
important to ask whether the training provided in maintaining it was correct or not.
Especially since it's very sensitive.
The brain is quite sensitive, yes.
No, sensitive issue, especially concerning disease spine.
So let's say that you speak to the lung. Did we train you? He says, of course. Are you trying to blame me? I did exactly what I was told. Go away, I don't want to talk to you. Next question. Somewhere there, I want to take it. So the minute you challenge them and say, did we train you? And you're asking them in a nice manner, and she says, are you trying to blame me?
It's not about the challenges and the...
But that's the response you get.
So the next question, the next answer is, are you the only one who's doing it, or is there somebody else? And at what point did the patient realize that he's supposed to come in? Because had somebody told the mom or the patient that if there is some fluid coming out, then you're supposed to come in. So were they informed about the possible complications of it or not?
So, yes.
And what's the delay? And if there is a delay, then why?
Okay. So that thing has a proper name. What do we call it in medical parlance?
Safety netting.
The safety netting, but there was another point that you made about explaining complications and stuff. What is that called? Informed consent. Good, okay, thank you. Hold that thought, we move to the gentleman here.
Yeah, that was the same thing actually I was going to mention about. It's basically when you're, I'm not a neurosurgeon, but obviously you're putting a device, you need to take an informed consent. And all these complications should be mentioned there, you shouldn't forget to mention all of these. So if I was in that place, I wouldn't worry because I already explained the complications to the patient and they've signed on it and they know that this is what has happened.
You wouldn't worry if it was there, yes?
When I say I would worry that yes, there's a complication happening, of course, but I wouldn't say that my job is at risk or something like that because we have signed on the consent that this is happened and it's been explained to them.
Provided that consent is there.
Absolutely.
And it is informed.
Yes.
And it is properly explained with the risks and balances and everything else. And there's a safety net.
Absolutely.
Correct. And the points made earlier today is what happened, try to find out what happened. So all of these things are important to understand. Time is up. Is there any session after this? We can wait for 5 minutes. We won't take more than 5 minutes. But the important thing here is that the patient now says, for example, actually, I think you did it wrong. You probably drilled the screw in too much. And I only tightened it exactly as you told me, and it's gone wrong. And it's your fault. It can become quite complicated, as you can see. Now this patient has got a screw in the brain, there's brain damage, there is, he gets epilepsy from it, there's lots of problems. And it is not always a very simple way to answer, because the first time you think, oh God, I've done this, did I put the screw in right, did I do the informed consent, did I write the right things, what exactly is the patient complaining about, how do I answer this? What you need is basically to go to a defense organization and say, listen, this is what's happened, this is what the statement I'm going to write. Can your medical legal experts look at it, tell us what is happening? Answer this in the right possible way, explain, apologize for what has happened, empathize with the patient and see what the problem is, take it from there. If that part is right, and the process has been explained correctly and all the gaps hopefully don't exist and you've done everything, documentation, everything properly, then it can become a learning situation, what to do better in the future. Was it just an unfortunate incident? And it stops, or change the record, it stops other employment-related issues and MSPS. So I'll pass on to Dr. Matthew for some closing comments.
The last comment is, medical defense shield, this is not an advert. I see that majority of you are not members of either a trade union or a medical defense organization. And there is one unique one which is both a trade union and a medical defense organization. Our stands are there outside Medical Defense Shield. Go and become a member today. And thank you.
Thank you all. I wish we could have spoken for more, but I've been told off.
Sorry. Thank you so much for your time, Dr. Grover and Dr. Matthew. It was very insightful. I hope everyone enjoyed the session and will be leaving today well-equipped in handling tricky situations in a tactful manner. Now we have the award ceremony and vote of thanks. Yeah, in 5 minutes, is it? Oh, sorry, it'll be in 5 minutes.
No. Yeah, okay. So since we have 5 minutes, thank you for someone being on Indian Standard Time. I was asked that can we discuss the first scenario which Dr. Matthew discussed. So it is a very interesting scenario where system failures need to be explored. And actually, if you have a good defense organization, they will be able to advise you on how to protect your system failures and how to build it up. So if you're a doctor who just requested an X-ray, which then turns out to be positive for something 2 years later, you should not be the one to blame, but you'll be surprised how often this happens. Most of you should have, and I hope you have heard about Hadisa Baba and how she got into trouble. All of us wrote a lot in her favor, even before for her as well. And as a consequence, I actually went to the Francis inquiry and we presented our case along with more BAPIO members. Dr. Mehta was there. You were there as well, Dr. Mehta. No. So anyway, so the idea was that it is important that you have experts who understand the context of an error. This person has definitely had an error, and yes, duty of candor says you have to admit the error. But then, the next step should not be finding a scapegoat, which is the usual and the easiest option for most human resource people, and unfortunately for some medical leaders, they will find who can I blame, who can I hand this on and forget about it, without having to admit that actually, was there discrepancy reporting system working? Did the radiology report come in time? How was the handover process? Who was the named consultant? Was there a checkup phase or not? Did the report go to the GP? Did they do something about it? Was the patient given any other safety genetic advice or not? And once you start exploring all of this, what happens is that instead of the focus being on the one poor SHO or junior doctor who did one small little error, you try to expose the whole situation in the context in which it happened, and that helps. If I have time, I could explain to you how one of our members, he was a new graduate from Pakistan who came, forced into giving sedation to an old patient. And he didn't quite know what was happening. Ultimately, the nurse injected 10 times the amount of propofol that was required in the patient died. And he came to us and wasn't even a member at that time, but he said we will help you. So we drafted the whole scenario, situation, everything else, and actually he got away. But I could easily have seen a person like that could not come to us at the right time, end up in jail. Because people have been put into jail for manslaughter. And no marks guessing, 12 people convicted for manslaughter. None of them had abundance of melanin. Let's put it that way. 5 minutes out.
Thank you very much. Thank you very much, Dr. Grover and Dr. Matthew. We are just waiting for the second parallel workshop delegates to just join us. So we have a couple of minutes before we begin the much-awaited award ceremony. I would just, inform the delegates here that we are coming up with this amazing program by the BAPIO SAS LED Forum. We are starting with the mentorship program. That's the Mentor and Mentee project. And Meena here is leading it, and we would be very grateful if anybody who is interested in becoming a mentor has a basic experience in NHS of at least 1 year, and we have all the details ready. Everything is ready. You just need to email us, and we are happy to enroll you as the mentor, so which gives you a kind of leadership role. And those who are new to the NHS, you're most welcome to be, join as a mentee, and we will connect you to the mentors. And that's the email ID displayed. And the second initiative is, of course, the clinical attachment. We all know it's a bit tricky when you are new to the system and you need some help. So with this regards, we are trying to connect the new NHS recruits or those who have just finished the PLAB exam in order to connect them with the consultants. So kindly email us to the aforementioned email ID. Spread the word to your friends and those who have already finished PLAB 2 or are waiting for the exams. Thank you very much. Please make note of all these. Thank you. Just a couple of minutes more, I think we are almost expecting the delegates to come to the main hall.
Hello, everyone. While there is some time, I thought I'll inform you about what are we going to do later today. And at 6:20, there will be drink reception just outside the foyers. And by 6:55 or 7 o'clock, we are trying to get here for our dinner. And of course, following that, we do have activities and most of the things, singing, dancing, all these things performed by healthcare professionals and doctors and nurses. And they are all from, almost all of them are from Leicester. And we do have a lot of people with multi-talented, skilled people. So we thought we would showcase all those things for you. And I hope you all would be able to enjoy the session. And I hope you all had a wonderful day. And of course, I learned a lot. I listened to various thought process, and we need to do a lot of work to move forward. And it seems like even though I am continue to speak, they are not coming. Yeah. Yeah. Okay. Thank you. It seems like they are coming, so we would start.
Sir, shall I start?
But we can.
Shall I start? Go down, no, I'll call you. Okay. People are still coming. We'll just give 1 more minute and then we will start our award ceremony. I think we should start now. Thank you all for attending the oral and poster presentation. Now we are going to begin our award ceremony for oral and poster presentation. I would like to congratulate all the winners. And may I please call upon Dr. Kantappa Gajanan and Shubhangi Barnwal to please come on the stage and give the prizes to the winners. Can everyone please be seated? We are going to announce the winner for oral and poster presentation. Thank you. We will start with our third prize first for oral presentation, which goes to Nang Hom. Nang, please, can you come on the stage? Congratulations, Nang. Second prize goes to Sashi Kumar. Sashi Kumar. Okay.
Shashi Kumar's friend is there. Can you ask him to come?
Sashi Kumar friend. Is there anyone who knows Sashi Kumar here? Can you please come on the stage and collect the award, please? I guess so. Okay. Okay. I think I've seen Sashi Kumar. Is he? Okay, that's not. Okay, we will move forward to our first winner. So the first prize goes to Amy Craig. Unfortunately, she had to leave for her shift, so she's not with us. So now we will proceed to the poster presentation awards. Is he? I don't think so. I don't think he's there. Yeah.
Thank you.
Thank you.
Hi all. First of all, I would like to thank everyone who's presented posters today. Now, I would like to invite Dr. Viju Simon and Dr. Parveen Dodamani to give away the prizes for the poster presentation winners. So the third prize goes to Dr. Fiza Saifullah. Congratulations, Fiza. The second prize goes to Dr. Priyanka Balasubramani. And the first prize goes to Dr. Gavin Reed. Congratulations, Gavin. Thank you all for attending the event, and thank you, Dr. Oh, I would like to call upon Dr. Shashi Kumar right now to collect his second prize. Congratulations, Shashi Kumar. Thank you all for attending our event. I would like to call Dr. Parveen Dodabani over to the stage to deliver the vote of thanks now.
Thank you, Lakshmi. That's a great responsibility, I must say, and I hope I don't miss anybody. So, good evening, everyone. It's my absolute honor and privilege as Secretary of the first National LED Conference to render the vote of thanks on behalf of BAPIO and the SAS LED Forum. I would like to begin with a quote, anonymous. A leader is one who knows the way, goes the way, and shows the way. I think you all know whom I am thanking now. It is our beloved founder, president of BAPIO, Dr. Mehta, who has been our guiding light, as well as Dr. Satish Matthew, Vice President BAPIO, for being our inspiration and pillar of strength. These stalwarts have not only been our inspiration for various academic activities of the BAPIO, but we are also really grateful for the enormous support and guidance in organizing today's conference. Thank you. I would also like to express our appreciation and acknowledge the support of BAPIO executive members. I extend our heartfelt gratitude to today's chief guest, Mr. John MacDonald, Chairman, University Hospitals of Leicester, for taking time out of his busy schedule and gracing this occasion. Thank you, sir. We would be lost in woods, I must say, if not for our mentors, Dr. Biju Simon, the National Joint Secretary of BAPIO, and Dr. K. Gajanan, the Chair of SAS LED Forum, who have helped in meticulous planning and execution of the conference. I would also personally thank them for giving me this amazing opportunity. Thank you. We are so grateful to have such an eclectic line-up of eminent speakers for delivering such fantastic keynote and workshop sessions. I also extend our appreciation to our distinguished panel members for their fruitful and constructive discussions. Thank you, everyone. And we also apologize to really rushing you at times. Very sorry for that. So I believe today we accomplished a quantum leap in achieving the BAPIO's vision, that is equality, by launching the LED Charter. We extend our sincere gratitude to Professor Indranil Chakravarti and the entire team who contributed to the Charter creation. Thank you. We are indebted to our gracious, benevolent supporter, Dr. Nick Kotecha and Randall Foundation, and unfortunately he could not be here today because of some personal reasons, but we really thank you very much, sir. We would also immensely thank our sponsors, the British Medical Association and Freedom Mortgage. We thank our collaborators, Medical Association of Nigerians across Great Britain, Association of Pakistani Physicians of Northern Europe, Nepalese Doctors Association UK, National Overseas Doctors Family Association, British Egyptian Medical Association, and Bangladeshi Doctors Association in the United Kingdom. Thank you, everyone. A special cheers to all our delegates. Thank you, thanks a million for coming here, and assembling from across various parts of UK and being the very reason for today's success. Thank you. I would also like to take this opportunity to congratulate the winners of the oral and the poster presentations, as well as the participants. I think participation is the first step towards winning, so congratulations to all of you. We all know the strength of the team is each individual member. The strength of each member is the team. So now it's the time to thank my amazing organizing team, wherein each and every member has multitasked and stepped up to the best of abilities after, navigating the long day, the night shifts, and exams. Yeah. So I really would like to say a big thank you to the joint secretaries, all the team leads and moderators of various sessions, well-being, keynote, and workshop sessions, and especially our social media and marketing team, Praveen and Siri. Big hand to you guys for being the face of this conference. I think it just created an ambience because of which you all are here. Thank you very much. We also acknowledge and appreciate the work of our budding NHS doctors who have been our volunteers for today's conference. We truly recognize your efforts and contribution to extend the hospitality to our dignitaries and delegates. Thank you. And now comes to the Commander-in-Chief, Dr. Shubhangi Parnawal. Amazing. So the chair of the conference, a budding young doctor, I think we all agree, Shubhangi, you have been truly amazing, and congratulations and well done. I would also like to express our appreciation to our catering team, as well as to Mr. Arvind Singh and Marriott Management for providing us with a great venue and supporting with both logistics and technology. I would like to end by saying, finally, I'm here. So coming together is a beginning. Keeping together is progress, and working together is success. So we at BAPIO and SAS LED Forum sincerely hope we have taken our first step towards success of achieving our goal of breaking down the barriers today. Thank you, everyone, and have a pleasant evening. Thank you. And I've been prompted to say, please do scan the QR code and give us the feedback. Thank you very much.
cardiac plan? Oh, let's sort this out.
So 7:30?
Yeah, 7:30. Because let give some मेरी घड़ी में अभी तो 7:15 15 मिनट में और क्या करना कर लीजिए आप
അതായി സിഗ്നൽ
I mean, I've done this stuff, but
Jum Num ta Rum ta dhalam kutak te kura de ta gradagradagradagada ta Jum ta ka jum jum ta ta kita ta 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 jum gradagradagam ta ta tanum ta 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 rum ta ta kita ta de ta gradagradagradagada ta rita ta dana ta ta runa ta ta dimi ta ta da jum ta tanum ta ta rum ta gadim ta gradagradagradagada dim ta tarigradagada ta jum dim da ta ta jum nam da ta ta jum tam ta kita dana ta de tangradagradagada dim ta tarigradagada ta jum dim da ta kita jum jum da kita da jum da jum jum da kita ta jum gradagradagada jum ta ni ta 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 dana ni ta ta tarigradagada ta dana ta ta jum ta dana ta de tangradagada ta tarigradagada ta jum dim da ta ta jum nam da ta kita jum ta dim tom nam da de tangradagada di ta dana ta ta tarigradagada ta dana ta dim ta tari ta dana ta ta di ta dana ta de tangradagada ta dim tarigradagada ta dim tarigradagada ta dim tarigradagada ta dim tarigradagada jum tarigradagada tangradagada tarigradagada dingradagada tarigradagada Ta jum num ta rum ta dhadam tak tak da ta jum ta takita ta da ta ta jum num ta rum ta dhadam tak tak da ta gida ta jum ta takita ta da ta jum ta ta num ta rum.
Don't stop for life. Glitter in the sky, glitter in my eyes, shining just the way I like. If you're feeling like you need a little bit of company, you met me at the perfect time. You want me, I want you, baby. My sugar boo, where love is hidden, the Milky Way, we're renegade. I'm like goody 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 sana, samana goody 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 sana. Bada 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 bada. I see us written in the stars. We can go wherever, so let's do it now and never. Baby, nothing's ever, ever too far. Glitter in the sky, glitter in our eyes, shining just the way we are. I feel like we're forever every time we get together, but whatever, let's get lost on Mars, yeah. You want me, I want you, baby. My sugar boo, where love is hidden, the Milky Way, we're renegade.
Hello, check. Hello. Hello. Hello, check. Hello, check. Hello. Hello. Okay.
check. Hello. 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 Check. Hello. Check. Hello. 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 അവിടുത്തെ മോണിറ്ററിനകത്ത് റിവർബ് കുറവാണ്. ശരി, പുറത്ത് Hello, check. Hello. Yeah. Hello. Hello, check. Hello. Hello, check. Hello, check. Hello. Need a bit more. Hello. Check. Hello. Check. Hello. Hi. Hello. Okay, that sounds better. Hello. Can you? Hello. Hi, everybody. Hello. Hi. I think you need a bit more. Hello. Hi. Hello. That's better. Hello, everybody. Hello. Got the mic.
Hello everyone, we're planning to start the event shortly. If everyone could kindly get seated, we could kickstart the event tonight.
Can I request all the guests to be seated in the designated table? We will start our evening shortly in 2 minutes once everyone is seated. Thank you very much.
Ladies and gentlemen, and welcome you all to this very special event. I am Anupama Vijay.
I am Anindya Bhumik,
the host for tonight's event. We all are here to celebrate the past, look forward to the future, and enjoy this very special moment. And over the years, we've grown stronger and bigger.
We stand here at an illustrious occasion as we, the BAPIO family, have successfully completed 25 glorious years of its excellence. And this wouldn't have possible without your efforts to make a blank material to what it is today. So first of all, before we go any further, I want all of you to have a big smile on your face and put your hands together, because you are the real champions of what BAPIO has become, and you are the reason we stand here marking this amazing occasion.
All right, guys, so let's all start with a loud round of applause. Can we do that, everybody, please? Yeah, so you are the crowd. You have just 2 ground rules, I would say. Anyone who comes on stage, we just need to make sure that we encourage them and support them to the maximum. Is that all right? Yes, okay. So without any further overdue, I would like to welcome each and every one of you on behalf of BAPIO, SAS and LED Forum. Should we start?
Yes, of course we shall start. As we all know, BAPIO has not only been looking towards excellence in career progression, but it's quite a culturally progressive family. We have very talented members, and I might say I have the greatness of having a really talented person beside me. Anupama Vijay, shall we start the night with you tonight?
Yeah, I think I would just start the night with a song from my side, and yeah, if that's...
Yeah, so just to give a brief summary for Anupama, so she's a medical registrar at University Hospital of Leicester, and she's really passionate about singing, has been participating in lots of South Indian music competitions, and has a YouTube channel. So can we all subscribe to her YouTube channel, please? Yeah? Thank you, Anupama. I'll take on the next.
Thank you, that's so sweet. Thank you. everyone.
Thank you, Anupama. Did everyone enjoy the first? Yeah, are we subscribing to our channel then? I've subscribed to our channel, all right? So let's give a big round of applause. So without further ado, we do have more acts coming up. Let's keep the tempo and energy high for everyone. So just a guess, when we think about broken bones, going to a doctor to get our bones fixed, what do we think of? Pain, screaming. What if the opposite happens? That someone who's fixing you is singing a nice song to you. Instead of painkillers, you get a good song. So next act, Dr. Kumar Naik is an orthopedic surgeon, and not only that, he's passionate about singing, has acted in Bollywood movies, is a producer, passionate about community work as well, and as I have heard as well, has won the community election last time as well. So man of many wonders. Can we please welcome Dr. Kumar Naik on stage, please? Thank you very much.
Hello. That's a generous introduction. Thank you very much. After Anupama has sung the song, now I'm getting a bit of butterfly in my stomach. You guys, I don't know what you guys are going to do. Don't throw the knife and fork and things. You can throw the tissue paper or the towel, but don't throw the metal, please. And also, this is a bit fast song because it's a slightly, maybe a late night song, but I'm singing a bit early, and Anupama and Ravind has given me the slot. Without much of ado, let's start, sir. Give me a minute, please. Give me a minute. Sorry. I will forget the lyrics, sorry. Then this music will go on and I'll be dancing with you. Sorry, give me a minute. This shows how much tense I am at the moment. Okay, let's do it. You remember this song?
Bianca, the most beautiful girl in the world. Watch this.
1990 song. मस्ताना प्यार मेरा दीवाना भूल गई हमसे ना हो जाए रूप तेरा मस्ताना प्यार मेरा दीवाना भूल गई हमसे ना हो जाए Leicester is today rocking tape.
Worldwide accepted, beauty and brains with the heart that's connected. Me say room with the rock. Must find a woman who drive me crazy. I'm your Tijuana. We could treasure hunting for your love, 'cause I'm not. You run on my style like Shana. Yo,
मस्त समा है आज नशे में सारा जहां है नशीली मस्त समा है आज नशे में सारा जहां है आज नशीली रागम बहलाए रूप तेरा मस्ताना प्यार मेरा दीवाना भूल गई हमसे ना हो जाए रूप तेरा मस्ताना प्यार मेरा दीवाना भूल गई हमसे ना हो जाए है हमको समाना, दूर ही रहना, पास लाना। हमको रहा है हमको समाना, दूर ही रहना, पास लाना। ऐसे मगर ये दिल को समझाए, रूप तेरा मस्ताना, प्यार मेरा दीवाना, भूल कोई हमसे ना हो जाए। रूप तेरा मस्ताना, प्यार मेरा दीवाना, भूल कोई हमसे ना हो जाए।
लिस्टर आज कितना अच्छा LED BAPIO, the rocking the BAPIO LED is rocking today.
Thank you very much. Thank you. And I don't have a YouTube channel, so you don't need to subscribe. Now you know that why I don't have a YouTube channel. Thank you very much.
Thank you, Dr. Kumar. That was indeed a very lovely performance. I think you're underestimating yourself. You're a really, really good singer. Isn't it, guys? Just give him a loud round of applause.
These anchors been lovely in generous compliments. Thank you.
Thank you so much. Thank you. So, next on stage, we have a dance performance. I think it's something that everyone can enjoy, everyone can feel as well. So we have Dr. Akash Prakash. He's a foundation level doctor working in Leicester Royal Infirmary, and he's doing an Indian art form called Bharatnatyam. I would like to invite Dr. Akash to the stage to give us a small description about what he's going to perform.
Namaskaram. My name is Akshay Prakash. Sorry, not Akash. I hope you all are having a lovely evening. My name is Akshay. I studied Bharatanatyam in London under my dance guru, Shri Prakash Yedugude, who's a resident Bharatanatyam teacher at the Bharati Vidya Bhavan, West Kensington. So I'm going to be performing a Pushpanjali, which is normally an invocatory item in any Bharatanatyam repertoire. It's just an offering to the stage, to the lords, and the beginning of any dance performance. I hope you enjoy it. Thank you very much.
Tajam tam tam, dittam tajam dhim dhim, tam tajam thom thom, tajam jam jam Dittam tajam tam tam, dittam tajam dhim dhim, tam tajam thom thom, tajam jam jam. Tajano dittam tajam tam tam, dittam tajam dhim dhim, tam tajam thom thom, tajam jam jam. Tajano dittam tajam tam tam, dittam tajam dhim dhim, tam tajam thom thom, tajam jam jam. Tajano dittam tajam tam tam, dittam tajam dhim dhim, tam tajam thom thom, tajam jam jam. Tajam tam tat tajam dhim tat tajam tam tat tam tajam tajam jam jam tajam tat tam tajam tam tajam dhim tajam tam tajam jam jam tajam tat tam jam 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 tam jam 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 tam jam 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 tam jam 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 tam tari tari tajam thana thana tajam janu janu tajam tam tari tari tajam thana thana tajam janu janu tajam tam taka tam 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 taka tam dhim ta dhim ta taka dhim tom ta taka tom ta janu ta dhimi ta taka jam taka tari tajam dhana ta jam tari ta dhana ta janu ta dhimi tam taka tari tajam ta dhana ta jam ta tari ta dhana ta janu ta dhimi tam ta tari ta dhana ta janu ta dhimi tam di ku ta dhim dhina to taka di ku ta dhim dhina to taka di ku ta dhim dhina to ta tari ta dhana ta janu ta dhimi Tajam tam 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 tajam dhim dhim tam tajam dhom dhom tajam jam
Akshay, that was a magical performance. I think we still feel like seeing more of Akshay's performance. I think that was a very short one, but that was really magical. I think Bharatanatyam is a dance form that needs a lot of footwork, the posture. I think you've got great art, and you're really good, Akshay. So it's a real pleasure to see this art form in front of all of us. So thank you so much. And next, I think it's dinner time.
Yeah, we have seen a wide range of performances already, but there's loads more to come. But let's not do it in an empty stomach. So everyone, enjoy the dinner for now. We will catch you back later. Thank you very much.
Thank you. while we have the dinner going on, I think we should invite Mr. Dilip. Dilip is a singer, a performer, a drama actor, and he's also acted in TV serials and movies and whatnot. To add to his laurels, he's also awarded the News Person of the Year in the UK in Malayalam newspaper in 2013. I would like to invite Mr. Dilip to the stage now. Being a stage artist, I think he's also got a stage name. That's the way he's known amongst his art colleagues. So his stage name is Mr. Dilip Elena. Is that right? All right, let's listen to Dilip's song now.
Hello. Thank you guys. Thank you for inviting me for this auspicious event. I'll try my best. I'm going to sing an old Hindi song. And I already heard the song of Arun Kumar and Anu. So we'll try my best. Please forgive my flaws. Thank you. मैं शायद तो नहीं, मैं शायद तो नहीं, मगर ये हंसी जब से देखा मैंने तुझको मुझको शायरी आ गई। मैं शायद तो नहीं, मगर ये हंसी जब से देखा मैंने तुझको मुझको शायरी आ गई। मैं आशिक तो नहीं, मगर ये हंसी जब से देखा मैंने तुझको मुझको शायरी आ गई। मैं शायद तो नहीं। प्यार क्या नाम मैंने सुना था, मगर प्यार क्या है ये मुझको नहीं थी कदर। प्यार क्या नाम मैंने सुना था, मगर प्यार क्या है ये मुझको नहीं थी कदर। मैं तो वो जा रहा उलझनों की तरह, दोस्तों नहीं रहा दुश्मनों की तरह। मैं दुश्मन तो नहीं, मैं दुश्मन तो नहीं, मगर ये हंसी जब से देखा मैंने तुझको मुझको शायरी आ गई। मैं शायद तो नहीं। सोचता हूँ अगर मैं दुआ मांगता, हाथ अपने उठाकर मैं क्या मांगता। सोचता हूँ अगर मैं दुआ मांगता, हाथ अपने उठाकर मैं क्या मांगता। जब से तुझसे मोहब्बत में करने लगा, तब से ऐसे इबादत में करने लगा। मैं काफिर तो नहीं, मैं काफिर तो नहीं, मगर ये हंसी जब से देखा मैंने तुझको, मुझको दोस्ती आ गई। मैं शायर तो नहीं। Thank you, thank you.
Thank you, Dileep. That was an amazing performance.
Hello. Hi, everyone. Hope you're having a good evening. My name is Jatin Naidu. Today I'll be playing sax for you. I'm a third-year medical student at UCL at the moment, and when I heard about an opportunity to play here, it was a big yes from me. So today I'm going to play a mixture of songs, so some Western songs, some Eastern songs. The first one is called Nothing's Gonna Change My Love for You. Some of you might know this, so I hope you enjoy. Thank you.
Jatin, that was really awesome. I was just sitting on that table and I've heard one of my friends just say, I've never seen anyone playing saxophone. And I think it's tough. How would you say too, if there's any young people out here who wants to learn saxophone?
Yeah, I would say go for it. But yeah, breathing's an issue. But apart from that, finger work's okay, yeah.
I think you were so humble in saying that you've got an opportunity, so you thought you'd come up on stage. But I've got a paper full things about Jatin, so I think I should say that. I think he's got a diploma in saxophone and also in piano, and he's auditioned for the British Got Talent, guys. He's a great talent. And he's performed on the central stage in Leicester Mela and also performed the BBC Asian Network and the Sabras Audio. And he's also got his own jazz group. And you've been doing gigs in colleges in London. Look at him. I think it was our honor to have you on stage, Jatin. And you're really doing well. And all the best for your future. Thank you, Jatin.
Also, I've also got a YouTube channel, yes, yeah. Thank you. I've got a couple more songs, if that's okay. Yeah, thank you. I'm going to play some Bollywood now, and then, yeah.
Yeah, thank you.
Thank you, thank you. I've got another one lined up, so please stay on the stage. Hope you like this one. Thank you, everybody. Okay, another one.
Wow. Isn't this amazing? So listen, I just wanted, this is the raw Indian talent, isn't it? Amazing. And for those, I was telling Richard, and sorry, Richard's wife, and oh, sorry, okay, I made the wrong pair. Okay, I'm done. Kill. So let me tell you one thing before Ramesh comes here. Okay, this song, for those who haven't seen Bollywood, is about smoking cannabis. That is what it is, dam maro dam. So I want to, but listen, I'm the chair of BAPIO, so I should be respectable. No confessions here. Not even in Punjab, Patiala. Nothing about that. But listen, what an amazing talent. But on behalf of BAPIO, Ramesh, myself, Satish, Joydeep, Parag, Biju, all our executive team, absolutely, Arvind, who's not here, we're so delighted. You know, this is the essence of what the Indian tradition is. Get everybody together. Let's all mingle. Let's all enjoy the day. Let's fix all those inequalities that there are, but also break those bloody boundaries, you know. Let's all get together. None better than to do it. Thank you. None better than to do it in Leicester at this particular time, because we can't let a small number of bad eggs spoil it for us. Whether it's India, Pakistan, Sri Lanka, Nepal, wherever we are, UK, we're all citizens of the country. So thank you very much, folks. Thank you. Thank you. And thank you so much.
Thank you, everyone. That was really an enjoyable moment. Thank you, Jatin, for setting the mood. I just want to draw everyone's attention. The main course has been served. We said that we would give a break for the dinner, but we served our appetizers as well with music, just to give you a taste of how the night is going to be. So as the main course are being served, I would request everyone to enjoy the main course, and as soon as the desserts are started, we'll serve you with more sweet music and melody. Thank you, everyone. Good evening, everyone. I hope everyone's enjoying their dinner. And as I promised before we serve sweet desserts for your taste buds, we have sweet music for your ears. So if you've heard him play before, but we have not given him the introduction, I'm going to request Mr. Akshay to come up on stage again with his amazing violin talents. Mr. Akshay has been playing violin for the last 14 years and has been performing as an independent artist over the years, along with several accompanying bands. He has won the Radio Mirchi Freshers Award in 2016 and various inter- and intra-collegiate cultural fests. He is a finance student at the University of Leicester, so when he's not doing complex maths or solving our money problems, he's playing the violin. So let's welcome Akshay on stage.
Hello, ladies and gentlemen. We do have a special guest and she's going to sing for us. Can I invite Dr. Ananda Dev, Medical Director of ICS Black County, going to sing for us. Thank you.
This is very, very unexpected. Hello everyone, please excuse me, this is very sudden, but I will sing a few lines. I'm about to sing a song in my mother tongue Telugu. This is the first language I learned. So please excuse me for any, rustiness or any mistakes in singing. And I will have a look at the lyrics while I sing. So please bear with me. I might not sing the full song, but I'll sing a bit of it. So this song celebrates the importance of art and singing, and that we should be valuing art not because of the monetary returns it gives us, but because of the joy it brings us, the emotions that it arouses in us. లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను, లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను, మధుర భారతి పద సన్నిధిలో, మధుర భారతి పద సన్నిధిలో దిగే తొలి పువ్వును నేను, ఒదిగే తొలి పువ్వును నేను, లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను. ఏ ఫలమాసించి ముత్తకోకిలా ఎలుగెట్టి పాడును, ఏ ఫలమాసించి మట్టకోకిలా ఎలుగెట్టి పాడును, ఏ వెలాసించి పూచే పువ్వు తావిని విరజిమ్మును, అవలిధి లేని ప్రతి అనుభూతికి, అవధి లేని ప్రతి అనుభూతికి ఆత్మానందమే పరమార్థం, లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను. ఏ సిరి కోరి పోతన్నా భాగవత సుధలు చిలికించెను, ఏ సిరి కోరి పోతన్నా భాగవత సుధలు చిలికించెను, ఏ నిధి కోరి త్యాగయ్యా రాగజల నిధులు పొంగించెను, రమణీయ కళావిష్కృతికి రసానందమే పరమార్థం, లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను, లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను, మధుర భారతి పద సన్నిధిలో దిగే దొలి పువ్వును నేను, ఒదిగే దొలి పువ్వును నేను, లలిత కళారాధనలో వెలిగే చిరుదివ్వెను నేను. థ్యాంక్ యూ.
Thank you for the lovely performances. So next up, as we said, we go with the sweet songs coming in as we're coming with the dessert. So today's theme of the performance we go with as the courses are going. Appetizers first, mains in the middle, and then we finish off with the desserts. So now we invite Dr. Sridhar Arani, Senior Consultant in Pediatrics and Pediatric Rheumatology, based at Leicester Children's Hospital. He has a hobby for Bollywood singing and yoga, and he's going to treat us with some wonderful old Bollywood classic songs. Dr. Sridhar Arani, please.
Good evening, ladies and gentlemen, and my dear friends. I hope you had a fabulous day and enjoying your dinner. And I think we saw today fantastic performances. We got plenty of in-house talent. We had mesmerizing performances from our violinist Akshay, as well as the saxophonist, that was my son Jatin. I'm not as talented as my son, but chauffeuring both my kids for some music lessons. Somehow I've started singing as a hobby. It's a nice de-stressing hobby with my busy pediatric world. I hope you enjoy some of those iconic Bollywood songs. Bear with me on this. This is a beautiful song from the movie Blackmail, picturized on Dharmendra and Rocky. Of course, Kishore Da is a singer. This is my attempt.
पल पल दिल के पास तुम रहती हो, पल पल दिल के पास तुम रहती हो। जीवन मीठी प्यार ये कहती हो, पल पल दिल के पास तुम रहती हो। हर शाम आंखों पर तेरा आंचल लहराए, हर रात यादों की बारात ले आए। मैं सांस लेता हूँ तेरी खुशबू आती है, एक महका महका सा पैगाम लाती है। मेरे दिल की धड़कन भी तेरे गीत गाती है, पल पल दिल के पास तुम रहती हो। कल तुझको देखा था मैंने अपने आंगन में, जैसे कह रही थी तुम मुझे बांध बंधन में।
सोचूंगी क्यों इतना मैं तुमसे प्यार करूं, तुम समझोगी दीवाना मैं भी इकरार करूं। दीवानों की ये बातें दीवाने जानते हैं, जो में क्या मजा है परवाने जानते हैं। तुम यूं ही जलाते रहना आकर ख्वाबों में, पल पल दिल के पास तुम रहती हो। जीवन मीठी प्यास ये कहती हो, पल पल दिल के पास आप रहते हैं।
Thank you once again. And now this is a song. It is also about friendship. Now this song from A Dosti is picturized in Sholay on Dharmendra and Amitabh Bachchan. This was picturized very close to a place in Bangalore where I come from. So I hope you like this song. And again, there are two singers. One is Kishore Kumar and Manna Day, R.D. Burman music.
अनिल चौहान कराओके।
This is dedicated to all the friends here. I'm sure there have been a lot of friends today.
दोस्ती हम नहीं तोड़ेंगे, तोड़ेंगे हम मगर तेरे साथ ना छोड़ेंगे। ये दोस्ती हम नहीं तोड़ेंगे, तोड़ेंगे हम मगर तेरे साथ ना छोड़ेंगे। अरे मेरी जी तेरी हाँ मेरी हाँ सुन ये मेरा यार, तेरा घम मेरा घम मेरी जान तेरी जान ऐसा तुम प्यार। जान में भी खेलेंगे तेरे लिए ले लेंगे, जान में भी खेलेंगे तेरे लिए ले लेंगे। सबसे दुश्मनी ये दोस्ती हम नहीं तोड़ेंगे, तोड़ेंगे हम मगर तेरे साथ ना छोड़ेंगे। dedicated to all the friends here. Thanks so much indeed.
Thank
Thank
you.
you.
Thank you so much, Dr. Sridhar. You've definitely taken us back to the 80s era. Am I right? Is it
Anil
80s?
Chauhan Karaoke.
Thank you. So today we are in the presence of some legends, and I would like to call first on stage Dr. Biju Simon. So Dr. Biju Simon is a consultant in geriatric medicine and acute medicine and specializes in orthogeriatrics. He's an enthusiast in nurturing and mentoring junior doctors, and he's a person who's been giving wings to the dreams of lots of international medical graduates in fulfilling their dreams to come to the UK and start a career, me being one of them. Welcome, Dr. Simon, my mentor, my guardian.
Thank you. Thank you for good words. Thank you, everyone, for coming, contributing, and helping us to make this a successful event. Of course, we achieved quite a lot during this day. But I thought I need to add 2 or 3 points. I don't take much time here. First thing, when I think about leadership, I look at to Mahabharata, I look at to Bible, and I get a lot of inspiration from them. So I'm going to tell you a small story. That story is Mahabharata, Kurukshetra battle is happening. Day 13, Dronacharya set up Chakravyuha and distracted Arjuna. So Arjuna went on a fight with someone else, and poor warrior Abhimanyu entered into Chakravyuha. Because Arjuna is distracted, Abhimanyu failed. Why I am saying this story here is, when juniors fail, that is responsibility of seniors. So when I sent Shubhangi to lead this conference, one thing I told her that you are my Abhimanyu, but this time Arjuna is not going to get distracted. So leadership all about supporting our youngsters. I started to take leadership role after 40 years of age. But I think if I had an opportunity at 20s, I would have performed better. So what I'm trying to do is buying 20 years plus to leadership and to lead our health service, to lead our country. So thank you, Shubhangi. Second story, probably you can look at my attire. This is, I'm from Kerala. Kerala, when you look at Kerala, there is a little bit paradox in Kerala. Kerala has got very high health outcomes. Yeah, that is advertisement. But we do have very low income. Low income, high health outcome. So what is the reason for that? Don Berwick was quizzed on it. So Don Berwick answered that for years, Kerala had matriarchal inheritance. So mother is important, female is important, female is leading the society. So female look after the community and community develops. So yesterday when I was having discussion with my colleagues, more of an EDA perspective, I told Colette Marshall and Kat Higgins, I thought I make them proud. I do have a team here. Could I request all my team to stand up, please? Or please come over to stage, please. My conference team, please. Did you forget, or are you in the influence of wine? Come on, please. Please, guys. Last Bridging of the Gap conference, Alice and John challenged BAPIO, saying that BAPIO leadership doesn't have much females. Look at this. How many females you do have? Yeah. No, we do have males as well, but we do have very fair, sizable proportion of females. I hope Colette Marshall and Kat Higgins be proud of me. Thank you. Next, my third point, what I'm going to say is, of course, I am standing here in limelight, and of course, I get opportunity to the stage, and Ramesh Mehta will be coming here and talking to you. Sadish Matthew will be dancing on the floor. All these things happens here. But how is it possible? It is possible because we sacrifice our time. That time belongs to our family, our children. So there is a very big sacrifice. And there are a lot of unsung heroes who doesn't come to the limelight. But I thought it is very important to recognize those heroes. And those heroes are the real heroes, in my opinion. So can I request Shubhangi to come and welcome to the stage.
A very good evening to one and all. Dr. Simon couldn't have spoken any words truer. I would now like to request Lakshmi to kindly hand over our tokens of gratitude to the following people, without whom this conference would not have been a success. They are the backbone of our leaders, of our team, of us. First and foremost, I would like to invite onto the stage Ms. Ritu Mehta. You truly are our backbone. Thank you, ma'am.
I didn't expect that. All of you work very hard. We are just behind you supporting. That's all. Thank you. Well done.
Thank you, ma'am. May I now request Lakshmi to please hand over a token of gratitude to Mrs. Molly Matthew.
Sorry, I didn't expect this. I didn't do anything this time. Thank you. Thank you.
Thank you, ma'am. I would now request Lakshmi to kindly hand over a token of gratitude to Mrs. Apulim Gajanan. Please, ma'am, come on stage. Thank you, ma'am. Please.
I've not done anything. Thank you. It's all behind me. No, not really. Thank you.
Thank you. Thank you. I would now request Lakshmi to kindly hand over a token of gratitude to our Chechi, Dr. Chitra Joseph. Thank you, ma'am.
Thank you. I was not expecting as well. Congratulations. It's a great team effort. Thank you.
Thank you. Most of our committee members most of all our parents really wanted to be here, but because of distance and being away in different countries, that was not possible. But there's one member in our team whose mom is here, and we'd like to invite her on our stage. Mrs. Anam Subaya, Praveen Subaya's mom. Please come on the stage, ma'am. I'd now request Lakshmi to kindly hand over a token of gratitude to ma'am. Thank you so much.
Thank you, everyone. Actually, we wanted to connect to all our members' family through Zoom, but unfortunately, technology cheated us. I am sorry. But anyway, and on behalf of this committee, I thank all the parents, all the near and dear of you, because you spent a lot of time to make it successful. Thank you so much to everyone. Thank you.
Wonderful and lovely speeches by Dr. Simon and wonderful words. Can we have a big round of applause for all the committee members again for the wonderful day we had today till now. Thank you, everyone. I'm privileged to be part of it as well. But without further ado, as we always know, BAPIO conferences or BAPIO events can't do with one person, and that's Mr. Mehta, Mr. Ramesh Mehta. He was the founding president of BAPIO in 1996 and has been at the helm of it. I've read about him after I've come here in the UK myself. I'm not a doctor from India, I'm from Bangladesh, but I've been helped by BAPIO when I was here during PLABs. He has been contributing to the benefit of not only Indian doctors, but also South Asian doctors and also other international medical graduate doctors. So that selfless help that he's provided has paved the path for many of us, irrespective of borders, irrespective of countries, religions. So thank you very much from a personal point of view. I'm not going to go to all his credentials. Everyone knows who he is. He's been given introductions again and again. He does not need one. But one thing I do notice about him, I've seen him before as an attendee of one of the programs, and this time as one of the organizers. I've seen him come as an active member or active organizer, the very first person to be here, and also coordinate everything till now. So Mr. Ramesh Mehta, would you please kindly come on stage to say a few words?
Biju, where are you? You know, I'm a bit worried about his lungi. When he was standing here, I think for Richard and John, the thing he's wearing at the bottom is called lungi. And I was worried if he is going to fall down. Biju, you've been brilliant. All these wonderful singers and musicians, the talent we have, I asked Richard, the chief executive of your trust, do you know them? And do you know that your staff has this talent? And he said, no, but how do you know? And I said, well, we have a network, and through network we know. But I'm going to tell you in a short while how this network is going to be from informal to formal network in the Leicester Hospital. But before I do that, could we give a big round of applause to the organizing committee of this conference? You know, one of the very special thing about this organizing committee, and Biju has mentioned that, and Biju has led that one, is they are all locally employed young doctors. And that shows the quality of leadership available to us for our future. Is that not fantastic? the way BAPIO organizes conferences and promotes the artistic talent and the dynamism amongst the young doctors, I am sure is the idea of brilliant future for BAPIO. Do you think that's right? No? Yeah, come on. So we will continue to do that. But very briefly, I need to mention how BAPIO has come to this stage of influence over 25 years of our life. It was launched in '96, and last year we had our Silver Jubilee celebrations. Really very interesting and amazing event. Today, BAPIO is at a stage where, whether it's Department of Health, whether it's National Health, NHS, whether it's General Medical Council, the BMA, Royal Colleges, everybody would stand up and listen to what we want to say. And the reason for that is because for all these 20 years, 25 years, not only we have promoted equality, diversity, and inclusion, but we have said that everything we do is how we can improve the patient care. The bottom line for us is the best patient care we can provide, and to do that, how we can improve our doctors' quality of providing the patient care. For the benefit, I must say that it has been a pleasure to be talking to John MacDonald, the chairman of the Leicester Hospital Trust, and Claire, the people's person here, who have sat throughout the conference taking notes and listening to everything we have said, showing their commitment to the good work that BAPIO has been doing. And John, I'm grateful to you for what you have offered to us to take this further to all the chairs and chief executives who are responsible for assisting into improving what we are doing. It's not only LEDs, not only SAS, not only trainees, but consultants, nurses, and all the staff. Unless the staff is happy, they cannot provide the best patient care. Coming back to BAPIO, over the years, we have now 13 divisions all over the country, including Scotland, Wales, and Northern Ireland. We have 10 specialty forums, including Young Doctors Forum, SAS Forum, Wellbeing Forum, and Patient and Staff Safety Forum. So all these forums, and you have seen what LED Forum has done, all our forums are as active as these ones. But even more importantly, we have now 5 branches. We call them arm's length bodies of BAPIO. And the reason for arm's length bodies of BAPIO is that they have independence to continue to progress the activities they want to do. The first one, which was started about 11 years ago, because the international medical graduates were not getting the support that they should be getting from established organizations. So Medical Defense Union was started by BAPIO 11 years ago. It has grown and is growing, and I'm glad that the medical director of the Medical Defense, it's my wine, is still here. Joydeep, can you please stand up? Dr. Grover is here. You will be pleased to know that the cases in the General Medical Council taken by MDS, Medical Defense Shield, have success rate of over 90%, as against MDU, MPS and others, 50%. Ladies and gentlemen, do you think MDS is doing a good job? And you know why? What is the difference? Not that the other establishment do not want to do their job properly, but the problem is their understanding of the background, the culture from which these international medical graduates come in, how they behave. They don't understand that and they can't represent them properly. Our second arm's length body, BAPIO Training Academy, which was started in 2014, is growing and growing and growing. It is not only helping training of doctors here, but internationally. It is also helping, supporting the doctors coming into the country and going back to their country of origin as international fellowship, under international fellowship program. I'm pleased that the executive director of BAPIO Training Academy is here. Parag, can you please stand up? Parag, Professor Singhal, that's Parag. Since he took over as the as executive director, the BAPIO Training Academy has grown hugely, and the number of doctors coming into the country. You know, BAPIO is not an agency. We are not a locum agency. We are a proper organization providing transparent support to the National Health Service as well as the health services in the countries from where the doctors come in. We look after the doctors properly. So that's our second arm's length body, BAPIO Training Academy. The third one, which was launched only 2 years ago, BAPIO Institute of Health Research. Unfortunately, Professor Indranil Chakravarti had to leave just now because he's driving back home. He's working tomorrow as consultant pulmonologist in St. George's in Tooting, London. Under the research activities, just in 2 years, we have done absolutely amazing work. And Tista is shaking her head there because she knows firsthand. We have been doing a lot of constructive, I call it a constructive work, and 3 important documents which have been produced in just 2 years, bridging the gap, showing how the journey of international medical graduates coming into as LED and growing up to consultant, and some of our doctors are becoming now not only medical directors but chief executives, how all this happened and where are the problems, where is the barrier for the progression. So that's Bridging the Gap document, which was produced 2 years ago in consultation with 150 different organizations and doctors, including organizations overseas, USA, Australia, Canada, and so on. Our second document, which was produced some time ago, was about dignity at work. Almost all the hospitals and the trust have policy on dignity at work to ensure that there is no bullying and harassment. However, we know that bullying and harassment goes on in every single hospital and in primary care in a big way, because there is no way to regulate that. So what we have decided to do, what we did actually, is to provide, to organize a document which is called Dignity at Work Standards. So we can now audit the work being done in different hospitals and see if that policy is working or not. And the third one, which was launched today, the LED Charter. This is just an example what sort of work is being done through BIHR, the BAPIO Institute of Health Research. We then have BAPIO Faculty of Leadership, And Professor Geeta Menon, who had to leave just now, who is also postgraduate dean for South London, and we are doing excellent work to promote leadership amongst not only young doctors, but all the doctors and other staff. And finally, we have the fifth arm's length body called BINA. And this is the result of the fact that there are almost 30,000 Indian nurses working in the NHS. And by nature, because of the cultural background, all these nurses are very polite, sincere, and they do not like to challenge. So they have been bullied, harassed, and not looked after properly. We had to do something. Since the launch, just over a year ago, BINA, and I think Claire knows about this, has progressed in a big way, and it is providing pastoral care to all the nurses, and not only nurses of Indian origin, but as we do, because we believe in diversity, equality, and inclusion, we include everyone, all the staff. So, in short, BAPIO has progressed in a big way. Now, the final thing about the networking, the informal networking. It has been my pleasure, as I have already said, to meet the who's who in Leicester Hospital Trust. So John, MacDonald, and Claire have been around, and I've been speaking to them all day, but Richard came in the evening, and Richard, as Chief Executive, thanks for joining us. BAPIO is going to very shortly announce formation of a formal unit, BAPIO unit in Leicester Hospital. It will be called BAPIO Leicester Unit, and we already have a chair and a mentor. You can guess who is the mentor. So Biju Simon is going to mentor. And Satya Joseph is, sorry? Satya, yeah. Where is she? Can you please, yeah. Thank you very much. So she is going to be the chair, consultant anesthetist in Leicester Hospital. Satya, most welcome and thank you very much. Before I finish, I must acknowledge one of a very important Leicester person who is present amongst us. Most of the youngsters will not recognize him, but those who have been here for a while will know Dr. Gautam Bodiwala. Dr. Bodiwala Dr. Bodiwala is known as the father of accident emergency in UK. He is the one who started accident emergency department in United Kingdom. He is the only doctor in whose name there is a branch in Leicester Hospital called Bodiwala Department of Accident and Emergency. Gautam Bhai, thank you for joining us. And his beautiful wife, Geeta Ben, who has been the backbone for him. I've got BAPIO chairman there, JS, to look after. Gautam Bhai. JS, can you just stand up as well? JS has been a big support for BAPIO all the while. JS. Dr. J.S. Bamra, CBE, has been BAPIO chairman and supporting all our work all the time. I must not forget I have to say this. Satish, I hope you don't mind. Maybe you just stand up for a while. Dr. Satish Matthew. He is known as agony aunt for all the doctors who are in difficulty. And over the last 25 years, he has given his very strong shoulders to anyone who is in difficulty, can ring him, and he really tries his best to help them. So with that one, I know we can't keep on talking too much because we need to go on dancing and so on. But before we do that, we have a very important person here called Richard, the Chief Executive of Leicester University Hospital of Leicester Foundation Trust. Richard, it's a great pleasure you are here. As I have been saying, I've been talking a lot to all the big guns in your hospital and you, and I hope that we will continue to have very collaborative effort. I have said to Claire, because when Claire said that she would like to look at the charter that we have developed and ensure that that charter is followed in this trust, I thought that your hospital could be a role model for the whole country. And to do that, we would be very keen to work with you in collaboration. May I request you to come and say a few words, please?
Thank you very much. Thank you. Good evening, everyone. Can you hear me okay? Yeah. It's an absolute delight to be here. I was feeling nervous enough about coming up here, and then we had all of the wonderful talent from Leicester Hospitals and beyond. So we had the dancing, the singing, the musical instruments. If I'd known that we were going to be doing that, I would have brought my guitar with me tonight. Is there a guitar in the room? Has anyone got a guitar? Thank God for that. Okay. Anyway, thank you for the opportunity to pull my trousers down, to say a few words tonight. Delighted to be here at the National Local Employed Doctors Conference for 2002. We've obviously got many colleagues here from Leicester Hospitals. We've also got many colleagues here who work in primary care in Leicester. But if you're not from Leicester, if this is your first time in Leicester, we'd like to welcome you to our wonderful city. It's incredibly diverse, it's a safe city, it's my home, it's my family's home. We're really proud to call Leicester our city. It's obviously at the centre of the UK, and we hope, as we've heard, we hope to be at the centre of the NHS for years to come. We know that the NHS is under unprecedented pressure at the moment. We've got an increasing number of people who want to receive care in the NHS who are waiting for care at the moment. We know that political expectations are increasing, and undoubtedly the workforce is very tired. Undeniably, we're in a difficult situation. The reality is quite possibly the next couple of years may well be even more difficult than the recent past. However, I personally, before coming here tonight, and certainly having been here for a couple of hours, I feel incredibly optimistic and hopeful about the future, and there are many reasons why I believe that the future will be better than the past. What are those reasons? So COVID has challenged our thinking, and it's enabled us to do things that 3 years ago we may not have believed were possible. You, everyone in this room, all of you in the NHS continues to make a difference to millions of people every day. And who knows how technology will change what we can do in the near future. I feel incredibly lucky to be a very small part of the NHS. And that's because I work with remarkable people, many of whom are in the room today. There is so much talent in this room, and as colleagues have said, at Leicester Hospitals, we need to harness that. We need to work with you to unlock your potential and to unlock the potential of the organisation. Over the last couple of years, as I say, it's been very difficult years. Over the last couple of years, it's emphasised to me the importance of teamwork. As we've heard, high quality, safe, sustainable care can only be delivered by teams, and we're reliant on teams. And teams, by their nature, are made up of a diverse range of clinical and non-clinical colleagues from a range of different backgrounds and countries.
Healthcare is about looking after everyone, and to provide high quality of care, we have to look after everyone who works in our organisations. Sadly, as we've heard tonight, and you would have heard during the day today, within multidisciplinary teams, particular groups sometimes get forgotten about. They're overlooked. They do not receive the recognition that they deserve. Opportunity does not present itself equally. One such group is the locally employed doctors, and despite them making up such a significant proportion of our workforce, these roles have traditionally been regarded as primarily service provision, and educational aspects and supervision for doctors within these posts has been patchy. I'm the Chief Executive at the University Hospitals of Leicester. I feel incredibly fortunate to be the Chief Executive here, and we know that at University Hospitals of Leicester the number of locally employed doctors is increasing. I believe at the last count we had 260 LED doctors, and these doctors are particularly employed in emergency care, respiratory, cardiology, musculoskeletal and specialist surgery amongst others. At Leicester Hospitals, we want to work in partnership with primary care. We want to work in partnership with our community services. We want to work in partnership with voluntary services. We want to be a force for good. And as we expand in partnership with others to work in other parts of healthcare, our reliance on locally employed doctors is only going to increase. Sadly, though, we know that the national surveys and research indicates this group of doctors experience more bullying, more complaints, feel less supported, and are less likely to get training posts. Within Leicester Hospitals, we know that the internal surveys also suggest that these doctors are less likely to recommend the trust as a place to work than doctors who are in training. We have to change this, and we can change this. At Leicester, we want to be recognised as a great place for all to receive care, and for this to happen, we need to be a great place for all to work. We have a lot of work to do, but I personally believe that the journey at Leicester Hospitals has already begun. I believe that it's beginning to feel like a different place to work, and it's beginning to feel like an even better place to receive care. Locally employed doctors in Leicester are an incredibly important group of colleagues. You have my word, you have the word of John, you have the word of Claire and others, that we will work tirelessly to ensure all are welcome in Leicester, that all are supported, including with their education and their supervision needs, and we want to retain and recruit the best possible talent in Leicester, and that certainly includes locally employed doctors. So before I conclude, can we just have a round of applause for our colleagues and our support from BAPIO, please? And one of the themes that we've been through tonight is about all of the immense amount of work that often goes on behind the scenes. So can we also have a round of applause for the chefs, for the waiters and for the waitresses who have been remarkable tonight. So I'd like to thank you for joining the conference today. I'd like to thank you for listening tonight. And most importantly, I'd like to thank everyone in this room individually for the difference that you make to our patients, for the difference that you make to your colleagues. You're all remarkable people. You're certainly exceptionally good at looking after patients and looking after colleagues. When you do that as intently as you do, the opportunity for you to look after yourself is going to be very slim. So please, it's so much easier said than done, but please take the opportunity to look after yourself. As I said, life is difficult at the moment, but I personally believe working with you, we have a huge opportunity to make a massive difference. And I think we should feel optimistic and hopeful and courageous about the future. The future will be better than the past. So thank you so much for your time, and I hope you enjoy the rest of the evening. Thank you. Cheers.
Thank you very much for all the insightful speeches, and it's good to know about the lovely initiative between BAPIO and the Leicester Hospital. So without further ado, we'll get back on with the culture segment again. We'll start with some songs again with Dr. Kumar and Dr. Anupama. I would like you to call you back on stage. They're coming here with a wonderful song that will definitely have an effect of stealing your heart right now. So you'll get the song when it started, yep?
Hello. This is the advantage to sing with a professional singer, so that my voice will be masked easily. Is that right? Unfortunately, we lost our queen, but today Dr. Biju Simon has made, still we have long live queens. Big round of applause to all the beautiful queens here in the auditorium. If I miss, make sure that you take it here.